2021. It is an honor to meet you again at IHOP 2021 conference. And we would like to start our today's first session, which is about virtual clinics. Please let us welcome Dr. Ghada Bawazir, our today's moderator. تفضل دكتور.
Assalamu alaikum rahmatullah. Sabah al-khair. Welcome everybody, those who are attending and those who are on the other side. Today we're going to discuss, or at least this session is going to cover the virtual clinics. And we all know that during the COVID-19, the concept of virtual clinic became more prominent, and I think that the COVID itself had expedited the acceptance of the virtual clinics as one of the essential model of care in our current times. And in order to shed the light more into the impact of virtual clinic and the experience in Saudi Arabia for such important aspect of care, we will have today two presenters, Dr. Khalifa Diab and Dr. Abdurrahman Shayban, in order to present their experience. And I will start with Dr. Khalifa Diab. Dr. Khalifa Diab is a consultant clinical pharmacist specialist at King Abdulaziz Medical City. He had a bachelor degree in sciences, degree in pharmacy from King Saud University, and he had a Saudi certificate in clinical pharmacy program. With all due respect, please welcome Dr. Khalifa Diab in order to present his first presentation. تفضل دكتور خليفة.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Ghada, for your nice presentation. Today I'm going to talk about our experience. We did actually study regarding the telepharmacy anticoagulation clinic and we assessed the patient's outcome. So this is the working team, the research team. It was led by Dr. Mahal Ammari. My objectives for this presentation, we'll talk about small introduction. I'll talk about the aim of our research. Sure. The aim of our research, what was our methodology, the result, discussion, then the conclusion. So anticoagulation control for patient taking vitamin K anticoagulants, it's really challenging because of high risk profile. So it is well established that clinical pharmacist-led anticoagulation clinic services, it's associated with superior anticoagulation control compared with physician-managed anticoagulation. So, and the most used measure to assess patient anticoagulation control is the INR and the time in therapeutic range. The INR, all of us know INR. The time in therapeutic range means the percentage of time during the study or during the treatment period where the INR was therapeutic. So the INR measures the stability, while the time in therapeutic range reflects the achievement of intensity of anticoagulation. So it is a preferred indicator to evaluate the anticoagulation quality as it affects the patient's outcome, such as stroke and mortality. So at King Abdulaziz Medical City, the anticoagulation is led totally by clinical pharmacists. We have 3 anticoagulation clinic, actually 4 anticoagulation clinic per week, 3 adults and 1 pediatric. And during the current COVID situations, a lot of measures were taken to assure continuity of patient care with the assurance of social distancing. So what we did that we converted our clinic from face-to-face to a virtual clinic. We hired a coordinator. A coordinator started to call the patient like 72 to 24 hours prior to the appointment to remind them to do their INR test. And telling them that they should not come to the clinic. We're gonna call them. So the patient was given the choice, either that he will do his INR at home or at a nearby hospital, or he come to the hospital in the lab and do the INR there. Then during the clinical pharmacist will call the patient, and it's like an interview and assess his INR result and discuss with him any interactions or evaluate his case. So this is basically what happened when we shifted to a virtual clinic. And for those patients who choose not to come to the hospital and take their INR in a nearby clinic or a nearby hospital, we provide them with a WhatsApp phone to send the INR result to us. So in either way, we have an INR result for the patient. Those who choose to come to the hospital and do INR, and we're going to call them next day, or those who did it in a nearby hospital and they send us the result through the WhatsApp. So our aim in this study was to evaluate the efficiency, how efficient this telepharmacy anticoagulation clinic, what was the cost effectiveness, and we also assess the patient satisfaction with the new modality. So it was conducted at King Abdulaziz Medical City in Riyadh. It was a prospective study conducted from March 15 to May 13, 2020. This is right away after the COVID situation began and the curfew. And we followed the patients up to 3 months. We included all adult patients who were intended to be treated for at least 3 months, for minimum 3 months for anticoagulation. We use a definition to assess how good is the anticoagulation control. It is done by Rosalind Dahl and colleagues. We define a good control if the time of the INR was therapeutic during at least 70% of the time during the study. And we consider that intermediate control if it was between 50 to 70%. And it was inadequate if the mean time was 50% of the time, the INR was 50% of the time less than therapeutic. And we also did a pharmacist satisfaction survey. We asked the patient who completed the anticoagulation clinic to fill our survey. And this survey was validated من ناحية اللغة أيضا من ناحية الcultural. And we got our approval from our IRB. Statistical analysis was performed using statistical software, SPSS, and integral consistency of the pharmacist satisfaction survey was assessed using Cronbach alpha coefficient, and it was acceptable because it was more than 0.7. So these are our demographics. We had 270 patients with a mean age 58. Female were 59% of the sample. The main comorbidities we encountered was hypertension and diabetes. Indication for anticoagulation was mainly AFib, almost 46%, followed by DVT 20%, and pulmonary embolism 40%. And patients were treated for a mean target INR of 2 to 3, mostly more than 91% of the time. So we had almost 59% of our INR was therapeutic during the study period, and the INR was therapeutic when about 57.8 of the time during the study period. For AFib patients, we had more control. 62% INR was therapeutic, and the time when therapeutic rate was also 62. While VTE patient, the INR was 54, and the time within therapeutic range was 49. So to say who was good and who was not good, almost 31% of our patients had a good therapeutic control or good anticoagulation control. and 20% of them were intermediate, and 49% had inadequate or poor anticoagulation control. When we go by indication, the AFib patient had the most therapeutic time and or a good control, almost 35.5%. Stroke, although they are small patients, but they had the better outcome. However, because AFib have a significant number, so we are concentrating on AFib and VTE. So AFib had 35% of the time where they were good control, and VTE almost 22% of the time. And regarding complication, we followed the patient for the complication up to 14 months, and 90% of the cases had no complications. We had minor bleeding like 3.7, major bleeding 2.9, and bruises 2.2. This is the patient satisfaction survey. This is the result. Almost 265 patients, they completed the survey without any missing responses. The overall component, or the overall satisfaction was good, 32 out of 40. The patients were really satisfied about the pharmacist, 23 out of 28. And the median, their satisfaction about the modality was 10 out of 12. But the survey is composed of 10 questions, 7 of them about the pharmacist, and 3 of them about the modality or about the setting itself. Regarding the cost, we did not find any significant cost reduction in the clinical pharmacist, only 11%. However, with the coagulate check or the point of care, we have significant cost, more than 70% of the patient. Instead of them coming to the clinic and do their INR at the clinic, they are going to the lab or doing it outside. Also, we had significant reduction of the nursing cost, more than 80%. And regarding the time, we used to need 10 to 15 minutes in order to interview a patient in a face-to-face clinic. This time reduced during the telepharmacy to 5 to 10 minutes. So we were able to see more patients, and also we can in case there is no a lot of patients coming to the clinic, we can take some of the pharmacists and use them in other areas. So it is like adjustment of work and more utilization of the clinical pharmacist. So this is the discussion of our result. We were lucky that we had a previous study in our hospital, and this is actually the strength of our study. We had a before study conducted in the face-to-face clinic, and they found that the mean INR was 59%. Comparing to us, it was also 59.39%. So it's really comparable. And most of 26 of their patients had a good control. Also, we had 31 of our patients with a good control. So actually, we are slightly better than what happened before. So this tells us that face-to-face is really comparable to telemedicine or telepharmacy module. It's very efficient to implement such a module. In another study where cardiologists followed the anticoagulation for patients for AFib and VTE, their mean TTR was 60%, and we had our mean TTR was 57.8%. So also we are not that far. They use a different definition to say patient has a good control. They use a cut of 50. So there is a lot of definitions for saying which one has a good control. We use the definition of 70 as a minimum, but they use their definition of 50%. So if we combine this category with this category, 20 plus 30%, we have more than 51% just to compare to them. So also we are still in the same level. We have the same results. In a study managed by clinical pharmacists, they compared face-to-face. This is just like our study. They compare face-to-face to telemedicine, and they find absolutely no difference between the telepharmacy or face-to-face. They had mean TTR with 68% compared to 69%. So this is also solidating our findings that telepharmacy is equivalent to face-to-face. Patients with AFib, we had a huge study, included more than 29,000 patients. There patients who had very good anticoagulation control were 44%. This is for AFib patient. And we had also 35.5%. So almost the same. We are close to them. And comparing even 19,000 patients with VTE, patients who had good control were 36% of the sample, and we have 22%. Imagine they have a huge number of patients for a longer duration, and we did it only in 270 patients in 3 months. So the last thing that I want to emphasize on that it is really not easy to get a good INR. It's not easy to have 100% INR. In a pooled analysis of 95 AFib study, therapeutic INR was found only 56% of the time. So it's considered achievement if you reach such a goal. While the TTR was 61% of the time. Comparing to our result, we had 52.9% INR was therapeutic, and it was 57% or 58% during the time was therapeutic. So our study was limited by it is only one tertiary center located in one location, with short duration, only 3 months. Patient compliance was an issue. Some patients, they did not respond to our coordinator calls. Also, they did not respond to the clinical pharmacist when they called them to discuss with them their case or their situation. Some patients, they were not compliant in monitoring. They did not do their INR. And some of the patients, they did not were compliant with their medications. If you remember, we had a nationwide problem with the local delivery services where patients lost their medication. Medication did not reach to them on that time. So this has also affected our result. Patients were left out of warfarin for like weeks sometimes. So that's why we had some result with subtherapeutic INR. Also, patients with tight INR, like 2 to 2.5 or 2.5 to 3, were challenging to achieve. And we did not do any analysis regarding the comorbidity and their effect on our result. We did not do any analysis on the effect of lifestyle, drug-drug interaction, or drug-food interaction on the INR. So as a conclusion, this is the first study to assess the telepharmacy anticoagulation clinic efficiency and patient satisfaction in Saudi Arabia during the COVID-19 pandemic. This type of consultation was as effective as face-to-face consultation. The study also highlighted that though that reduction in the costs were not that high, there was a significant increase in resource, meaning clinical pharmacist utilization as a result of this model. The adaptation of telepharmacy resulted in time saving for the clinical pharmacists who can be utilized in other many improvement projects in adult ambulatory clinic to ensure the delivery of better quality and safe patient care. Thank you so much for your listening. If you have any question, I'll be more than happy to answer.
Shukran, Dr. Khalifa, for the very nice presentation and the activity that you did in the anticoagulation clinic. Our next speaker will be Dr. Abdurrahman Shayban. Dr. Abdurrahman Shayban is a clinical pharmacist at King Faisal Medical City for Southern Region. Welcome, Dr. Abdurrahman. Dr. Abdurrahman is going to talk to us about patient education across the
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I want to thank the organized committee for this invitation. Today I will speak about the medication counseling clinic. I will give the overview about the medication counseling clinic and how it is work, and the type of medication counseling clinic that we provide, and also a part of our presentation process and outcome measurement, and including the patient satisfaction. What is the medication counseling clinic? It is to introduce the medication information either orally and by written form to the patient or to the representative of the patient on direction of use and advice on side effects or precautions, and also direction the patient to the appropriate storage and diet and lifestyle modifications. What is the objective of the patient counseling? It is important that to understand a patient, to understand their illness and their case, and what is the role of the medication for their illness, and that would improve the medication compliance with the patient. Also, that would improve and more effective the drug treatment, and also to reduce incidence of adverse drug effect. Patients with a chronic disease, when they follow their treatment plan, that would improve the quality of life for their and enhance image of the pharmacist and their profession. What is the method of providing the service? Choosing appropriate service providing method, either written or verbal. Condition, hearing and vision difficulties, and also we deal with low level of education and language issue. We have to use a sample language and use the plain language, and for sure non-medical, to ensure the patient understand what the counseling that about. Also, there is a skill, communication skill. It's important to the eye communication and use effective communication such as body language and non-verbal communication. Use a cautionary and advisory label that promotes the oral information as a card and medication leaflet. Now we will move the criteria of patient eligible to refer to this clinic. Any patient who has one or many of these medical conditions, like diabetic patient and hypertensive patient with a stroke or asthma or neurological condition, and such on. Also, any patient on more than 5 medication or more than 10 doses per day, that's eligible patient to refer to this clinic. Any patient has a problem with managing medication-related devices, like asthmatic patient, we have to ensure the patient use the devices by correct way. Number 4, any patient with narrow therapeutic index drug, like patient on warfarin and requiring therapeutic monitoring. Also, if the patient not adhere to their medication, and this a big problem with patient compliance for a better, more effective for this medication. What is the step during the patient counseling? Preparing before the session by reading the patient file or patient discharge summary or report to take a background about the patient medical history. Then opening the session, counseling content will be the name of description and medication, and the reason why this has been prescribed to this and how it will work, how to take the medication properly, and expect the duration of treatment. And we can see that with a patient with newly diagnosed with chronic disease, some of the patient when they get well, they just stop their medication. And also with short course of duration, like antibiotics. Some of my patients, they just take their medication for a couple of days, then when they get well, they just stop this medication. Also expect benefit from the treatment. Possible adverse effect that may happen or not. Possible auditory interaction. Advice on correct and proper storage. What to do if the dose is missed. And we can see with some of the patients, when they miss their dose, they just duplicate the dose and they thought to replace the missing dose. And this, for sure, it's a mistake. They just have to forget the missing dose when they will be close to the next dose, and they take the next dose at the same time. At the end, closing the session with the patient by asking the patient if the patient has any more question or need any inquiries, or sometimes I've asked the patient to replay the main point that I've explained to him to ensure that patient understand that counseling. Now we'll move to the type of clinics that we provide. We start with the hospital clinic, referral from the OPD pharmacy and the physician clinic. And during the pandemic, we get to start to a virtual clinic throughout the FaceTime and WhatsApp and some of applications like Zoom and Teams to contact the patient through that application. And now, after the ANAT virtual clinic and the ANAT platform has been released, we're trying to move this official and approval platform, and that will be throughout the Sahati application. There is some method we trying to make this ANAT virtual clinic effective by telling the patient will receive the message, including the link of the appointment and including the YouTube to explain to the patient how will get access to this virtual clinic. As much as we can, we will ask the patient about the best time to contact to make this clinic more effective. Also, the best contact number. Also, we're trying to ask the patient to provide one of their relatives if they don't familiar with their medication, and some patients don't know how to get access to this virtual clinic. This ANAT virtual clinic, we've seen that it's more effective, especially with the patient who receives their medication with Saudi Post. We gather their name. The patient met the criteria of patient counseling. We gather their name. Then we make that in schedule and contact that patient. Now we will move to the program timeline. In 2017, this service was manual and starting the training course under the supervision of General Administration of Pharmaceutical Care, and we will highlight the name of the person who was behind us at this time, Dr. Rana Al-Mustanir. Then in 2018 and 2019, with Dr. Rasha Al-Zahrani, a medication counseling clinic policy has been released, and training course, and it was established about 17 clinic was established all through the kingdom, and thus those clinics has served about 6,000 patients. In 2020 and 2021, process and outcome measurement electronic form with Dr. Huda and Dr. Ahmed Al-Saleh under the supervision of General Administration of Pharmaceutical Care, and that electronic form was include a number of clinic and patient demography and information, reason for referral, type of information service delivered to the patient, type of clinic, if it's virtual or ANAT virtual clinic or hospital clinic, source of referral, clinic or department, And that electronic form was including the contact number to measure the patient satisfaction. We can see here in this slide the number of clinics, of medication counseling clinic, all through the kingdom, and we suspect the work hours per week, at least 4 hours per week, and per patient 30 minutes per patient, which means at least between 24 to 32 patients per month, and at least between 72 to 96 patients per quarter. Now we will move to the percent of pharmacy care clinic beneficiary per type of a clinic per quarter, starting by the first quarter of this year. And we can see here the ANAT virtual clinic was 2%, and the hospital clinic was about 76%, and the virtual clinic through the WhatsApp and the FaceTime and other application was about 22%. In the next quarter, second quarter of 2021, ANAT virtual clinic increased to 6%, and the hospital clinic decreased to 67%, and the virtual clinic was about 27%. In the third quarter of 2021, the ANAT virtual clinic increased to 9%, and that's what we aim for, to move all virtual clinic to this official virtual clinic. And the hospital clinic in the third quarter was 67%, and the virtual clinic decreased from the previous quarter to 24%. We can see here in this slide the age distribution from the beginning of this year till September 2021. The major patient who visit this clinic, their age was between 50 to 64 years old, and the next percent, 25%, their age was between 35 to 49 years old, and we can see the distribution age between this chart. Percent of pharmacy care clinic inquiries by the reason of for counseling. The majority of the patient who visit this clinic, patient who has a chronic disease, and the percent of that patient was about 53%. And then after that, patient on a new medication, and the percent of that, 34%. Also, patient with drug interaction, and that was with about 26%. Source of referral from the OPD pharmacy was about 75%, and it has the majority of the patient referral from the dispensing window, and the percent of the referring from the physician clinic was only about 24%. And we would encourage our doctors on all clinics, if the patient meets the criteria, to refer this patient to the medication counseling clinic to complete their counseling. Percent of pharmacy clinic inquiries by item discussed. We suspect at least between 4 to 5 items of these items discussed with the patient during the counseling, and the high percent was with the medication name and indication and dose, and it has a percent of 90%. Coming after that, the duration of the therapy, it has around 73%. Coming after that, step to taken of missed dose, and it was about 51%. Last slide about the measurement of patient satisfaction. We can see here in the schedule لطف واهتمام الصيدلي حاز على ما يقارب 87% من رضا المرضى. أن كان هذا في الكوارتر الثالث من هذه السنة 2021. شرح الصيدلي لتعليمات استخدام الأدوية ودواعي الاستخدام كان حاز على نسبة 84.46% من رضا المرضى. شرح طرق التواصل في حال وجود أي استفسارات أو تساؤلات من الاستخدامات الأدوية كان ما يقارب 87 إلى 79 نسبتها. And I would encourage all clinic provider to direct patient if they close their contact number of the clinic to direct patient at least to 937 to at least to take their counseling or their inquiries. التقييم العام للاستشارة الدوائية قد حاز على 82.97%. احتمالية أن تصاب بخدمة الاستشارة الدوائية الآخرين 82.14%. And we can see here the overall patient satisfaction all through the quarter. In the third quarter of 2021 and fourth quarter 2020, in the third quarter of 2022 and fourth quarter 2020, it was about 85%. On the first quarter of this year, 2021, dropped to 79%, and in the second quarter of 2021, it was about 82%. And that's all about my presentation, and thank you for your attention.
Shukran, Dr. Abdurrahman. We're going to have the speakers now on the stage to have your questions. Dr. Khalifa. Can you have any questions from the audience?
صباح الخير يعطيكم العافية. Thank you for this great presentations. My first question, Dr. Khalifa. This study, Doctor, or the National Guard experience with virtual clinic, as you presented, was done during the pandemic COVID-19 situation. Are you going, or is there any kind of recommendation to continue the virtual clinics and expand in the virtual clinics in the National Guard as well? Or it was just only limited for a period of time and there is no any plan to go with a future expansion for the clinic?
Thank you, Doctor, for the question. Actually, the success of the virtual clinics in general and National Guard allowed for the continuation. Now, most of our clinics converted to virtual, unless the patient really need to come to the hospital. We found it was easier, it was more efficient, and it's cost saving. Now we are moving more and more to more virtual clinics, not only in anticoagulation, mostly in all the outpatient clinics.
Shukran, thank you. Dr. Abdurrahman, I have a question. يقولوا زكاة العلم نشره. All of the data that you talked about in your presentation, excellent data. When can we expect to see a publication, a research published with this regards?
Thank you, Dr. Muhammad, for this question. Inshallah, in next year or in the next time, inshallah, we'll try to work on it to arrange this data for publication, and it is a huge data for sure, and it's worth to publish. But inshallah, in next time, inshallah.
What?
To see the beneficial benefit of this data and how it is work with the patient satisfaction and how it is work with the medication counseling clinic, and it will reflect the benefit of medication counseling clinic, and it will show for sure the benefit with the patient.
شكرا. تفضل.
السلام عليكم صباح الخير. يعطيك العافية دكتور عبد الرحمن. دكتور خليفة, يمكن one of my questions إنه يعني what was or were the greatest challenge in establishing this service at your institution? والسؤال الثاني يعني
السؤال الأول معلش.
السؤال الأول يعني what was or were يعني إذا كان في أكثر من واحد challenges يعني in establishing this service في الانستتيوشن حقكم. يمكن يكون السؤال الثاني إنه الكونتينيوتي حق الكونسلنج بعد البيشنت ما يمشي من عندك. يعني is there any specific service أو strategy for the patient to come back and ask a question if they don't have an appointment, ولا في line service عليها, ولا they have to have an appointment for another يعني consultation?
You mean if they have further questions
Yes.
other than the later on after they finish the clinic
Exactly.
itself? Okay.
To be honest, the most challenges with this clinic on how to take the patient trust and how to reflect and explain to the patient very well, trying to find out the correct answer always, and if you don't find that, how to take the contact number of the patient and provide the correct answer for this patient. The other question, some of the patient, we need to see this patient if the patient has, for example, some side effect, and that side effect coming because the incorrect use of the medication. Some of medication before the meal, some of the medication after meal, and that's the main things. If the patient is stable and with the green zone, as we can see, we cannot schedule patient soon unless there is a new medication, unless there is a changes in his medication. So we will schedule a patient depending on his situation.
Thank you very much.
Thank you.
تفضل.
السلام عليكم.
عليكم السلام.
صباح الخير جميعا. يعطيكم العافية دكتور.
الله يعافيك.
دكتور عبد الرحمن for your comprehensive presentation. I have two questions for Dr. Khalifa and one question for Dr. Abdul Rahman. Dr. Khalifa, when you talk about your experience with the anticoagulation clinic and National Guard, and you talk about there is no substantial impact in terms of need for clinical pharmacists to run the service. Can you give me more information how the virtual clinic not reducing the need for clinical pharmacists to run the service?
I'm sorry, I did not get your question. Can you repeat?
ذكرت دكتور ان الموضوع اللي هو الامباكت كوست على من ناحيه اللي هو الساعات اتوقع يحتاجونها الكلينيكال فارماسيست. فكيف ما قلت مقارنه بالمواعيد الحضوريه للمستشفى؟
الكوست كان في cost reduction. ما كان there was a cost reduction. It was 11%, but it's not that big. يعني if you compare it to the nursing or to the coagulo check, it was not that big. The only يعني the factor that we noticed, the time was يعني huge factor. الكلينيكال فارماسي تقريبا cost 200 ريال per one patient. So with the patient reduction due to the care view, we did not see that much of patient compared to before. Although that in the beginning it was higher number, but with the time everything was reduced. يعني الكلينيك was more organized actually with the tele pharmacy. We used to have patients coming all the time, walk in and scheduled. Now with the telepharmacy, everything is really organized. So certain number of patients only will come to the clinic, or those only who need to come. Otherwise, those who are scheduled will be the one who to call. So in regard to costs, it was not that big issue, but the time was really significant for us. The patient before, they used to come to the clinic to do their coagulo check in the clinic. So one strip in the clinic costs us like 14 riyals. So imagine that you are seeing 50 patients during one clinic, so multiplying 14, this is a huge number. With the telemedicine modality, patients now they are moving to the lab or they are doing outside King Abdulaziz Medical City. So this is where we saw really a huge cost reduction. Also the nursing, instead of each nurse taking the patient to do the point of care, they are not facing patient like before. So this is also a cost reduction. But the pharmacists, they are there, either telemedicine or face-to-face. So 5 clinical pharmacists or 4 clinical pharmacists, they are there all the time.
طيب النقطة الثانية يا دكتور ما أدري كنتوا بحثتوا موضوع اللي هو الكوست افكتفنس في مسألة العيادة الافتراضية، لكن في من ضمن الشغلات اللي هي أنا لاحظتها وموجودة يمكن في كل المستشفيات مسألة إن احنا نسوي كلوزد لللوب للسيرفيس تكون فول 100% فيرتشوال كلينيك، ومن ضمن المعوقات اللي موجودة فيها مسألة هل نقدر نوفر للمريض نفس الجلوكو شيك اللي يكون عندنا INR home check. Did you study it from this perspective? If we provide it to the patient, would be as the service cost effective or not?
From what I know, the machine that the patient can, I have one of my patients. She bought, because of COVID, she was so afraid. She bought a machine for herself. The machine only cost her 6,000 riyal, and the strips, they are really costly. So this is really not cost effective. The machine is really costly for the patient. So this is not a cost effective approach.
دكتور عبد الرحمن بخصوص اللي هو الميديكيشن كونسلتنج، يعني انا اؤيد نقطه الدكتور الشناوي من ناحيه اللي هو الببليكيشن اوف ذس بيبر، لكن اللي لاحظته في الدراسه القياسات اللي صارت كلها نسميها اللي هو performance KPI about your performance. If there is any clinical outcomes measured from this clinic, for example, reduce number of adverse events reported by the patient, reduce admission to the hospital. Satisfaction, maybe it's measured already, like in clinical outcomes. Are you planning or did you do it in your study here?
Thank you for your question. Until now, there is no thought about this, but it's a good idea to add that on the KPIs or on our study. It will work to discuss that and to reflect that as well.
Okay, I have a couple of questions. Both of you can answer those questions. واحد له علاقة بالدليفري والثاني له علاقة بالdocumentation. So بالنسبة للدليفري, allow me to speak in Arabic just to make it more easier for everybody. بالنسبة للدليفري of the service itself, was it audio, was it video, was it a mix of both? What was the experience for both of you for the virtual clinic?
For us, it was telephone.
Telephone call.
No telephone. It was called telepharmacy. Now the hospital is moving toward video conference.
Okay.
So we are moving to this stage in the hospital.
And Dr.
Similar to this, we start by telephone and WhatsApp, and now we will move with the virtual clinic by phone.
Okay, and that's very interesting because one of the issues with telemedicine and virtual pharmacy, virtual clinic in general, is the confidentiality issues of the patient. So how would you go about this confidentiality? I know that the Saudi Council, Health Council, they have certain regulation for telemedicine and the delivery of telemedicine. So what are the process that you have in order to involve the patient in the virtual clinic? Do you have their consent? Do you have any issues regarding the confidentiality issues? So how do you go about these things in terms of delivering the clinic?
Upon the establishment of the new service that we are going to establish now, or actually about to already started, يعني personnel from علاقات المرضى, they're going to call the patient and they're going to tell them that such and such is going to happen. A physician is going to call you or a doctor is going to call you to discuss your case. Are you willing to go with this approach or not?
So you can send the patient.
Yes. If they are willing, we're going to go for it. If not, we're going to go with the old plan telepharmacy. Besides, not everybody are familiar with the new iPhones or something. We have a lot of patients who are elderly. They are not able to use the
little bit different, and maybe just for legal issues and regulatory issues, would that be something that's documented? يعني توثقوا أو تكتبوا إنه والله هذه this patient note is actually from a virtual clinic, so there's a code for virtual visit rather than a face-to-face visit. Do you have that in your documentation?
You mean there is a code in the
system, patient file? Yes.
No, actually, document that by manual virtual clinic, and then we start writing our note.
But you cannot audit that.
If a patient came to the clinic as walking or something.
But can you audit that in order to see
with the new system
issues?
now we're gonna audit that.
Okay.
But before there was no auditing there. But now there will be a recording, and if there is any text in between the patient and the clinical or the physician, everything will be recorded.
For us, and during using the virtual anatomy clinic, there is a part of the meeting the patient and what diagnosis and what our plan for this patient. And also there is a selection of patient case.
Okay.
So it's documented through the anatomy virtual clinic. Okay. And about the confidentiality, using the virtual anatomy clinic, there is a selection of using the camera or video or just only through the the voice. So also using the closed room during our counseling, eliminate all distractions, trying to be professional as much as we can. So that's about the patient. If the patient needs to attend, that's up to him. We always will be there.
But what was the most important patient satisfaction points with the virtual clinic in general?
From my side, I've seen most of the patients satisfied about this patient. Some of the patients coming from the long distance, so they just provide their medication, whatever were there at home, and they just attend this clinic and listen and asking about their medication. So also I've covered the anticoagulant clinic virtual. Some of the patients just to provide the INR and that just provide this test for me and take their direction and document that in their file as well in our center. So that's
the convenience.
Most of them, some of them, to be honest, don't attend, and we don't know if they have a problem or just not feel good with this new service. So most of them they are satisfied.
دكتور خليفة.
مثل ما قال دكتور عبد الرحمن يعني خاصة المرضى اللي يجون من بعيد. We have patients coming only from Hail or from Jizan just for the clinic. They buy a ticket and they come to the hospital, visit the clinic, and then go back. So this is really costly for them. So they really appreciate having such a service. So this is the main satisfaction that we found.
Any other questions from the audience? Okay, thank you very much to Khalifa, Dr. Abdul Rahman, for the very nice experiences that you have. And I think virtual clinics are going to be on the rise because it's very cost effective, as you mentioned, and it will reach a lot of patients all through the kingdom that we know that transportation, access of care is going to be even higher with that. Thank you all for your listening, and I wish you a very good conference. Thank you.
Now, I'd like to invite Dr. Mohammed Shinawi to thank our speakers. Dr. Khalifa Diab. دكتور عبد الرحمن الشيبان. دكتور غادة باوزير. Dear audience, before proceeding to our next session, we would like to give you a small gift. We will randomly select one of you to get the gift. So let us see who's the winner. And please stay tuned, there will be 2 more gifts. By now, we would like to proceed to our next session, which is about healthcare medications. And now, I'd like to invite and welcome Dr. Abu Bakr Amer to be our moderator for this session.
Assalamu alaikum everyone, good morning. صراحة I'm very happy to be here among you. It's a pleasure and honor to be any part of this great event. Please allow me to introduce myself. My name is Abu Bakr Amar, I'm your colleague. I'm a clinical pharmacist and the head of Scientific and Staff Development Unit at King Saud Medical City in Riyadh here. I'll be having the pleasure, an absolute great pleasure of introducing our next distinguished speakers for this session, session number 8 of this great conference. We're going to hear about home health care, and we're going to start with our Dr. Amal Al-Najjar. She's the Drug and Poison Information Center Supervisor at the Security Force Hospital in Riyadh. Dr. Najjar received her bachelor degree in pharmaceutical science from King Saud University, followed by Master of Clinical Research from Liverpool University in England. She then was awarded a Master in Forensics Toxicology from Naif Arab Security Science University in 2017. So please everyone join me in welcoming Dr. Amal al-Najjar.
Bismillah ar-Rahman ar-Rahim. Alhamdulillah wa salatu wa salam ala Rasulillah. It's a pleasure to be among you in this event, which is very distinguished event, and to be among this nice gathering of pharmacists. Thank you, Mr. Chairman, for the introduction. Before starting talking about the role of pharmacists in home health care, why we are concerned about home health care? Because it's the reality which reflects the health care that we are providing to our society. Remember when we talk about the studies and clinical designs, when we talk about clinical setting for a study, we consider the ideal settlement or the ideal set for any study. And that's why when we get the results of this study, we like to have the real world data in order to test really the effectiveness of the medication among our population. Same, when the patients are sitting in a hospital, they are facing all the care that can be given to them. In another word, we consider it like the ideal setting for them. But after giving them the consultations, the medications, and they go to their home, this is the reality. How do they practice using their medication? This is what we want to test. This is, the process that we want to test, its outcome, which comes to us in the hospital. In case that we wanted to adjust their medication, we want to change their medication, we have to know really whether they are using this medication properly and they are getting, the optimum benefit of this, or there is something to be corrected. Our objectives in this presentation is just to define the role of pharmacists in providing pharmaceutical care in home setting, explain the significance of such service provided by the pharmacist, and list distinguished examples on this practice, and describe the need for pharmacists and pharmacy students also to be involved in this healthcare, and identify the opportunities and challenges that face the pharmacists when they really, practice such service in home setting. This is like a motivation slides that I have it for the pharmacist. There is a scholarly abbreviation for pharmacists, and they consider, pharmacist is like a sign for patience, honesty, alertness, research, motivator, administrator, gorgeous, intelligence, studious, and thinker. And also scope of pharmacists, they consider pharmacists reflects a very, distinguished picture to the society. Since they are working as artists, they are designing the drug dosage form. They are like lawyers. They have their fair knowledge of law and legislation about the drug. They are also considered as engineers because they have sound technical knowledge, and entrepreneur with sound knowledge of management, accounting, marketing, and counseling. And we can see this from all, private sector and company perspective. And health professional having their fair knowledge regarding the health. As introduction, we know that over the past 4 decades, the role of pharmacists evolved from medicine suppliers toward that of a provider of a service and information. And finally, they became participating in the treatment process or with the treatment management team. Also, they had played a very traditional role in community pharmacy, and we could see this in the previous years. Today, they are reaching practicing as home care providers or home health care providers among very, very well differentiated healthcare team. What was the idea behind home health care? The idea emerged from the older or the geriatric patients who like to be at their home or who are originally home-bounded patients because of their diseases. And patients who utilize home care service are often senior, as we mentioned, with multiple medical conditions and complex medication regimens, placing them at risk of adverse medication-related events at their homes. That's why they need service to be intervening their life and fixing it. And also the recent circumstances locked down patients and even the healthcare providers, as we saw in the pandemic. With the continuously expanding scope of healthcare service, pharmacists can provide a wide array of home-based clinical service. Because at the beginning, when we said that we need the pharmacists to participate in home healthcare setting, they said, what will the pharmacists do? The medication is prescribed, the label is written, counseling is provided to the patient, and the rule is finished. No need to expand the team and to have a big number of personnel entering the home of the patients, especially for certain setting or certain culture that they don't also welcome a huge number of patients entering for such homes. Okay, for instance, as we used to know that pharmacists are able to administer drugs by injection, there are certain pharmacists who have courses in this and prescribe medication, and also they can order laboratory tests. This depends on the organization or in the country and their legalization if they do permit this. Medication-related problem, as all of us know, they are common among home care patients who take many medication, who are polypharmacy patients, and they have mixed or complex medical conditions that you need to adjust every medication according to the disease status of the patient, or even you have to check every medication interacting with the other. Moreover, for our culture, we have to check the medication interaction with food or even with herbal remedies that the patient take. We found that some patients, they are a little bit alerted towards medication. They might come and ask you, or they might call you and ask you, is there any drug-drug interaction between those medications? But they will never ask you if there is any drug-herb interaction, because they do believe herbs are natural and there is no harm can emerge from herbs if they are interacting with medication. And this is very, dangerous area. That's why home-based pharmacy care, they can investigate this. Sometimes even if the patient wants to ask you, he does not recognize the scientific name of the herb in order to ask you about it, and then you can't clue out what is the drug interaction. By seeing these herbs or by acquiring them, you can either identify the herb through several tools, or you can request for herb analysis in order to know the active ingredients embedded in this herb and to discover the drug interaction. As we said, pharmacist, as a member of home care team, he can mitigate, he can reduce the medication-related problems, which always can imply under either indication, or he can correct any, improper indication of certain medication. He can clarify the effectiveness of the medication and why there is, under dosage, and that's why there is less of effectiveness. He can elaborate in the safety and he can encourage the patient compliance. Despite increased effort to educate and ensure patients and families to understand all information provided about medication, especially on discharge setting, we can see that the discharge instruction can be complicated and confusing for the patient who is with a chronic illness and their families. And for our culture, we notice that when we go for counseling the patients for the medication, especially if we get a little bit late and the patient is at discharge and he's just waiting for the pharmacist to come and provide him with the counseling, he just does not concentrate while you are providing the counseling. He just wants to get his medication quickly and just run to the home. And that's why they don't focus on the instruction that you're giving. But when they reach home, they start the dilemma. I don't recall what they said. Yes, information is written in the label. I might be ignorant and can't read the label, or I can't remember certain texts that the pharmacist provided while I am discharged. And oftentimes for this population, multiple drugs are prescribed to manage their health, and in turn this leads to higher risk of errors. If there is more medication, then the tendency of errors is more. There is a study saying that subjected to home setting, only 8% of those patients who received the service were readmitted within 30 days. However, the other group who did not receive the service, around 16 to 17% of them were readmitted. Okay, when we would just want to talk on the expected role of pharmacists to be provided while serving as home health care personnel. There are various repetitions in home pharmacy service that have been described in the literature, but there is a limited information about the real practice. What does the pharmacist face? And what are the interaction between the patient and the pharmacist themselves? What are the things that the patient needs? What are the points that we have to stress in? What are the changes that we have to do in the training, curriculum for our pharmacists who reach patients at their home? Okay, pharmacists can provide consultative services, and consultative services that need the pharmacist to be prepared before he goes to the patients, because we heard from several teams that we assigned for home service that when they go there, they find that there are new medications that they have never come across, and they have to dig in their mobiles to try to find information for the patient at the same time, and they receive statements of the patient. I can't dig in my mobile and find the information. I thought that you know it before. That's why before you go to the home to provide this consultative service, you have to be aware a little bit of the medication that the patient takes. Just track the patient record or medical record and see what medication they're saying. Go to the database that you have and read all the or the leaflets about the medication that should be provided to the patient, because it acquires statements in simple words that you can disseminate the terminology for the patient, because patient won't understand the complicated terms that we usually use. As a consultant home care, pharmacists can collaborate with other home care health professionals in order to make recommendations, because being a member among the other healthcare team, they can advise you that you need to visit this patient. He has information about his medication, or he needs your visits. There is a medication related issues that you have to visit. This can manage your time and save it as well. And based on data from initial consultation and home visit, pharmacists can also provide a variety of clinical service, like ordering lab tests, especially for homebound patients who cannot visit the hospital so frequent, prescribing and describing medication, and facilitating seamless care as patient transition between inpatient or outpatient setting, and so on. Additionally, pharmacists can be heavily involved in providing patient education, as we mentioned, collaborating, as we mentioned, with other healthcare providers in arranging referrals to other consultants when needed. Also, they can play a great role in optimizing therapy for older patients, for female patients, because they have certain situation with their hormones and their contraceptives and hormonal medication that they're using, for patients taking polypharmacy also as well. Engaging with the patient in their home enables pharmacists to assist patient use compliance, because so many healthcare providers got tricked by the patient when they reach the hospital. They manage the number of tablets that they have to bring to the physician in order to fool them that they were compliant with the medication. But reaching their home, you can discover the truth. In the patient's home, pharmacist can help prevent medication errors, because he can see the reality and he can understand from the attendees at home, how does the patient take his medication? Is he compliant? Is he take it as instructed or not? Home care pharmacists serve as critical role as a liaison at the transition of care, as we said, between hospital and home. For patients recently discharged from the hospital, as we mentioned, home care pharmacists can reinforce medication teaching. He got discharged, he reached his home, and now nobody can give him the information. That's why, and he faced a difficulty of taking his medication. He experienced this difficulty. Now he will listen to you and he will listen carefully. Evaluate a change in medication therapy. He can discover if the patient is taking this tablet once, twice, thrice, because patient would say, I took it 3 times daily, then I found no advantage. 1 time is sufficient. Some patient, they might take it in less frequency, because they want to save the quantity they have. They do feel that they are not that sick to take the complete or the full regimen. They can identify if there is a need for compliance packaging. Some patients, they need to have their medication packaged in certain counter or in certain device to remind them that they took the dose, or to alarm them, or certain things like this. Home care pharmacists also involved in ordering in-home lab collections, as we said, for homebound patients. And they have a role in addressing the ongoing need for patient education. Some patients, they need ongoing needs. Certain medication, they need gradual increment or gradual decrement. Some medication, they need to take certain type of medication as a loading, and then you have to change it to another dosage form. All these needs continuous following. Integration into home care team allow pharmacists to be involved in the care of medically complex patients who would benefit from evaluation of their medication therapies. Sometimes you can't, as a pharmacist alone, to evaluate the medical status of the patient. You need to be engaged in comprehensive medical team. Connection with multiple home healthcare professionals facilitates collaborate care and ensures patients have access to appropriate service. I faced one case that one team of pharmacists, they were visiting a group of patients at home, and the patients, they liked their way of disseminating information, of interacting with them. For a reason or another, this team could not continue the service. Then when we assigned another team, they were reluctant to deal with them. And we had some members from the previous team to go to those homes and to reintroduce the new team in order to accept them. Sometimes you need to do these steps. Optimizing the care of home care teams has been recognized as an approach to mitigate unnecessary hospital admissions, as we mentioned. Because patient, when we get some issues related to their health, some of them, they get panic and they think that they have to run to the emergency rooms, making them crowded, and at the end they are not eligible for admission, or their no need for admission. Pharmacists can reduce this traffic to the emergency room. In light of COVID-19 pandemic, the role of home care services and home pharmacy service will likely to continue to evolve, because we knew that during COVID, we learned so many technologies, so many tools that we can function remotely or virtually. And now, as we saw in our previous presentation, that this will evolve, inshallah, will continue. Example of pharmacist role experience. This is what have been tried and what have been experienced, what has been done as pharmacists in home health care setting. They were performing patient assessment for medication-related factors, and they were ordering laboratory tests necessary for monitoring outcomes of medication therapies to know the drug level and etc. Interpret data related to medication safety and effectiveness, and they were able to answer all related questions, initiate or modify medication therapy care plans on the basis of patient response. According to the patient response, the plan is changed or adjusted. Provide information, education, counseling to patient about medication-related care. Document the care provided in patient records, and this is very necessary if the patient is having his record either at home, which will be transferred to the hospital, or at hospital. They used to document all these operations. Identify any barriers to patient compliance in order to work on it and solve it and to improve the compliance. Participate in multidisciplinary reviews of patients' progress, specifically when discussing it with the management team of this patient. Communicate with payers to resolve issues that may impede access to medication therapies. And during COVID time, several medications, they were, zero stock at the institutions. Those pharmacies, they had to communicate with the, companies, with the agencies in order to provide this medication and accelerate its existence for the patient. Communicate relevant issues to physician and other team members in order that to discuss with the team members if they need to, switch medication because they are not available anymore. Provide individualized health promotion and disease prevention specifically for each patient. They give the service, including administration of immunization where this is legally or organizationally authorized. As we remember that some pharmacists, they were providing this immunization on the public pharmacy and even at the home setting. Perform limited physical assessment and supervised medication therapy. This was usually done with diabetic patients and how do they respond to their medication. The home care pharmacy service during COVID, I'll talk now specifically what happened during COVID as a home service that was provided. 2 minutes? Promoting pandemic control, providing guidance for home-based patient population regarding chronic disease, and instructing patients to take their home medication on time and corrected dose. Also informing patient on the availability of drug delivery or mail orders, making sure medication with period validity, educating chronic disease patient, answering the messages that or the questions that the patient have from the WhatsApp and all these things, providing psychological support, also providing factual and reliable information on disease associated with COVID. Decrease visits to the pharmacy by instructing them, utilizing of automation, discard of unused medication, educate the consultation, proper hygiene strategies, disseminating accurate information and to counter methods and misinformation, provide emotional support and monitoring adverse drug reaction, participating in virtual meeting with the patients. As a conclusion, the role of pharmacists in home care service, such as in current pandemic, is of crucial importance because they are often the first and the last point of contact with the healthcare system for patients who need reliable information and advice. Thank you, and sorry if I took more than my time.
Thank you very much, Dr. Amal Najjar, for this great lecture and great service that's participating into optimal patient care. Now we're gonna push the discussions to the end of the session just due to time limitation. We're gonna move to our next distinguished speaker, who's a hematology and oncology clinical pharmacist at King Abdullah Medical City, and we're going to hear about their experience in applying the home health care. Please, guys, join me into applauding and welcoming Dr. Ishtiyaq Bajnaid.
Assalamu alaikum. Sorry for the technical issues. Today I'm going to speak about King Abdullah Medical City experience in providing home pharmacy services, and not the way Dr. Amal mentioned it, as providing a real home services where the pharmacists go to the home to provide direct patient care at home. But some kind of home services that we collaborate with home healthcare and other healthcare provider in providing such services. So I'm going to discuss current pharmacy home care provided at KMC and discuss the future directions or challenges to those kind of services. I have nothing to disclose. So just to talk about KMC, what KMC, so we can understand what kind of services that I'm going to talk about. KMC is located in Mecca. The population of Mecca currently is around 2.4 million person, but KMC is a tertiary and quaternary hospital, referral hospital that serves oncology, hematology, cardiology, and cardiac surgery, and many centers of excellence like neuroscience and ophthalmology. So patients really refer to us from all over the kingdom. With a 550 bed capacity, we have limitations in providing such density and advanced services, and we always have kind of shortages in beds. So I'm going to talk about what kind of home services we provided to kind of elevate those crises. So one of the most, I would say, the most or the longest experience with us is the outpatient parental antimicrobial therapy program, or OBAT program. We also have a home chemotherapy biologics infusion program, and we have home vaccination program. I'm going to talk a little bit about each one briefly. So the first one is the OBAT program. The OBAT, as defined by the Infectious Disease Society of America, as the provision of parental antimicrobial therapy in at least 2 doses on different days without the interfering hospitalization. So that was established in October 2017 when we started our service. And the purpose was to start the OBAT as one of the AMS or antimicrobial stewardship strategy to enhance efficacy, safety, and decrease the antimicrobial resistance and decrease the cost related to antimicrobial. Also to reduce the hospital length of stay and increase the access of care for other patients who can benefit from those beds just occupied for IV antibiotics. To reduce health care costs related to admissions and length of stay and increase patient satisfaction. So as you can see, it's not very clear here, but the team was really multidisciplinary. So the pharmacist, one of the integral role of that team. We started with one home health care team, and we provided only 2 to 3 patients at a time. We could not procure more than 2 to 3 patients. The visits were only once daily visits, so we could only administer once daily dosing. Alternatively, we used the CADD or CAD pumps to administer continuous antimicrobial administration for medication that requires multiple dosing. At that time, we only procure patients who, or recruited patients who have central line or are willing to have central line, and only patient within 30-kilometer parameter of KMC can be, of course, eligible for this service. This is our OBAT team. Of course, the head is the infectious disease department. The pharmacy is the second big leader in that project. The primary physician, of course, they play a very good role in that. Home health care, we have an OBAT coordinator, and the role of OBAT coordinator is very important in working out this process, and the vascular access device team. So basically, how come patients enrolled in this program is by referral from the primary physician, and then goes to the selection criteria from the infectious disease, from social worker. They go and visit the patient's home and see if it is appropriate for antimicrobial storage and administration. If it's not in a very, Makkah has slumps or ashwaiyat. So some of these areas are not accessible. So that's a kind of a selection. Also, the selection comes to the pharmacy to provide our input regarding can we provide this kind of medication to that patient. After the assessment done, the infectious disease consultant will do a plan, or OBAT plan, and then there is a portion of that plan done by the pharmacist where we wrote the dosage and the infusion rate and so on. Then each day, the home health care will come at the pharmacy at 8:30 a.m. to collect the medication. They go to the patient's home, sometimes take pre-lab, administer the medications. If they have any problem, they can contact an on-call pharmacist for that purposes. And then they came back, administered the medication. They come back with all findings they find at home, and then we discuss the patient case, whether to continue or adjust the plan accordingly. When the therapy ends, for example, intended for 2 weeks, 3 weeks, 1 month, then the case will be closed and the referral will be sealed. So what is the rule for the pharmacist in that kind of home services? Is to establish the policy and protocols and guidelines. The preparation process is very important in those patients, especially, I think, currently we are around 70% of our patients have continuous infusion. So that's something that we just explored and implemented through OBAT system or OBAT program. Medication stability is something very challenging with those patients. Handover to just make sure that the patient never missed any dose, and what to do in emergency situations where the patient, for example, have anaphylaxis or have line occlusion or have, for example, delayed allergy. Also, the pharmacist review the antimicrobial formulary to accommodate more antimicrobial that can benefit those kind of patients. The pharmacist has a very big role in education and training for the patient or for the whole staff dealing with these antimicrobials. We do TDMs and continuous infusion utilization all the time. They contact us to do this. Also, we do monitoring and dose adjustment on a daily basis. All patients who are currently in the OPAT program will go to the pharmacist in charge of that program, and then they review the patients. If they need dose adjustment or anything, they would contact their physician. Regarding the dosage, the frequency or the route utilization is something that we've reached very far in terms of what. For example, we give 12 grams, like total 12 grams of cloxacillin as a continuous infusion. Or for example, ceftazidime twice daily instead of 3 times a day. So we kind of do a lot of literature review to do this. We have to have alternatives, either oral or IV in case of line occlusion, shortages or delayed allergy. Actually, since 2017, we only had 1 patient who have delayed allergy, penicillin allergy, after 5 weeks of treatment, and it was proven that it's allergy. So that's something they consulted the pharmacist, and we saw the patient. We visited the patient and we saw her, and we kind of suggested that it is allergy. So the allergy and the adverse reaction monitoring and reporting management, and especially in delayed allergy, is something that the pharmacy always have to intervene in. As of March 2020, just before the pandemic, we had 90 patients benefit from the OBAT, and we have 444 days saved. Most of these patients were on ertapenem at the beginning of our trial. Now, all of our patients, or most of our patients, take IV instead of just ertapenem. 87% of those patients completed their OBAT without readmission. 12 patients had readmission for different reasons. And the estimated cost saving, just direct cost saving from bed capacity, is 18 million riyal. So can you imagine if we do the same thing in all the hospitals? And we just calculated like the direct cost, not just the indirect cost. During the COVID-19, the beginning of the COVID-19, of course, the services were temporarily seized because of the safety, and then it was resumed in September 2020. From that time to July 2021, we had almost 40 patients, and those 40 patients accounted to almost 600 bed days saved, more than the 90 before. Because most of these patients are endocarditis who required like 6 weeks of treatment, fungal infection who required more than 1 or 2 months of treatment. So that's why we are advancing our practices. We have 2 teams. We can visit the patients twice a day, so we can accommodate twice daily dosing. And now we are using combination, so some patients have 2 pumps or 3 pumps. The other program is home chemotherapy biologics infusion. And the purpose, of course, is to increase the bed capacity again, to reduce the waiting time at the infusion center. Sometimes it goes around from 2 to 6 hours just waiting for the infusion, and increase the patient satisfaction. Those are the medications that we listed as proposed medication for that program. We started, of course, 5FU is something very old that we do at home, but bortezomib is something new. And in the coming 3 months, we will discuss the rest medications. So the role of pharmacists in chemotherapy and biologics infusion is even more augmented because the stabilities and compatibilities of those medications are very complex, and they are changed from the dilution and from the vial to the bag. The stability, the compatibility with the lines is very tricky with those medications. Hypersensitivity is something very common with biologics, so we have to put in place protocols in case of hypersensitivities at home. We provide anaphylactic shock and consultations whenever something happens to the patient. Pre-medications are something very important for those patients, so we have to prepare the pre-medications, make sure that the patients take their pre-medications before the start of infusion. Patient counseling and education, especially in some of those chemotherapy that the patient has to live with the pump for more than 4 weeks, is something very crucial because those are hazardous medications. So if there is a spill or extravasation, there has to be a very clear communication and counseling and education of the patient how to do and what to do in case of these kind of things. We provide the patient and the healthcare with the spill kit so they can manage any spillage in the hazardous medication. Coordination and communication is something vital in those medications, especially they are very expensive medications. So if the patient, for example, had a lab test just the day before giving those medications and it was omitting that dose, the preparation will be wasted. So what we did is to cohort patients. So let's say bortezomib, we schedule two visits for 2 patients at the same day to split the doses and the vials, or to share the vials. Allergies and adverse reactions are very important. We make registries for these things, especially for those patients. One thing is very important for the pharmacist to participate in is the procurement, selection, and monitoring of the ambulatory pump used. Because each pump, those are the 3 commonly used, but there are so many ambulatory pumps out there, but they are very tricky. They have different or limited, sometimes infusion rates. So you have to be very careful when choosing which one to procure to your hospital. Use the one that has wider range so it can accommodate different kind of medications. The monitoring of those medications and the biomedical maintenance is very important. Programming those medications, because programming error is very fatal in those patients. Those patients have rates of microgram per kg or per milliliter. So if just 1 0 is different, then the patient might be harmful, and that might receive very great deal of harm, especially the patient at home. The consumable also in these pumps are tricky because some of them are not compatible with some kind of chemotherapy or biologics. So it's very important for us to understand what kind of consumable comes with those pumps to just plan ahead. The preparation also sometimes has limitation. For example, the cassette capacity of those pumps has limitation. So if we want to add more, we cannot. So that's something has to be considered from the beginning. The last experience is the home vaccination. Of course, that was mainly as a part of the COVID-19 pandemic fighting strategies. Home health care, of course, the targeted, but we went to the slums. There are so many YouTube videos talking about that. We went to special missions like in Dar al-Aitam or Dar al-Raaya. The vaccine that was provided, of course, it was Pfizer, the first one. So the storage challenge with Pfizer vaccine was very something that we intervened in. They had us on call all the time to help with the storage preparation also. Some of those missions we went as a pharmacist to prepare the medications on site. The training, we trained all the home healthcare for the administration almost every 2 weeks. We were consulted all the time especially for the stability and the adverse drug reaction. After we were done with the COVID-19 vaccination, we discussed the expansion of the service to include all vaccination to all home health care. So just lastly, to wrap up, is the challenges. So there is a geographical limitation for home health care providing. So we can only provide home health care for a distance of like 30 to 60 kilometers around us. Shortages in nurses is always a challenge. Lacking of stakeholders' awareness about the importance of pharmacy involvement in home health care is a must. It is something that we should consider, but also the lack of pharmacists themselves awareness of their role in home health care is another thing. Patient medical illiteracy is something very important. So we have to just assess how much the knowledge of our patients to give them more services or targeted services at their home. In KMC, we are already discussing the home pharmacy MTM service, the virtual clinics, and the home TBN, and the home patient-controlled anesthesia, but those two are a bit tricky because of the legislation problems, especially with the patient-controlled anesthesia, although our physicians are nagging us to start with the home infusion of narcotics. So just pharmacists at KMC have different roles and many opportunities to provide pharmaceutical care to patients at their home. And the pharmacy role in home health care is now recognized more at KMC than it was before, and it has an increasing demand. The head of the home health care is calling me all the time. So they are asking me for more involvement of the pharmacy. So I think this is a chance for everyone to actively seek the opportunities to explore this new frontier around the kingdom and share their experiences in such platform. Thank you.
يعطيك العافية دكتورة اشتياق. I just realized I did not give her the best introduction. Dr. Ishtiaq received her PharmD from King Abdulaziz University, which was followed by a PGY1 the Advanced Pharmacy Practice from MCPHS University in Boston, where I graduated as well. So this gives her a bonus. She also received her PGY1 residency at St. Elizabeth Medical Center. That's also in Boston, USA. And her clinical oncology and hematology residency program was done in King Abdulaziz Medical Center. Yep.
Thank you.
So now we're going to move on to the discussion. I'm quite sure that we're going to have a lot of these questions, at least from my side. No one has any questions, but I'm quite sure we're going to have some questions to our great distinguished speakers. So any questions from our audience?
السلام عليكم صباح الخير يعطيكم العافية. I would like to ask Dr. Amal, Are you considering completely shifting your service to a virtual home health care pharmacy clinic? That will have maybe cost saving, more efficient for staff time, and you will increase the access of patients to your care.
Thank you for this question. Actually, no, we are not considering this because also we have like patient preference. Several patients, they don't prefer to be served as like home based service, and I mean maybe in the let me say in the long future they might consider it, but for the time being, no. Patients, let me tell you an example that we were doing it during COVID. We were trying to contact the patient virtually and to open with them like Zoom, links, and that's it, in order to explain properly for them. And they insist to reach the hospital door, and they want to meet, the pharmacist or the physician or whoever. I don't think now we can totally shift to this. We will find some resistance that we might not be able to, overcome it.
I might have a few questions. One question to Dr. Amr Najjar. Was there any specific criteria for patients to be followed up at home rather than the regular method of managing your patients?
There were specific criteria for patients to be visited at home?
Yes.
Yes, we have like the patients who are home-bound patients who are immobile and difficult to mobile them. We have like geriatric patients, patients with polypharmacy, and the criteria was changed. It was not like from patient perspective. It was like from pandemic perspective when we have it during pandemic. Even patients who are not, under these criteria, they were visited at home and they were given, the service that they need. This was, tied to a pandemic area, but when there is a release, we return back to the criteria with some exceptions, and it was set by the committee of the Pharmacy and Therapeutic Committee, and it was discussed with the main administrative committee in the hospital, and then agreed on this criteria, those patients that to be visited.
Excellent. And in terms of staffing, did you recruit specific pharmacists for this service, or this service was like rotated between your staff?
Actually, it depends on the situation of the patient who are going to be visited. Some patients, they required clinical pharmacists to attend. Some patients, they required rotating pharmacists by schedule to attend.
Before asking more questions, I'm going to give the audience some chance. Is there any questions from your side? Is there a question? Mike?
Assalamu alaikum. Naif Al-Yamani, clinical pharmacist oncology. My question is for Dr. Ishtiaq. I like the presentation very much, to be honest with you, and it's a really excellent idea that you're considering providing home infusions for chemotherapy and some biologics. The point that you mentioned about having to structure the program very well to deal with incidents such as spills and probably adverse drug reactions or extravasations. Can you elaborate a little bit more about what you're planning to do in that part? Are you planning on educating the patient or the caregiver? Are you planning to have a rapid response team, some form of a rapid response team that can attend to such situations? Thank you.
So yes, when we started this program, there was a lot of hesitancy. But the home health care was really, they were very interested, and they were very, I would say, pushing forward to go with this program. So with that kind of enthusiasm, we tried to tackle these kind of questions or these kind of challenges. Regarding the spill kit, for example, or the spillage anyway, or handling hazardous medications, if you really think about it, it's like handling the oral chemotherapy. It's pretty the same, but we just tend to neglect that oral chemotherapy is hazardous as well. So just one of the processes that we did is the social worker, the involvement of social worker to assist the home of the patients, to assist the educational level of the patients and their family. So if that was met, and usually patients who have, for example, bortezomib, multiple myelomas for a long time, so their family usually have some level of educations about the elderly situation. So that's why they were really kind of engaged, the family themselves, and there was education for the family to handle these kind of things. There is a pharmacy and home health care on-call, like a service or a referral person that they can call whenever they have any kind of. But for example, with the first subcut, it's usually handled by the nurses going there. But for example, for blinatumomab, this is the real issue because it's IV. It's the duration is 6 weeks, and that's why we were a little bit cautious. But I think those patients are pretty educated. So education is very important for the family and the patients, and putting backups and being there, reachable for the patients whenever they have any issue is the two key things, I would say.
Thank you, Dr. Ishtiaq. My possibly last question, the TDM, was that done by trained pharmacists or there were other healthcare professionals in the team to do so?
No, so it was done by the pharmacist. So we have a schedule, but usually there is fixed pharmacist. But when she is not around or she's not on call, then someone will have to take over. So yes, TDM every day when the home health care they will go, they take the blood sample. And whenever the results comes, the coordinators call the pharmacy and they say the result has come. So they review the case and they suggest if there is a need to change the medication, the dose or not. Some of the tests became, for example, very low. So we question. We sent the nurse to get another sample, and the result came at the afternoon shift. So we called the patient personally, and we told him to stop the pump and to come to the hospital immediately. So that was done several times.
All right, so I believe we're running out of time, so we're going to conclude this session. Thank you very much, Dr. Amal Najjar, for introducing us to this beautiful concept showing the involvement of pharmacists in patient care different than the traditional ways. And Dr. Ishtiaq for allowing us to see your experience, which participated in, I think, 18 million savings riyals into healthcare systems. So, Sari, thank you very much. We're going to move on to the appreciation.
And now, I'd like to invite Dr. Ala Mutlaq to thank our speakers. Dr. Amal Najjar. Dr. Ishtiaq Bajnaid. دكتور أبو بكر عمير. And now we'd like to take a 10 minutes break, and after that we'll proceed to our next sessions. Thank you. By now, we will proceed to our next session, which is a debate about medications home delivery. And I'd like to welcome Dr. Mohammed Shinawi as a moderator for this session.
Assalamu alaikum. Since it's a debate, I believe we have to give a small brief about it. Nowadays, a lot of institutions in the kingdom, they are going for a home delivery. And recently, even for the narcotics and control, it was approved from the minister in order to have our narcotics and control delivered through a mail services companies. So it's a debate. Dr. Khalil, he will tell us about the advantages, and Dr. Naif, he will tell us about the disadvantages. Please welcome with me Dr. Khalil Al-Majid, Executive Director Operations, Ministry of National Guard Affairs. Dr. Khalil, he has a master's degree in medical education from King Saud University in 2013, and a master's degree in health and hospital administration from King Saud University in 2009, and a bachelor's degree in pharmaceutical science from King Saud University in 2000. Please welcome with me Dr. Khalil. Dr. Khalil, the stage is yours.
Assalamu alaikum. Allah yatikum al-afiyah. First of all, I would like to thank the organizing committee to just invite me وطاي الشرف اني حضر مثل المؤتمر من زمان. الفارماسيست we missed them. بس الله يعطيكم العافية جميعا. طبعا لما كلمني الدكتور عبد الرحمن السويعدي الله يعطيه العافية عن الادفانتج للميديكيشن هوم ديليفري، حاولت ابحر. طبعا ما في بروجكت ما في ادفانتج وديسادفانتج، لكن البيج جامب الان اللي صاير في البلد، الترانسفورميشن في الهيلث، we try to cope to reach the patient. فان شاء الله اني I will add an informative knowledge for you ان شاء الله. طبعا I will try to give some background about the general concept to understand the rationale for medication home delivery. I will try to build the advantage from real scenarios, and we will see with Dr. Naif inshallah the disadvantage inshallah. Just background, everybody know المملكة العربية السعودية is a continent. It's 2 million kilometers square, 13 administrative division, Emirates, centers. The governance we have, it's 136. The distance from point in Taif up to Najran, it's almost 2,000 kilo, more than 2,000 kilo. From the east to west, it's almost 1,500, with multiple thousands of centers. The population is scattered everywhere. This is one of the ideas keep how the patient they are facing and treating, and to be access to the healthcare and to be access to their medications. Since 3 years ago, when the plan of health transformation it's become a reality and we have to cope. We have facilitating. This is one of the core key performance indicator for the 2030 provision, facilitating the access to healthcare services, also improving the quality and the efficacy of healthcare services, improve the patient experience. One of the challenges that we face in the pharmacy is the patient experience. Last study that we read, it's about 78% satisfaction, which is still not acceptable. And with the expansion of the technology, how we could utilize our infrastructure and technology to serve our patients. From this rationale, I want to go to a real scenario that we are facing in daily basis. The end user, the frontliner pharmacists, they are facing daily. First scenario, we have one patient, Ahmed. He has familial hypercholesteremia on active medication plan or treatment plan in tertiary hospital in Riyadh. Ahmed, he's living in Al-Qarayat. As a familial hypercholesteremia, we realize that he's a chronic patient. He has to travel from Al-Qarayat in Riyadh just to take his medication. From that, I could realize that the medication home delivery, it will enhance the patient accessibility to their medications. Instead of he will book a flight or ride to Riyadh, it's almost 24 hours riding if you want to ride from there, or 2 hours in flight. If you have, could book your flights just to take your medication and get back again, and take in consideration the accommodation cost, the travel cost, and even the time you spend to take medication that usually take it in 20 minutes. Second scenario, which is another patient, Sarah. She's a hypertensive patient. She's rheumatoid arthritis. With our trend in biological medications, it's very expensive. And this is one of the things that we deal with it in National Guard. The biologics, we give it in a monthly basis. Very costly. We are not able to give it to the patient. We don't want to have a waste or improper utilization, improper storage. That will keep those medication is in a monthly basis. While hypertensive medication, it will be in quarterly basis. So, she lives in Shagra. She have to ask her relative, or she have to ask whoever in Riyadh to brought her medication to Shagra. Shagra is almost 200 kilos from Riyadh. What she did, she say, okay, I could adapt with my rheumatoid arthritis. I will stop the medication for 2 months until I have the visit for my hypertension medication, and they will take it all together. And then one of the things that we face, that the patient compliance, especially with those medications, we realize that it's a part of medication home delivery that they will add to us. So it's enhancing the compliance of patient. And we realize it within this 2 years because we are expanding in medication delivery. The third scenario, I think is most common in all outpatients. In our ACC, in ambulatory care services in Riyadh, in daily basis, we are dealing with 1,500 patients. How it's much crowded. I have 22 windows, at least 50 patients per day to be reached within 10 hours. They are accumulating in one area. 40% of those patients are refill patients, which could be avoided by medication delivery. So, as a safety culture, we think that the hospital crowdedness will be minimized with the medication home delivery. Fourth scenario, we realize from our distribution of our healthcare services, most of tertiary hospital and secondary hospital will be located in large cities. And alhamdulillah, the government support to have free access for medication and for treatment for all population, that will add another load for our government. I don't know if you are aware about that, but every single patient living outside Riyadh will be sponsored by the government to be traveled from his country, from his cities to Riyadh. The voucher will be free from the government and the accommodation. And this will add a huge cost in our expenditures. So, we realize that cost effectiveness with the medication home delivery will add value in cost minimization. The fifth scenario, in our experience with the medication home delivery in National Guard, we start in early 2000 with special population to have such medication home delivery. It was located for for certain patients living outside Riyadh. Through our patient surveys that we made, we reached 95% with their satisfactions. And during COVID, we reached 97% with whole patients with the curfew that we are applied and the lockdown that we have. So we believe the medication home delivery will add a patient experience. It will improve massively the patient experience and will add advantage for our care and for our patients. Finally, I think from the early morning we are talking about the virtual clinic, home health care, all those infrastructures, telehealth, 937 refill clinic, virtual clinic, all IT advancement and supply chain strategies, investment that we have it. If we are not able to utilize with the government support, that will still is considered a cost loss that we could not meet. So utilization of our infrastructure and technology, it will add advantage to have succeed medication home delivery. This is what I realize. In addition to, take it from the different perspective. If you minimize the patient in the hospital, that you will add another patient to the tertiary care to be accessible. So we will serve our accessibility the patient to the health care, and it will decrease the medication waste, because if I'm a tertiary patient, I'm a patient with I need to have advanced care, and I have my appointment with oncologist or medicine or rheumatologist after 2 years, and this is the most common that we have. I know one of our key indicators in transformation to have visit within 4 weeks, but still we have a waiting list. I'm sure all of the hospital, at least they have 1 year a waiting list for their patients. If we minimize the utilization of tertiary care through utilization of telehealth and utilization of medication home delivery, this will add a decrease in medication waste, because the patient will be struggle with primary care until they have a proper treatment. Here in nutshell, this is my advantage strategies. It's accessibility, compliance, safety culture, cost minimization, and improve experience and resources. ولو ما عندنا تنمية الإيرادات ولا كفاءة الإنفاق علمتكم الثالثة إنه we could be a chance of increase income. يعطيكم العافية.
Thank you, Dr. Khalil. Great advantages. Personally, I'm convinced with the continuation of mail services. Now we will see if Dr. Naif has another difficult part. He has to convince us all to rethink about the services, and he has to give us the disadvantages of medications home delivery. Please welcome with me Dr. Naif Al-Yamani, Consultant Clinical Pharmacist in Oncology, King Fahd Medical City. Dr. Naif, he has a PhD in Medicine and Therapeutics from University of Aberdeen, United Kingdom, and he has a Master Science in Clinical Pharmacology from University of Aberdeen, United Kingdom, and he had his bachelor degree in Pharmaceutical Science from King Saud University, Saudi Arabia. Please welcome with me Dr. Naif, and we wish you all the luck in the presentation.
طيب. بسم الله الرحمن الرحيم. First of all, I would like to thank the organizing committee and the scientific committee for inviting me to debate with Dr. Khalil on the advantages and disadvantages of medication home delivery. Apologies for the technical difficulties at the beginning. So Dr. Khalil really made it very hard for me to talk about disadvantages, considering the advantages that are absolutely undoubted about the medication home delivery. However, when I really thought about it, and I discussed it with the team who's handling medication home delivery in King Fahd Medical City and in the R2 cluster, we came up, or the whole team came up with very interesting ideas, which I'll be presenting in a minute. So when we first think about the post-pandemic situation, we think communication, right? So we try to improve communication as much as we can. We try to minimize contact and enhance communication. So the first thing that came to mind with the team was as part of the disadvantages of medication home delivery was the difficulties providing counseling virtually to patients. So one of the problems there was the unfeasibility of a video call, which is very important to patients when you're describing to them which medications are they going to use, when and how. It's going to be very challenging when you're describing it over the phone. So a video call is very important, which is unfeasible in many cases. Patients are also reluctant to attend counseling appointments, and that's from a real experience with the team who are facing it on daily basis. Patients are not really keen on going to medication counseling clinics, primarily because they have been through a lot of other clinics and they just had enough. So they're not keen on going into another appointment with another healthcare provider to describe to them over and over what are they going to use, where and when and how. Another one is when you have a connection with the patient and you establish that connection, you very often face some difficulties with the calls being made online or voice over IP, and even in the mobile coverage in some areas also is not as good as it's supposed to be. So that's another challenge that we face. Literacy of patients. I noticed that also in previous presentations this morning, literacy of patients or medical literacy of patients was mentioned as a challenge in reaching out to patients at their homes. So if the patient is not aware about his or her medications, they will not be able to follow through the medication therapy, which will also or ultimately impact on patients' adherence. Another issue is with renewing prescriptions. So very often you run into this situation where a patient runs out of their prescription medications before their next appointment, where they're supposed to see the physician. Physician is supposed to assess their situation, decide on continuing or discontinuing or amending therapy. So we face real issues with trying to renew those prescriptions for patients or extend them to the time of their appointment to see the physician. So the main issues here revolve around communicating with the physician, trying to bridge this gap between the patient and the physician, studying the patient's whole therapy, discussing with the physician what's going to be continued on, what's going to be amended, based on feedback from the patient, for example. And there's also the issue of high alert medications and neurotherapeutic index medications, which are really tricky when you come to decide on whether or not to continue on the same dose or amend that dose based on lab tests. For example, if we're talking about warfarin, it gets much trickier than other medications because you have to see INR on regular basis, you have to follow the patients, you have to check for the signs. So all of these things make it really challenging to address renewing prescriptions for patients with expired prescriptions. Next is challenges in monitoring the therapy outcomes. So again, patient is at his or her home, they're comfortable, they're receiving their medications regularly through the mail. So they think to themselves, why bother go to the clinic even? Why bother go to the appointment with the physician? I'm doing well, I'm not feeling anything, so I'll just keep requesting my prescriptions to be renewed and they're sent to me at home and I don't have to go check up on myself. So that's a problem or a disadvantage of medication home delivery. Also, when you're thinking about the coordination between physicians in tertiary care hospitals in major cities with healthcare facilities in smaller areas, rural areas, you start thinking about the shortage of staff they have there or shortage of supplies they have to appropriately monitor the therapy outcomes for their patients. The lack of or difficulties, let's say, in coordination between healthcare providing facilities to monitor the outcomes of therapy for patients. Major disadvantage. Everyone has, I'm sure everyone has faced this at one point in their career. Patients come in to the pharmacy with more than one brand for the same medication, and they're using both simply because we ran out of that brand. The company had a shortage or the manufacturer closed for some reason, so we shifted to another manufacturer who's provided the medication, but then there was no proper counseling for the patient and the patient ended up using double the dose. So that causes confusion to patients and risk of therapy duplication, especially if there is no continuous follow-up with patients who are receiving their medications at their home. Next is back to Dr. Mohammed's point of mailing narcotics and controlled medications. There are difficulties, of course. We're at the very beginning of the journey to start this service, so we're facing a lot of issues. We still haven't yet managed to send our first shipment to patients because there are some technicalities with the license for the company and the contract with the service provider, which need to be squared out before we start. But even after we start, there will be challenges with patient consent. For example, if they opt to have their medications delivered to them, how are we going to collect consent from the patient for sending such highly critical medications and easy for misuse or abuse? It's a complicated process that will start with listing all the medications with their dosages, with their exact way of use, the batch, the expiry, everything. You have to list it down, so when the patient receives it from the courier, they will go through all of these medications, check one by one, and it's going to be really from a patient experience perspective, it's going to be a little bit challenging for them. There's always a risk of shipment loss, which someone will have to be accountable for. There's also the fact that many of those patients are frail patients. So they will probably or most likely not going to be receiving those medications themselves. There's a caregiver or a relative who's going to receive those medications. So again, there's that uncertainty that the patient's ultimately going to receive the medications and use them and benefit from them. Another issue is with trying to identify patients' addresses correctly. So there's the problem, of course, of the rural areas not having national addresses in them. There's the problem of some patients maybe providing wrong address or an address of a relative who lives in another city for their medical file or medical record in the hospital, which may end up sending the patient's medications to a wrong address at the end. Never mind that it's a correct address that is recorded in the system, it's not actually the patient's address. The patient used a relative's address within the same city that they're receiving the care. There's also an issue of trying to juggle maybe between the preferred addresses of the patient to receive their prescriptions. Some people don't prefer to receive their medications at home. They prefer to receive it in their work, for example, or at a different address. So again, linking with the Ministry of Interior database or ABSHIR for the appropriate national address will not be enough at the end. We'll face challenges with some patients not wanting their medications to be delivered to their homes. So there is a difficulty in integrating between the health information system and the service provider system, simply because they use totally different programming language and which results in a totally different build, which at the end makes it extremely difficult, if not impossible, to integrate information between health information system and the service provider, which will result at the end in having to navigate between two systems, which creates, to be honest with you, an unpleasant experience for our pharmacists and also for patients who will use two systems or two applications, one to order from the hospital and another one to track their shipment through the service provider. There are challenges dealing with return shipments. So return shipments are a fact. There are the undeliverable shipment because of for example, they're damaged or the patient refused to receive the shipment for some reason, or the patient is not reachable at that time. So they will have to be returned and will have to face the fact that the storage conditions of these medications or these shipments are not, or you cannot be certain that these shipments have been stored appropriately according to the storage conditions of mandated by Sabahi and JCI, for example. Next is the challenges with the service provider. They need to provide specially equipped vehicles to move medications. They simply cannot deal with medication shipments like they deal with any other shipments. It's out of the question. They need to provide properly equipped vehicles, which I know that they're working on, but they haven't been to that extent yet. There's continuous shortage with the packaging material and the wrapping material that is provided by the company, which again makes it really difficult in communicating with them. Coordinating those challenges with the service provider also proved to be difficult to a certain extent, and they're sometimes slow in responding to fixing issues, be that late delivery to a certain patient who keeps on following, or delivery to a wrong address. Sometimes it's really there is a slow response from the service provider for some reason. Another disadvantage is the unavailability of a unified medical record, and in this point, I'm really somehow challenging Dr. Khalil's point of properly utilizing the resources. Not having a unified medical record across the country, which any healthcare provider can access anywhere and check the patient's medical history, is going to provide strains, or going to result in strains on our resources, be that medications or appointment with staff, with physicians, or you name it. If the patient is following in a Ministry of Health institution, and then they go to the Ministry of National Guard, and then they go to the military hospital, they go to King Faisal Specialist Hospital. A lot of our population, unfortunately, have this mentality of needing to check for a second, third, fourth, fifth opinion, and they tend to collect therapies from everyone, which usually results in contradicting therapy plans, and quite often you end up, or the patient ends up using, for example, 2 medications from the same class. They're probably not the same medication, but they're from the same therapeutic class, so they end up being overly treated, if you may call it. Last but not least, there's a difficulty, and we have to face this reality. Patients in our population, they prefer to be treated at tertiary care hospitals. We have not yet reached the optimal goal where we really integrate healthcare through all levels, from primary to secondary to tertiary to quaternary even. So there are these difficulties of convincing the patients, and if you keep providing the service to stable patients who simply need regular follow-ups, not very complicated procedures, if any, they will resist to be transferred back to the institution that they were transferred from at the beginning to the tertiary care hospital, putting again strains on the tertiary services, and making it difficult for other patients who may need those tertiary services, tertiary care services, but they cannot get access to it because the system is too full to add on at the end. And this is going to be inappropriate utilization of the secondary and primary care, which contradicts the integrated care model within the healthcare transformation under Vision 2030. That's all from my side, and thank you all very much.
Thank you, Dr. Naif. After the disadvantages, I believe we have to cancel the whole service. So, Dr. Khalil, I have a question. Since you are telling us about the advantages, did you have any call from the HR in your institution telling you, once we are going ahead and you are going ahead in the pharmacy to increase the service of mail order for your patients, you need to decrease the number of staff in your outpatient pharmacy?
You remind me with Wasfati now. In reality, I don't believe that pharmacy is working as an outpatient situation as just dispensary area. There is a clinical interventions that they have to make. They have to verify the prescriptions. They have to review what kind of case that they have. And then the other part of dispensary, it's the role of medication delivery. And the medication delivery, there is a back office who control the tracking the medications, tracking the patient as he receives his medication, the counseling and e-consultation process that we are implemented already now in National Guard. They are in the back office. Actually, we are increasing demand now. We are requesting more expansion for the service that we have now. It's a refill center.
Great. So I believe the answer to this, we can summarize it from Dr. Khalil that mail order has no impact on the manpower.
Except technician.
Except on the technical part.
Technical part. How they will accumulate medications, it will minimize because in medication home delivery, it's not I want just to show it in a bigger picture. We have Wasfati program. We have within the hospital, even Dr. Naif, he mentioned about different HIS. In National Guard experience, we have one unique HIS system that will be accessible from primary, secondary, tertiary, and even there is a portal and there is access. And all it will fill in a one pool, which HIS system the same. Our colleagues in Jeddah, they could access our file in Riyadh. And our colleagues in Yamba, in the primary care, they could access our center in Jazan. But we don't have this, such kind of HIS variations. And Majlis al-Dhaman al-Sahi, CCHI now, they are accumulating all data for the patient to be ready for the insurance program that will be implemented to have unified file. And I think all sectors, they are engaged in this process now. All of this challenges, it will build a unique pharmaceutical care services programs. They will add more, from my perspective, it's more demand on the service rather than it will be minimize the need for pharmacists. Actually, it will increase the clinical competence of the pharmacist to be more decision making in this part, especially with the MTM clinic or polypharmacy clinic and all ambulatory care services that will be provided, inshallah.
Thank you, Doctor. Dr. Naif, how are you? We have to convince the people now for the advantage of the home delivery. So, don't you think that having majority of our tertiary care hospitals in Riyadh in one road only, if you go to Khurais, starting from Takhassusi, King Fahd Medical City, military, Prince Sultan Cardiac Center, security forces, Al Habib Hospital, then we will end by the National Guard. It's a very crowded road. If I want to go now to National Guard, I have to take 2 hours at least in order to reach there. In addition, I have to park my car. I cannot find parking area if I want to go to King Fahd Medical City to park my car in order to go to the pharmacy to pick up my medication. Do you think having this service provided to our patients, especially nowadays, it's not just only medications, everything. Food service, I can order from a restaurant 5 minutes away from my home, but I will not go to him. I will order it through the application. I will order the medication to be delivered to me. Don't you think that this is worth to have the mail order pharmacy services done and to balance it with the disadvantage? This is better, it will help us?
I couldn't agree more with you, Doctor. I really think that the benefits of mail delivery or medication home delivery outweighs the disadvantages and the problems. But we need to consider really the last point that I mentioned, which is the strains on our tertiary care. You're right. Those tertiary care hospitals in Riyadh are accumulated in one place, and if we take the bigger picture, they are accumulated in Riyadh with some medical cities and some specialist hospitals here and there outside Riyadh. But at the end, the majority are here in Riyadh. So most of the patients, they would want to be treated in those tertiary care hospitals, regardless what their symptoms are or what their problems are, what their conditions are, whether they need actually a tertiary care or not. For a common cold, they would just drop to the ER of King Fahd Medical City or any other place, demanding to be treated because this is a Ministry of Health institution that has to accept them. So again, we really need to pay more attention to the population, raise their awareness of the importance of integrated care within the healthcare transformation, which starts with, even before primary care, starts with prevention, and then goes to primary care, and then goes to secondary, and after that to tertiary or quaternary care. So no doubt, medication home delivery is extremely beneficial, but again, we need to keep in mind these the presented challenges and find solutions around them. So let's say, for example, the issue of patients accumulating in tertiary care hospitals, we need to do better coordination with the different levels of care to have patients stream through those upwards and downwards to reach the optimal utilization of all resources.
Thank you, Doctor. I want to open the floor now to our audience in order to ask. Dr. Ahmed, please go ahead.
Assalamu alaikum. First of all, I would like to thank you for your valuable presentation about this service. Actually, I have one question about reporting of medication error for those population. Is there any data that focus on those population who receive this medication via delivery or via mail delivery, and compared to those who has received it physically from the outpatient pharmacy?
Do you want to take it over, Doctor?
Okay, anyone can answer.
Okay, so thank you for this very important question. It's really challenging to monitor medication errors outside the premises of a healthcare institution. But we have seen some errors that we consider have reached the patient. So they will be categorized as C, category C or above. And we deal with them in a manner similar to a significant medication error that requires full root cause analysis to find out what went wrong, where and when and by whom, to try and trace back the history of actions and find out what went wrong and trying to fix it. But to be honest with you, reporting in that domain, meaning outside the healthcare facility, is less than you would want. To be honest with you, within healthcare institutions, reporting is still considered not optimal. So when you take it outside, you're going to find it's much less than what it should be. Maybe Dr. Khalil has.
And I think this is one of the challenges in the outpatient services. Usually, it's how to track medication error, because it's the last stage of the patient to deal with the institute, rather than, as Dr. Naif said, inside the institute or even outside with the medication delivery, or what kind of, even the relative, when he brought them take medication from military care and he went out, it will be the same. It's different perspective from the inpatient side. There is control, there is closed loop monitoring for medication delivery. While in outpatient, the last step, it's in the last window in the hospital. Either it's from the delivery company or from the outpatient services. But I think this is one of the challenges we are agreeing on it everywhere.
Can I add to this as well? Once we start any new project, I believe the medication errors changes. All of us, we went through the same period of having the HIS implemented in our institutions. We converted the paper prescription to an electronic prescription. And we were dreaming at that time that we will cancel the transcribing errors, that it's happening. However, we found that we had a new errors that it's coming, which was the selecting errors. Many errors that it happened, instead of physician, he will select Ventolin, he will select a Ventavis. And instead of selecting cyclosporine, he will select cyclophosphamide. So those errors, it got changed. I believe once we will have in any kind of projects, whether home delivery or anything else, it has an impact on the safety. It has an impact in the errors. Our target is 0 errors, however, that we hope to minimize it to reach 0, but I don't believe that we will reach 0. Any more questions before we will open the debate for voting from the audience? Dr. Abu Bakr, please.
Bismillah ar-Rahman ar-Rahim. Thank you for these interesting sessions. My question is regarding the 937 issues from our real life in Camp Abdullah Medical City in Mecca regarding patient satisfaction, delay in delivery, system shut down. If the system is shut down, what is the alternative method to deliver medication to the patient? Because it is always submission of the orders through online, or either by receiving direct call by designated staff. We receive sometimes no staff is picking the calls. The other times the system is down. Sometimes switching medication between patients, delivering wrong medication to patients. How can we solve these issues? Thank you.
I could not realize the system that you are talking about. For the system down in general, I believe this exists in every hospital. There is a contingency plan to accommodate with each process that we lose either the patient, how to access the hospital, the hotlines that we created. And in our experience, we have the We Care platform, which is away from our system, that deal with any complaint of the patient and should be replied to the patient within 24 hours, either for the delay, either for any miscommunication, he not able to take his refill, and they will initiate a request for him, regardless his delivery, because his delivery is already tracked by our teams when it's reached to the patient or it's misreached. For other obstacles that we realize it exists, we try to modify it with a unique workflow just to adapt with. This is usually what we are doing in our experience.
طيب. Now to the results. Thank you, doctors. في another question? دكتورة غادة.
Assalamu alaikum. Thank you very much for your both acceptable point of views. I don't have a question, more like a reflection. So one of the most important things is, are we utilizing all stakeholders or all these resources that we have in order to accomplish a home delivery or medication refills for the patients? Are we utilizing all the possible stakeholders and all expertise for the pharmacists in order to get that done? I know that for home delivery, you can definitely, to overcome some of the issues that are raised by Dr. Naif, is to highlight who are the patients who are eligible for that. Definitely a huge section of patients will be eligible for home delivery without any risk on their safety and so on. The other thing is, what is the connection between hospital, tertiary, secondary hospital, and the community pharmacies? in order to also have them as partners in this home delivery and availability of the medication for the patient near their homes. That's something that the ministries are actually looking for, especially with the WASFAT. So where's the role of WASFAT in the whole thing here to help with the delivery of the medication at the site or at the neighborhood where the patient is living? Thank you.
شكرا جزيلا يا دكتور يعطيك العافية. I believe this is we combine between maybe the home delivery and the wasfati or taking the medications from the community pharmacies. But definitely, yes, the community pharmacy are now, even if they are nearby the home, they were asked to deliver to the patient home, not to wait to the patients to go to them. They are still in the process, but I hope that it will soon, inshallah. Hi. Thank you, everybody, and we now have to go to vote. Thank you, doctors. However, that one of you will be the winner, and the other one, he will lose. So who convinced the people? Can we see hands for the people that they are with the medication home delivery? Hands. Medication home delivery?
That's unfair, Doctor.
It sounds that, I'm sorry, Dr. Naif, but Dr. Khalil, he won the battle. And I believe that we can see it very clear now here. Everybody, they voted for with a medication home delivery.
Relax. We have to see where is our defect to improve, rather
Great.
than it's a
So
debate.
we can change it from disadvantages to challenges or areas for improvement, all the points that Dr. Naif he mentioned, and we need to work all together in order to improve it in the future, inshallah. شكرا جزيلا.
Thank you, Doctor. It was a very valuable and informative debate. And now we would like to thank our speakers. Dr. Khalil Al-Majid, Dr. Naif Yamani, Dear audience, now we will move to our next lecture, which is about weight loss intervention for better clinical and economical outcomes. Please let us welcome Dr. Ali Shehri.
Assalamu alaikum. So it's my pleasure to be here today. Thank you very much for the organizing committee for the invitation. And we have limited time, so I'll try to go with the time, and we'll take the question by the end of this presentation. So I'm here today to talk about the weight loss intervention and the burden of the obesity on the clinical and economical outcomes. As we know, obesity is a global pandemic, and it's a big burden all over the world, and mainly in Saudi. So more than 670 million people, they struggle with their weight over all the world. And in Saudi Arabia, 1 out of 3 adults, they have obesity. Also, the problem of the obesity is a big burden on the pediatric age group and adolescent, and more than 340 million of children and adolescents between age of 5 to 18, they struggle also with their weight. So if we see the obesity map in Saudi Arabia, we can see this is based on the national survey which was done in 2016, that the prevalence of obesity is almost you can see it here, it's almost 36% or around 37%. That's in the adult. And if we go to the pediatric age group, it's almost touching the 20%. And I'm sure the percentage or the prevalence nowadays is higher than this. So the latest data from the Public Health Authority reflecting prevalence of obesity of more than 50% of the population in Saudi, they have either overweight or obesity. An Action.io study, which was conducted by Dr. Al-Fadda and his group, looking for the gaps in obesity management, and they found that 68% of patients with obesity, they recognize it as disease. But in the healthcare practitioner, 62% of the healthcare practitioner recognizing the obesity as a disease. So that's a little challenge that you can see that the healthcare practitioner who recognize the obesity as disease is less than the patient. And there is a gap of 6 years between the patient when he starts to struggle with obesity till he starts his first dialogue with his primary health care or primary physician regarding the obesity. So obesity in the top 3 global social burden, you can see that it came directly after smoking and wars. So that's really reflect how big is the problem and how's the big burden of such a disease. So raising level of people who are having overweight, that will reflect in many social aspects by damaging health, wealth, and well-being, lowering the school performance, shortening life expectancy of adults, and other cardiometabolic complications. So very important to highlight that obesity was the only disease mentioned in the Vision of 2030 under the National Transformation Program and as a part of quality of life section. So obesity was clearly mentioned in the Vision of 2030, and the aim or the initiative and the objective is to decrease the prevalence by 2030 by around 1%. So that's a very big challenge, and I think everybody should contribute on this promising objective. So we are not here just to decrease the prevalence, but just first you need to stop the progression, and then you decrease the prevalence. And that's reflect how big is the challenge, and how we should work all together to achieve this target by 2030, inshallah. Obesity is associated with multiple complications. I am sure most of you knows this. So it's reflected metabolically, mechanically, and mentally. We can see that a lot of disease and more than 200 comorbidities are associated with obesity, going from depression, anxiety, asthma, cardiac disease, infertility, and type 2 diabetes, hypertension, dyslipidemia, sleep apnea, and a lot of comorbidity as we mentioned. So again, also the children who has obesity can develop many complications even at their early age. So the tumor cerebri is one of them, sleep apnea, early cardiovascular disease, and high level of lipid, high blood pressure, fatty liver, and many endocrinology and hormonal disturbance related to obesity in the early age of children. So here is just to highlight the challenge in obesity management, which is called the metabolic adaptation. And that's happen when the patient reduces her weight, so it creates like an energy gap. And in this energy gap, that's imbalance between the hunger signal and energy expenditure, and lead to many hormonal imbalance in the body, reflecting the physiology of the obesity. Greater weight loss lead to improved health outcome, and that's the good point that we need to highlight on, that even if you start with 5% weight loss only, that could reflect positively on cardiometabolic complication like hypertension and diabetes. 5 to 10% could reflect more in the PCOS and fatty liver, and so on. So once we have more weight loss, we have more chance for remission and regression of the complication. As you can see in type 2 diabetes remission, 15% total body weight loss can lead to remission of the diabetes. So this is just to highlight how do you start the conversation with patient who has obesity. So there is an international standard called 5A modules that was created by Dr. Chuan from Canada, and that's started with ask. So you ask the permission for the patient to discuss the obesity, because this is very sensitive area, and some patients, they don't like to go in detail for this issue, so you have to take the permission. Then you assess the parameters and the physical parameters of the patient, advising the patient about the health risk and obesity related comorbidities, and then agree on realistic goal. So that's very important, to agree with the patient on a realistic goal and avoid the high expectation and high target weight loss. So it should be an unrealistic goal, and then assist the patient in identifying and addressing the barriers and provide the resources that could help him to manage his or her weight. So this is just to say that there is no one solution can fit all patient who has obesity. So we have the lifestyle, we have the medication, we have the surgical intervention. So we can't depend only in one style and one intervention. So it's kind of transdisciplinary action between all these things, and combining the different arm of intervention till you find the better or the best outcome. So this is the guideline for obesity management, and we can see that the pharmacotherapy started to be indicated in patient who has weight from overweight category with related comorbidities. So you can see that's BMI 27 with related comorbidities, you can start the pharmacotherapy, and after that, any BMI after 30, regardless whether the patient has comorbidity or not, he can go for pharmacotherapy intervention for the treatment of weight. For the surgical intervention, it will be only limited in class 2 obesity with BMI 35 and above if there is a related comorbidities, and BMI more than 40 regardless of the comorbidity presence. So here is the pharmacological option for weight management all over the world, and you can see the orlistat in US. There is the orlistat, phentermine, casemia, which is a combination between the phentermine and topiramate, lorcaserin, and this medication unfortunately was recalled from the market earlier last year in 2020 because of the risk of solid organ cancer. So it's not there anymore. And we have the Contrave. So Contrave is a combination between naltrexone and bupropion, and that's almost traded in US under name of Contrave and in Europe under name of Mesemba. And we have the well-known medication, which is the Saxenda, liraglutide 3 milligram. So if we came to Saudi, we have only orlistat and liraglutide, Saxenda 3 milligram. Contrave got the approval, but not yet in the market. So the pharmacotherapy is an adjuvant therapy with lifestyle intervention, could increase the magnitude of the response for a patient who has obesity. So if we focus more about liraglutide, which is working mainly on the appetite suppression, and as a GLP, there is different action of GLP hormone in the body, and that's starting from the local action in the GI tract and central action in the brain, decreasing the appetite and decreasing the risk of stroke and improving the quality of life by decreasing the depression. There is also very good action for the GLP hormone on the cardiac output and improving the cardiometabolic risk and blood pressure. Again, a positive effect on the liver by decreasing the fatty infiltration, and also very main effect of liraglutide on the pancreas by enhancing the insulin secretion and insulin sensitivity, and that will lead to better outcome of patient who has type 2 diabetes. There is now different forms of GLP molecule in the market, injectable, and even lately there is an oral GLP form. So the liraglutide 3 milligram has went through very well respected trial called the SCALE trial, and we have 1 in phase 2 and 4 in phase 3 and 3 at phase 3B. More or around 6,800 patients was recruited in these trials to see the effect of liraglutide 3 milligram on the weight loss and obesity-related comorbidities. And we can see that all the arm of a SCALE trial, which is a SCALE obesity and pre-diabetes, a SCALE obesity and diabetes, a SCALE maintenance, and a SCALE sleep apnea, all of them, they were published in high-index journals. And this is a type of journal that we call it high index or rated as class A journals. So the weight loss magnitude during the SCALE trial was a little variable. So in a SCALE obesity, there is almost around 10% total body weight loss. In a SCALE pre-diabetes, it's almost 7%. In SCALE diabetes, 6%, and the SCALE sleep apnea again is almost 6%. So we have something between 6 to 10% weight loss in SCALE trials for those patients who received liraglutide 3 milligram during the trial period. So, and here you can see the change in body weight or categorization of the body weight loss in patient who is receiving liraglutide 3 milligram in patient with obesity and pre-diabetes and obesity and diabetes. And there is something called early responder and early non-responder. So the early responder was those patients who lost most of the weight in the first 16 weeks, while those patients who was early non-responder, those patients who continue to lose weight till 1 year period. And the good point here that even the early responder, they continue to lose weight even at 1 year point, even if you continue beyond 16 weeks of the period of the trial. So the categorization of the weight loss here on the right side, you can see that almost 90% of patients who received liraglutide 3 milligram, they lost more than 5% of their weight. Almost half of the population who enrolled in this trial lost more than 10%, and that resemble almost 1 in 2. And almost 1 in 4, they lost more than 15% body weight. So that's very, that's called super responder, because this is very promising percentage. So the bariatric surgery, it gives 20%, while here 1 in 4, they got more than 15%. So they are almost touching the result of the bariatric surgery. So here is the cardiometabolic improvement across the scale trial, and we can see that almost in the first 3 months, most of the patient, or around 70% of them, they went to the normal blood sugar level or to the normal glycemic level of their blood sugar. And the same happened for the blood pressure. You can see here that in the first 3 months, they went to a reasonable reading of their systolic and diastolic blood pressure, and the same reflected also on the metabolic profile related to the lipid, and that's reflected on the LDL triglyceride and improving even the high density lipoprotein. So we're going to talk about the safety profile of liraglutide 3 milligram, and the most common side effect of the liraglutide 3 milligram was related to the gastrointestinal adverse event, and most of these events were mild to moderate in severity and were tolerable by most of the patients in the first few weeks. So usually patients who use the liraglutide or any GLP, they will experience some GI upset in the first few days, but that would be very tolerable in most of the case, or in majority of people, once they go slowly and in slow escalation of the dose. There was no significant increase in the MACE risk, and no significant increase in the gallbladder disease or even the acute pancreatitis. It was numerically imbalanced in liraglutide arm. Rate of neoplasm was again numerically imbalanced, and the risk of neoplasm related to the thyroid was really insignificant, or even the breast cancer. Most of the cases who was having breast cancer during the scale trial, they were have advancing disease. So most likely they were having the disease before the enroll of to the trial, but once they lost the weight, they get the chance to notice the change in their body, and they get the diagnosis with breast cancer. Even the mental or neuropsychiatric manifestation was negative, was non-significant and almost similar to placebo. So here is an interesting data that I want to share with you, which is the first data in Saudi Arabia related to liraglutide 3 milligram. We conducted this data as a real-world evidence for liraglutide 3 milligram in King Fahd Medical City, and we designed this study to study the effectiveness of liraglutide 3 milligram in reducing the weight loss and the obesity-related comorbidity. So this is non-interventional retrospective cohort study, and around 412 patients were recruited and studying the effect of liraglutide on a period of 6 months about the weight loss, and looking for the outcome categorization also of the weight loss and the obesity-related comorbidities, and the change in cardiometabolic biomarkers, including the diabetes and lipid profile. So we had almost 6.5 kg weight loss, average of 6.5 kg weight loss on the Saudi data. And if we go to see it in categorization and in comparison with the randomized control trial, that we can see that almost 76% of the patient, they were able to lose weight, and half of the population in Saudi, they lost more than 5%, and that's almost comparable to the scale trial, the international trial, taking into consideration that in a scale trial that was an interventional study, not retrospective. So those patients, they went through a fully supervised trial and fully support from lifestyle, psychological part, and behavior intervention. While in our data, it's just a retrospective study. Patient came to the clinic, take the Saxenda or the liraglutide 3 milligram, and they just came for the follow-up. So if we go more to see the categorization of the weight loss, you can see 30%, so 1 in 3, they lost more than 10% of their weight, and 12% they lost more than 15% in comparison to 14% in the randomized control trial. So this shows that we have a good effect of the liraglutide 3 milligram in our population. Here is the change in our data and BMI. So we had a significant change in the BMI, almost 2.5 kg per square meter. And here is the change in the cardiometabolic status, mainly related to the diabetes, which is a reduction of 0.5% in the hemoglobin A1C in the whole sample, whether diabetic or non-diabetic. And if we go to the diabetic sample, which was almost resembling 40% of the sample, they have reduction of 1% of their hemoglobin A1C in 6 months, and that's significant reduction comparable to the randomized control trial in the international data. So you can see here is the significance in the change in the cardiometabolic biomarker, which is the BMI, the reduction of the BMI and reduction of the A1C, and any reduction of these metabolic biomarkers will reflect positively in enhancing the life expectancy of the patient. So in summary, obesity is a chronic disease, need long-term management. Pharmacotherapy is a very effective tool for weight reduction. Liraglutide is the only pharmacotherapy approved for adolescents at age of 12 to 18, and this is a very important point. We need to highlight it, that liraglutide is the only approved medication in Saudi Arabia to treat adolescents who struggle with their weight. Liraglutide role is beyond weight loss. It reflects in cardiometabolic and mechanical outcome of the patient. Tolerability for liraglutide is high in general for adult and adolescent. So here is just some platform that could help people who's interested to read more about obesity and to get some certified training in obesity management. So I would encourage everybody to visit this platform and enhance their knowledge and their education about the obesity and obesity management. So by that, I will conclude my presentation. Thank you very much, and I am happy to hear any question. So it's the time for the lunch. And if anybody has a question, or we can conclude. So good. Thank you very much. It was my pleasure to see you today. Inshallah, we'll see you again soon. Thank you.
Dear audience, now we would like to take a break for 15 minutes before moving along with the next sessions. Thank you. Welcome back, everyone. Now we will move along with other session, which is about SGLT2 inhibitors, is a new essential pillar in heart failure with reduced ejection fraction treatment. Please let us welcome Dr. Mariam Al-Qasir through Zoom.
السلام عليكم ورحمة الله وبركاته. Can you hear me? السلام عليكم ورحمة الله وبركاته. Can you hear me? Okay. Thank you very much. Assalamu alaikum. Gives me a great deal of pleasure to be presenting to you today. I'd like to thank the organizing committee to inviting me to give this rather important talk that's very close to my heart. So my talk is entitled From Prevention to Treatment, the Outsized Role of SGLT2 Inhibitors in Contemporary Practice. So these are some of my disclosures. As a quick outline, I'm going to start off with one case that's going to showcase the use of SGLT2 inhibitors in today's practice, and then talk about the unmet need within heart failure, and then talk about some of the data around the use of SGLT2 inhibitors. How does that specific drug fit in today's heart failure world? And then go down to the Kingdom of Saudi Arabia specifically. What are the challenges in heart failure patients today in KSA? And then wrap up with a few key take-home messages. So I'm going to start off with an actual patient, Mr. AA. He's a 68-year-old gentleman who's actively following up in our heart failure clinic. He's known case of hypertension, dyslipidemic, obese. He had non-ischemic cardiomyopathy. Initial ejection fraction was as low as 25%, but with good medical therapy, exercise plan, reduction of weight, we managed to get him to improve to about 35 to 40%, and he's been maintained on ARNI. Of note, he's not a diabetic and he has a normal renal function. So from a medication standpoint, he was maintained on sacubitril valsartan in the order of 200 milligrams twice daily, carvedilol 25 milligrams twice daily, and spironolactone 25 milligrams once daily. His functional class 2, but reasonably well maintained. So what I did in light of the Emperor studies, I had started him on empagliflozin 10 milligrams once daily. He's been doing well since then. He's had no admissions. He's on regular follow-up. His filling pressures on echocardiogram had normalized, and he symptomatically improved, and his ejection fraction has been maintaining it on the higher end of that spectrum at about 40%. So this brings me to the unmet need of heart failure. Unfortunately, despite the recent advances in heart failure medications, yet we still have a big gap in managing these patients. This diagnosis comes with a very grim prognosis. So about half of these patients die within 50 years, which competes with worst cancers available today. And unfortunately, there is paucity and scarcity in the management of patients in a particular group, which are very challenging. And these are the HFpEF patients, which are heart failure with preserved ejection fraction. Now, the way I like to describe the role of SGLT2 is I start off with serendipity. So basically, we know that from the early 2000s, because of some of the side effects of some of the older anti-diabetics, most of the Food and Drug Regulatory authorities in the world had mandated that any novel anti-diabetic needs to have a standalone cardiovascular outcome trial to make sure that these medications are safe in cardiac patients, as most diabetics have cardiovascular disease or at risk of developing cardiovascular disease. And so this was the whole premise in which the SGLT2 drugs came into life when it comes down to the role in the cardiac world. So when they did the cardiovascular outcome trials to look at their safety, what they noticed, in fact, was that not only were they safe, but they had a great benefit in reduction of heart failure hospitalization, and cardiovascular death and major adverse cardiac events. And it was not one drug, but it was more like the whole class had that effect. So this was seen in dapagliflozin, canagliflozin, and empagliflozin, for instance, across the DECLARE, CANVAS, and the EMPA-REG trial. So because of that interesting finding from the EMPA-REG and the DECLARE and TIMI, what the DECLARE and the CANVAS, what they did is it got positioned it started to find its place in the heart failure guidelines. So this is an example from the 2017 Canadian Cardiovascular Society guidelines for the management of heart failure. And back then it was positioned in the following manner. The recommendation was that empagliflozin, SGLT2 inhibitor, because back then this was the effect of only the EMPA-REG trial, must be considered for patients with type 2 diabetes and established cardiovascular disease for the prevention of heart failure-related outcomes. So it was positioned as a drug that should be considered for stage A heart failure. So these are patients without heart failure symptoms, without LV dysfunction, but there are at-risk population. And funnily enough, back then, it was a weak recommendation because it was based on one trial. And I'll show you now how the world has changed in about 4 years. So then after that, a series of the other SGLT2s came out, and it was not only noticed that it had a reduction of heart failure, hospitalization, and cardiovascular death, but there were quite a lot of renal protective elements for these patients. And that also gained another interest from our standpoint and from other society standpoints. So this brought about a number of studies from the drugs themselves to try to test and see whether they can expand the indication of the SGLT2 beyond just diabetic control. So they tested it in the usual HFrEF population from all of the usual HFrEF trials. So the first one that was published was DAPA-HF. So they used HFrEF patients, heart failure with reduced ejection fraction, and that was defined by an ejection fraction of less than 40%. There are functional class 2 or more and have elevated biomarkers, and excluded, again, the usual suspects who are patients with advanced chronic kidney disease, hypotensives, and in this case, type 1 diabetics as well. But it was interesting that half of this population were non-diabetic patients. And the remarkable thing was that this trial clearly showed that the primary outcome of composite cardiovascular death and heart failure hospitalizations was significantly reduced. And the hospitalization for heart failure was a major positive outcome in that regard. And about 6 months later, the EMPEROR-reduced trial came out. And the EMPEROR-reduced trial looked at the use of empagliflozin in a very similar population. This was almost identical to DAPA-HF in that it had half diabetics, half non-diabetics. It had the HFrEF, your typical HFrEF population as well. And again, the results were almost identical in that there was a clear and significant benefit over and above your standard guideline-directed medical therapy in terms of reduction of heart failure, hospitalization, and cardiovascular death. And this proved that this is a class effect when it comes down to this drug. And this drug is not only an anti-diabetic, but it opened it up to become an anti-failure medication. And in the different meta-analysis, it showed within this forest plot, for instance, that all of the outcomes, whether it's a composite or individual outcomes, all cross the line of unity in favor of the interventional arm, even as far as, a first kidney outcome compositor or hospitalization for heart failure or cardiovascular death. So the question that begs itself is, were the benefits any different between the diabetic and the non-diabetic population? And so if you look at the different subgroup analyses between the diabetic and the non-diabetic populations, you notice that the benefit is across both patient populations. So you should not offer it for non-diabetic patients, but in fact you should actually give them the benefit of the doubt, because the benefit is equal across both patient populations. So we know by the sheer fact that being in the heart failure industry, all of our patients down the line have deterioration in their renal function if they don't even start off with it. And so one of the things that we look at is, how does that affect your EGFR, and how does that affect your renal status? And in fact, I can, very confidently say that SGLT2s are one of the most renoprotective drugs in the heart failure world. One, that it definitively retards the progression of renal disease. We know that they do deteriorate with time, but you see the definite plateau that you don't see in the other arm that received good guideline-directed medical therapy without the empagliflozin. For me, this is the most important slide, because to be very honest, if you are a practicing clinician in heart failure, you know that what matters for patients is not when they die, but what matters for the patients is first that they stay out of hospital. So heart failure hospitalization is what matters. But secondly, that they have a decent quality of life whilst they're out of hospital and they're living. So this is a well-validated tool, which is the Kansas City Cardiomyopathy Questionnaire that we use across the board. And what was noticed that there was a significant improvement in the quality of life questionnaire in the interventional arm, in which patients that received SGLT2 inhibitors had shown in comparison to the placebo, although they were all randomized and double-blinded trials. So they didn't know whether they're receiving the intervention or the placebo. And the nice thing about this is that the benefits can be seen as early as 2 to 3 weeks from starting the medications. And this is really reflected in real life. So patients actually start to see the difference quite early on when they are on the medication. And for me, that's what matters. When patients actually feel better, that is a significant hard outcome for me when it comes down to my patients. Obviously, if we like to look at things objectively, we like to also say, okay, if we're keeping patients out of hospital and making them feel better, are we making any impact in terms of improving their LV function and showing physiologically any reverse remodeling? And so this is a sort of a study that clearly looked at that and showed that there was a positive outcome with SGLT2 in terms of showing significant reverse remodeling on echocardiographic parameters in the form of an improvement of ejection fraction, a reduction of left ventricular volume indices, whether in diastole or in systole, LV mass indices, and LA volume indices. So all of these had improved in the right direction, clearly in favor of the interventional arm, and as early as 6 to 9 months after the start of the therapy itself. Now, one of the questions that everybody asks is, okay, what about the side effect profile for these patients? What do we really need to know in terms of the potential harmful side effects and adverse events when it comes down to SGLT2? And I think the one that stands out is the genital tract infections, but I think it shouldn't be off-putting. If you advise the patient ahead of time of good hygiene, this could be avoided. And if the patient gets it, it doesn't mean that you need to stop it indefinitely. You need to take precautions, but you can always re-challenge it. But what's important is the major adverse events that we deal with on day-to-day basis with heart failure patients are not there. So the anti-failure therapies, unfortunately, come with a bag of side effects like hypotension, like hyperkalemia, like deterioration of the renal function. And we worry about something that was named as an anti-diabetic to use it in non-diabetic patients. But we know that, from the multiple studies and the thousands of patients that have been enrolled in phase 3 trials and now even in post-marketing trials, that there is no added risk of symptomatic hypotension, no added risk of hypoglycemia or potassium abnormalities or worsening renal function of note. So where do we stand today with regards to SGLT2 use in cardiac patients? Well, this is sort of a summary from, again, the Canadian Cardiovascular Society guidelines, and they say, well, you need to use it as a core therapy. It's one of the 4 pillars of therapy and anti-failure for heart failure with reduced ejection fraction, regardless of your diabetic status. But you also should use it in stage A heart failure, which are patients that are at risk and have not yet developed LV dysfunction, but they're diabetic and have cardiovascular disease without heart failure, or they're diabetic and above 50, but at risk of developing cardiovascular disease. And they also added, because of its renoprotective element, to use it in albuminuric renal disease with or without diabetes mellitus. So in terms of the ACC updates, they have positioned it as, again, one of the first 4 pillars of therapy. So you use ARNI, you use MRA, you use SGLT2 inhibitors, and you use a beta blocker as well. And the same thing in the Canadian Cardiovascular Society guidelines. And again, similarly, it's positioned as the first 4 medications with a class 1A indication. So it's interesting how we've gone from a weak indication to a class 1A, which is the strongest level of indication in about 4 years' time because of the multitude of benefits seen in multiple randomized clinical trials. So it's positioned today going from triple therapy to the Fantastic 4, and we've added the SGLT2 inhibitors with the usual 3 medications when it comes down to heart failure. Just for the next couple of minutes, if you can allow me, I'm just going to say a few words on heart failure with preserved ejection fraction. It's an area that we still struggle with. We struggle to understand it. We struggle to understand the different phenotypes. And we know that although maybe they don't die, they still carry quite a grim prognosis. Half of these patients still die in about 5 years. And even worse than that, because I'm very emotional when it comes down to quality of life of patients. These patients do much worse than heart failure with reduced ejection fraction because we don't have much to offer them. So we only offer them, diuretics really. And so there's always an unmet need and an unmet gap to manage with these patients. And although we have some indication from certain trials that they may be beneficial, but the highest class that these medications that we usually use in HFrEF populations have been given here is class 2B with a level of indication of C. So it's quite low. And so we saw a slight light at the end of the tunnel with the Emperor Preserved trial when we used it in heart failure with preserved population, ejection fraction population. And we saw that you see that there was a clinically meaningful relative rate reduction of composite primary endpoint of cardiovascular death and heart failure hospitalization. This was the first real positive trial for HFpEF population, and the lines diverged very early on, as early as 3 months post-randomization. So today, as we stand, really, the SGLT2 can be used in the whole spectrum of heart failure. The problem is the challenges in KSA with heart failure is that we deal with a relatively younger population than the Western counterparts, and they come with a bigger bag of comorbidities. Identification of at-risk population is usually not done proactively. So we only see them after the fact. So I think it's very important, if we have a lot of internists and family physicians amongst us, that they think about it when they screen patients for diabetic patients, or even screen patients who are at risk of developing cardiovascular disease. The beauty of empagliflozin, SGLT2s overall, is that dosing is only one dose. It's once daily. There is no need to be using it in sequence, so you don't have to wait to start somebody on something and try it and then add it on. You can start it early on. It's reasonably tolerable, and side effect profile is quite reasonable. And there isn't many major issues with hyperkalemia or hypotension. So in terms of, to wrap up, dear chairpersons, dear colleagues, take-home messages from prevention to heart failure. Where do we consider SGLT2? We consider it from the prevention arm in diabetics above 50 who are at risk of cardiovascular disease, in albuminuric renal disease with or without diabetes, and diabetics with cardiovascular disease at risk of heart failure, so even without heart failure. So these are the stage A patients. But then also you need to use it as a core therapy for HFrEF patients, and also for the whole spectrum of heart failure with preserved ejection fraction and then mildly reduced ejection fraction as well. So the whole spectrum of heart failure, you will not go wrong in using the drug itself. So with that, I leave you. Thank you very much, and I'm open to questions.
Dear audience, your attention was highly appreciated, and now we would like to move to our next session, which is a stewardship program. Please let us welcome Dr. Mislah al-Rashidi, our moderator for this session.
السلام عليكم. صباح الخير جميعا ومساء الخير جميعا. Antimicrobial. Today we'll talk about Our session about antimicrobial resistant stewardship program. You know, antimicrobial resistance increased in last year, 20 years ago, and who also decreased the development of drugs, new drugs, antimicrobial. Today we have different experience from different area. First experience program with Dr. Ala Al-Mutlaq about MOH antimicrobial stewardship. Dr. Ala Al-Mutlaq is manager of clinical pharmacy department in general administration at the pharmaceutical care administration. Graduated from King Saudi University. And she has also a board of clinical pharmacy and internal medicine. Welcome.
طيب بسم الله الرحمن الرحيم يعطيكم العافية جميعا. I think it is a good opportunity to share MOH experience with the different institution. Inshallah, I'm going to talk about how we starting the program at the hospital setting. Then I'm going to talk briefly about the outpatient setting. So actually, we're starting our program at the end of 2019. We starting by create a central team from different departmental, including pharmaceutical care, infection control, laboratory, and infectious disease. Each department has a specific role in this team. Then we assess the current situation at that time. We request from all the hospitals to give us a KPI for them implementation. We found we had at that time 4 feedback from 4 hospitals. The first one, Prince Mohammed bin Abdul Aziz, they they implemented the antimicrobial stewardship by ID clinical pharmacist and ID clinical pharmacist. The other hospital is King Khalid Hospital in Najran. They are implementing the stewardship by only ID clinical pharmacist. The other 2 hospitals, King Faisal Hospital in Taif and Babtain Center, Cardiac Center in Dammam, they are implemented the stewardship only by pharmacists. So we have a 3 experience. Each experience has a different human resources. As you know, the main core elements or main core member to implement the stewardship program is the availability of the core member, which is the clinical pharmacist and ID consultant. So from this experience, we put our plan and aligned with the national action plan, which raised by National AMR, the Antimicrobial Resistance Committee. So our plan to categorize our hospitals to 3 categories. Category A, including the hospital with ID consultant and ID clinical pharmacist. How they will work? They will work by implementing the prospective audit, plus restriction strategies, plus measuring the adherence to the guideline. So Group A can work to the full, they have the full member and they can work as a full program. The Group B, including ID consultant, either ID consultant or ID clinical pharmacist. So the responsible person will go daily to find patients on the restricted medication to check if these patients need this medication or it is appropriately used or not. The third group, Group C, so we will depend on the pharmacist only for a specific diagnosis like pneumonia, UTI, and cellulitis. The pharmacist will choose patients with this diagnosis, and they will evaluate, measuring the adherence of the physician, and they can put them intervention depending on the guideline. So after that, we started in February or launching the program in 2020, February 2020. Then the program unfortunately halted due to the COVID pandemic. We reactivated the program in July 2020. Then we reassess all the hospital. We finished 2020 with 38 hospital has a qualified program. At the end of the third quarter of 2021, we have, alhamdulillah, 50 hospital. This is a hospital, طبعا هنا, as I mentioned, each department has a specific KPI. So as pharmaceutical care, we will follow the ASP structure and the ASP implementation. I know I will have the question, I will keep this inshallah for discussion. What is the outcome? So we missed the outcome. Maybe in the discussion we will talk about it. The outcome, I mean the antibiotic consumption mainly. So for the infection control, they are responsible about the availability of antibiogram at the hospital setting, measuring the adherence to surgical prophylaxis guideline, and to measuring the C. diff rate. For laboratory department, they are responsible to provide the hospital with the equipment, especially the TDM reagent, therapeutic drug monitoring for vancomycin and aminoglycoside, and also to provide the hospital with the C. diff reagents and equipment. And of course, for infectious disease consultants, they helping us during the planning and also during the developing of the guideline. So now we will go to the KPI related to the pharmaceutical department, pharmaceutical general administration of pharmaceutical care. As I mentioned, now we implement the program in 50 hospitals. Depending on our categorization, 12 of them from group A, 17 from group B, and 21 from group C. So we check if they have already active committee or team, active member, ASP policy, hospital guideline, and if they have a regular meeting to discuss all these KPIs. The other main KPI, we measure the ASP implementation, so it is processing measurement also. And this is KPI, the obtaining of the culture before starting the antibiotic, adherence to the guideline. We measure the implementation of the restriction and pre-authorization medication, evaluate the appropriate use of medication, and type and number of intervention by the ASP team or ASP pharmacist. Also, we measure the physician acceptance rate to this recommendation from ASP team. All of this is we can measure it through the electronic form. So the pharmacist or the team will fill all the information during the round, and just for us, we will analyze this data. So, alhamdulillah, during the first, second, and third quarter from 2021, the ASP teams and pharmacists evaluated around 19,401 cases. So, as you see here, the most or the top two is Mecca cluster and First Central cluster in Riyadh. So depending on this intervention or cases evaluated and the quality of intervention, we determined the 4 training centers. So this is centers, just if any hospital need to start the program, we will send the responsible person to take his training in this center, then he can start to implement the program. So the first KPI, culture requested, alhamdulillah, we reaching 70%. Some hospitals reaching 100, but for overall, they reaching 70%. The guideline, we have 3 approved guideline approved by our Central BT Committee, lower respiratory tract infection, including all types of the pneumonia, urinary tract infection, and the skin and soft tissue. We reaching, alhamdulillah, 2%. For the implementation of restriction policy, I guess all of you know about the hospitals, they already have policy. But who implemented this policy or follow this policy? So, alhamdulillah, we reaching around, أنا ما أشوف الأرقام السكرين. So we reaching 86%. For the appropriate use of antibiotic by the main team, for initial appropriate regimen, it was 70. This is for all quarters, for quarter 1, 2, 3 overall. And the further management, which means after 3 days, the de-escalation, the needing for TDM or whatever, this is around 66. So for initial therapy, it's required from ASP team to make them intervention for 30% of the cases, and further management around 43. This is type of intervention. So the percentage of intervention actually reaching 64, including that requesting of the culture, requesting of the lab, de-escalation, changing from IV to oral, deciding the management plan, and what else? Stop the antibiotic, طبعا change the duration. So this is the type of intervention done by ASB team or ASB pharmacist. Acceptance rate, alhamdulillah, we're reaching 93. So the physician accepts the ASB team and pharmacist intervention. Here just I summarize the changes happening during the use of ASB or during implementation of the ASB. We're starting in 2020 with, or the end of 2020, 4,190 cases. We're jumping to 19,000 cases. The adherence to the guideline, the culture obtained, it was 69. Now we, alhamdulillah, reaching 79. Maybe we need more developing for this KPI. Guideline adherence, it was 49, especially when the hospital, they don't have a guideline. But alhamdulillah, after the approval of the guideline, we're reaching 88% adherence. Implementation of the restriction, it was 46. Now we are on 90%. ASB team intervention, it was 43 when comparing with no intervention. So now, alhamdulillah, 68 intervention when comparing with no intervention for these cases. Acceptance rates changing from 62 to 95. طبعا, as all the program, we have some challenges with the, especially with the therapeutic drug monitoring. So non-availability of this non-availability of the reagents leading to decrease the adherence to the guideline. So still we have the main challenges in our program. This is the KPI for general administration and the responsibility of the pharmacist at the hospital setting. We will move to the responsibility of the general administration pharmaceutical care. As I mentioned about antibiogram, surgical prophylaxis, anti-C. diff. In 2016, they have only 24 hospitals reporting antibiogram. At the end of 2020, they, alhamdulillah, jumping from 20 to 80 hospitals. And they طبعا do the analysis for resistance and for they make a surveillance about the resistance and the outbreak at the hospital setting. This is the distribution of the hospital with the antibiogram. The second KPIs, it is they measuring the surgical prophylaxis adherence. They targeting three main components: the type of antibiotic depending on the guideline, the time of administration and discontinuation of the antibiotic. In general, they received from all hospitals, so 100 responding from all hospitals, but the compliance or the adherence rate to the guideline ranging from 75 to 90. They received all this data through Hassan system. Of course, they also measuring the surgical infection rate. So I guess if they increase the adherence to the guideline, the rate of infection will be decreased, inshallah. Also, they have some challenges during the measuring of C. diff rate. The availability of this kit or reagents in all hospitals is not completed for all hospitals. We will move to the laboratory KPIs. As I mentioned, providing the hospital with the TDM. They targeting 121. 77 of these hospitals already have the reagent. Also for C. diff, they have only from these 121, they only provide for 43 hospitals, while in the other hospitals are still not available till now. So this is the main challenges in our program. So now I finishing from the hospital setting, we will move to the nudge, or we can consider it as ASB at outpatient setting. As you know, all the primary health care and hospitals now, starting to use WASFA-T system. So through WASFA-T system, we found a lot of prescription for inappropriate use for antibiotic. Mainly, if we're talking about this, mainly like the physician will write antibiotic for headache, for asthma. So we targeting these prescriptions, and we try to change the behavior of of the physician to change from to write the infectious disease diagnosis specifically. When we start at the second quarter of this year, the percentage of inappropriate antibiotic prescription was 9.1. Alhamdulillah, now at the end of the third quarter, we're reaching 8.6. Today, because my lecture is yesterday, today I have a new information. Alhamdulillah, the percentage is 4.9. After we changing the behavior, this is called nudging. It is not a stewardship. We will start, inshallah, the stewardship at the hospital setting. So this is the end of my lecture. Just I want to thank all people working in the hospital or in the regions as a supervisor who are working to implement this program and to achieve these KPIs and goals. And thank you.
Thank you, Dr. Ala. Second, antimicrobial stewardship experience with Prince Sultan Military Medical City with Dr. Ala Mawsali. Dr. Ala Mawsali is a consultant infectious disease clinical pharmacist, Prince Sultan Military Medical City, Riyadh. She has a PharmD from Imam Al-Qura University. She a clinical pharmacist practice residency, Prince Sultan Military Medical City, infectious disease pharmacotherapy certified, and from King Faisal Hospital Specialist Research Center. Welcome, Doctor.
Assalamu alaikum. Good afternoon, everyone. So my presentation today is about the PSMMC antimicrobial stewardship experience. In my presentation, I will go through overview of PSMMC, review of ASP definition, then overview of CDC core element to demonstrate our application to these guidelines in our practice, and finally, to discuss the ASP challenges, implementation challenges. So Prince Sultan Military Medical City, or what was known as Riyadh Military Hospital, it is a tertiary care medical center established at 1979. It had a leading record in many medical achievements, and it is one of the most advanced centers in the Middle East. We had the first renal transplant center in the kingdom. Then we are doing bone marrow transplant since 1989, and we are the first liver transplant in Arab region. So our bed capacity is 1,400 total bed number, with admission of 36,000 admission per year. And we have around 11 pharmacies for inpatient pharmacy and 11 ambulatory care pharmacies. So why to implement antimicrobial stewardship? So as you mentioned, because of the resistance. So resistance bacteria on the rise, and then the antibiotic production on the fall. Although there are many new approved antimicrobials, but unfortunately, we are facing resistance to the new products. So just a quick definition of antimicrobial stewardship. It's a coordinated intervention designed to improve and measure the appropriate use of antimicrobials by promoting selection of optimal drug, optimal dose with duration, and optimal route of administration. So the goals of perfect antimicrobial stewardship to improve the patient outcome, of course, and then increase the adherence and utilization of treatment guidelines. We would like to reduce the medication side effect or antimicrobial side effect, reduce antimicrobial resistance, reduce the risk of C. diff infection, and of course reduce the cost, but without adversely impact the health of the quality of care. So as Sir Alexander Fleming predicted when he when he was taking the Nobel Prize, that there will come a time the penicillins will be ineffective due to the misuse of the ignorant man, which is unfortunately what's happening right now. So we have 7 CDC core elements: leadership commitment, accountability, drug expertise, action, tracking, reporting, and education. So at PSMMC, we have an antimicrobial stewardship committee that is directed by consultant ID or ID physician, and associate director is ID clinical pharmacist. There are many members, including infectious diseases clinical pharmacist, adult and pediatric, infectious diseases physician, adult and pediatric as well, quality control, nursing, epidemiology, microbiology, infection control, IT, and IC consultant. So we've covered the first 3 core elements. We'll go now to the actions. So there is 2 types of actions. We have to implement policies and procedure, and there is another intervention. I will talk first about the policies and procedure that we have and since when. So here is the antimicrobial order sheet. I'm not sure if you can see it very clearly, but anyway, this is a form to request any antimicrobial, even it's a topical one, even if it's of UCD. So the physician or the prescriber has to write or document the indication. If it's a surgical prophylaxis, non-surgical prophylaxis, empiric treatment, or documented infection. And here, in this part, they have to write the medication name, of course, the dose, the route, and the frequency. This policy was implemented in our institute since 2002. And the guidelines we have, because we are a tertiary hospital, so we cover adult, pediatric, and neonates. We have guidelines for empiric antimicrobial therapy for adult, pediatric, and neonates, guidelines for aminoglycosides and vancomycin dosing and monitoring for the 3 population, and guidelines for antimicrobial surgical prophylaxis for adult, pediatric, IV-to-PO switch, and then guidelines for antimicrobial administered by nebulizer and intraventricular for adults, dosing of obese children, of course for pediatric, and antimicrobial dosing in children. So the effort of the guidelines started around the 90s, 1999 or 1998. It has to be updated every year, and this is the small blue booklet. It is our last one. We do it as a booklet for easy access by all healthcare workers. So the second part of the intervention is the action, specific intervention to improve antibiotic use. We have broad intervention, pharmacy-driven intervention, infection and syndrome specific, and microbiology-based intervention. For broad intervention, we have antibiotic timeout, prior authorization or restriction, and prospective audit and feedback. So this is the same form I just showed you, but here, for the another thing, which is antibiotic timeout. If the patient is taking the antibiotic for prophylaxis, it will be expired after 24 hours unless it is specified in the form. Empirical therapy, 72 hours, and documented infection, 7 days unless if it was mentioned otherwise. So for prior authorization or restriction, usually most of the hospitals, they have restricted, non-restricted. We have 4 categories of restriction. Unrestricted antimicrobial, which can be prescribed by any healthcare or physician, taking care of the patient, like flucloxacillin, ceftriaxone, trimethoprim, sulfamethoxazole. For level 1 restriction, it requires a consultant approval, like piperacillin tazobactam and acyclovir IV. For level 2 restriction, it's restricted to ID physicians only, like very broad spectrum antibiotic like meropenem, vancomycin, ceftazidime, avibactam. Tazocine or piperacillin tazobactam, it's level 2 restriction in an area where they misuse or abuse the antibiotic, like ER or surgical wards. So it's level 2 in those wards. And special restriction, whereas an antibiotic that is restricted to ID and other specialty. In our hospital, pan-sensitive pulmonary tuberculosis is managed by chest physician, not by ID. So rifampin, it's not restricted for ID only, ID and chest physician. Ganciclovir, restricted for infectious diseases, a transplant physician and hematologist. Lamivudine, restricted for ID and hepatologist. Here is a snapshot of the policy I just mentioned. Okay, before I go to the prospective audit and feedback, I will give you a short review of our ASP pathway. So after 48 hours of prescribing the antibiotic, the patient will be reviewed by the designated pharmacist. The pharmacist will go with ID physician for the round, and then they will discuss the case, if there is an intervention or not, and to document or endorse the intervention to the primary team. Then they will follow up the recommendation if it was taken or not by the primary team, and then they will fill the ASP form. So what we used to do since around 2015, this was the IV patch summary that we receive twice a week. We do the ASP round. So we review the patient, we see if they are fulfill the criteria for the stewardship, we review the culture, the indication, and so on. After that, we fill this form here. At the beginning of the form is the demographic data. Then here, every antimicrobial should be assessed if it's required or not, if it's indicated, what is the indication, is it empiric, prophylaxis, or whatever. And then if it's not indicated, is it a contamination, colonization, and what is the coverage for the indication? Is it low, excess, or adequate? And the duration and dose and frequency as well, it should be adequate. In order, the prescription here is, there is very small, is it a prescription is appropriate or not? So in order to be appropriate, it should be adequate for the dose, duration, and the indication. Then what is the recommendation of the ASP team? Is it discontinue antimicrobial or continue with take culture, do TDM or whatever? And here is the follow-up audit or the follow-up visit. If I say discontinue meropenem, so I have to go after 2 days to see if they followed my recommendation or not. So if it's performed, I'll just tick perform. So this is what we used to do until recently. We were lucky enough or fortunate enough to have a Cerner launched in our hospital, that we have what we call pharmacy surveillance system. For every ward, I have here certain alert that will fire or pop up to inform me that there is certain criteria for the patient is meeting, so I should review the patient. The one in the red are severe alert, the one in the black are mild to moderate alert. In the platform here, I could see the medication, the microbiology, and the lab related to ID, like neutrophil, procalcitonin, ESR, and CRP. So here, this alert, there is an antibiotic for this patient. He administered tazocine, but there is no culture was taken, no culture was requested. The other type of alert is the patient is receiving an antibiotic, but the culture that they took, it's already negative, so review the patient. There is another nice or good alert. It is a mismatch, bug-drug mismatch. So the patient has positive blood culture of Staphylococcus aureus or Crohn's, and the patient is on imipenem and it is resistant, so it needs to be reviewed. The last one, the patient has positive culture, but he is not on antibiotic. So this is alert for review. The form I just showed you for prospective audit and feedback, we have it here in the system. We added the primary consultant name and their feedback or response to the recommendation that was told by the ASP team. So this is the pharmacy, the second part of action, which is a pharmacy-driven intervention. IV to PO switch, dose adjustment, time-sensitive automatic stop order. We talk about the dose adjustment and time-sensitive antibiotic stop order. So we'll talk about the IV to PO switch. Here is the form. I'm sure most of you have this form. So to see if the patient has improved from the infection, the patient does not have contraindication for the oral antimicrobial therapy like active GI bleeding or something, or they don't have certain contraindication for infection to take oral therapy. So what we used to do, we have it here now in the system. There is an infection syndrome specific. These are the guidelines recommended by the CDC to have guidelines on it, that because of the misuse usually arise from these infection, community-acquired pneumonia, UTI, skin and soft tissue infection, impaired coverage for MRSA infection, which is of course according to the biogram of the hospital, what kind of the MRSA they usually encounter in the ER, C. diff infection, and treatment of culture-proven invasive infections. So the last but not the least, of course, the microbiology intervention, which is the antibiogram. This is, I guess, was the first antibiogram in our hospital in 2007. Until today, we are doing it because it is very important in managing or doing guidelines for antimicrobial stewardship. So we've covered the actions. There is tracking, reporting, and education. For tracking, we have 4 KPIs: appropriateness of consumptions of vial per 1,000 bed days, then days of therapy per 1,000 bed days, and defined daily dose per 1,000 bed days, of course, for standardization, all per 1,000 bed days. Defined daily dose usually calculated for adult areas only, but the other 3 calculated for all. Appropriateness of therapy, we see it during our prospective audit and feedback. So this was the first a report by pediatric ICU 17. We had a percentage of appropriateness about 67%. But alhamdulillah, today we reach up to around 100%, 99% for appropriateness of therapy. A percent of performed recommendation, if you remember our form, here our target is 80%. The good thing we are around 80, more than 80, 83, 84. Here is the days of therapy for 2020 for all the hospital. And here is the antibiotic consumption for all the hospital as well. So the last one is education. We are doing periodic lectures for different healthcare worker, physician, pharmacist, and nursing. For surgical prophylaxis or introduction to the antimicrobial stewardship, what is the restriction policy, and if we have new guidelines, we do a lecture for it. So we've finished, or we are done with the CDC core elements. So what are the challenges we faced? The most challenge we faced previously was lack of electronic system. I know we did it, but it was hectic actually to get the paper, to look for the patient. We are not sure about the location. All of these was by the new system. The second most challenge I think most of the hospital has, which is shortage of staff. Even if we have most of the areas are covered with pharmacist and physician, if they went on vacation or the fellows has an exam or so on, so the area will not be covered for certain period and because of shortage of staff. So this is a dilemma. Another thing is shortage of narrow spectrum antimicrobial. In our hospital, we have amoxicillin clavulinate. As a shortage of it, we have to use piperacillin tazobactam for aspiration pneumonia instead of augmentin. We have ceftazidime out of stock. Patient with shunt infection, instead of using ceftazidime, we will use meropenem because it's a shunt infection. So this is it's logistic issues, unfortunately. So our effort in antimicrobial stewardship, it was started in 2002 for implementation of restriction. Then at 2015, there was an individual effort to implement the prospective audit and feedback. But fortunately, in 2017, we started seriously for prospective audit and feedback. In 2020, by the end of last year, we had an approval for antimicrobial stewardship unit. We have pharmacists covering most of the areas, reporting, and we have now, 1 week ago, we got the approval for antimicrobial stewardship center, which hopefully will empower and remove the challenges I just discussed. Thank you, and if you have any question.
Thank you, Dr. Ala. Welcome, Dr. Ala. كلكم السلام عليكم. Very important, of course, antimicrobial stewardship program. So in MOH or another hospital, sure. But my question for Dr. Ala, you know, you have a huge number of hospitals in MOH. About private hospital, 50 available. الصوت في المستشفيات الطرفية اللي أقرأها من 50 سرير. طبعا كيف هو أنتم فريق البرنامج رغم أنه في شورتج، يعني لا في لابتست ولا في طبيب سبيشالست خصوصا في الفكر، طلبتوا على التحديات هذه.
يعطيك العافية دكتور. طيب يعطيك العافية دكتور. طيب I guess 50 bed still we didn't reach them. But as the Sabahi standard, which is the minimum standard, at least the hospital have a guideline for the most common infectious disease. So this is a hospital with 50 beds. I think the most common infectious is the CAP. So at least the community-acquired pneumonia guideline available in the hospital, and they follow up the adherence to this guideline. So just we will go with them with the minimum standard to implement it. At least this is what we will do. Until now, we didn't reach 50 hospital, and we can consider our working.
Thank you. دكتورة آلاء موصلي, at Prince Sultan Medical City. And ask about, you have a resistant, of course, antibiotic. You know, resistant from different area, the same or different, from hospital to hospital or area to area?
I think I've heard you correctly. You are asking about resistance if it's different from hospital to hospital?
Yes.
Yes. طبعا.
So.
Oh, sorry. So yes, it's different. Sometimes certain hospital, there is the patient comes with an resistant organism. So we know that in very certain institute, there is a lot of MDROs. So our empiric therapy will be different for patients who is coming from these hospitals. So yes.
Okay. Any question? Others? أسئلة? Welcome.
Assalamu alaikum.
Alaikum
العافية على presentation. Very comprehensive presentation about antimicrobial stewardship. Actually, I am looking for the outcome from, based on your experience, either in Prince Sultan Military Medical City or in Ministry of Health. When you obtain this antibiogram, do you consider what's called, I think, antibiotic holiday, stopping specific antibiotic from being used in the institution for a time period, for example, 6 months or 1 month, and then reassess the antibiogram if it's reduce the resistance level, so you can reinitiate in the hospital? Antibiotic holiday.
We don't do it in our hospital. We don't do the antibiotic. You mean to give a certain period, 6 months, and then change it after 6 months?
We stop it from to be used in the institution, for example, or delete it from formulary based on the resistance,
we
and
don't
then
do
we will.
this. No, we don't do this in our institute.
For us in MOH, there is a report reported yearly. They collected all the data from all hospitals, the antibiogram. Then they make the resistance pattern, what's happening during the last year. Alhamdulillah, for 2020, it was good. With the COVID pandemic, the resistance not changed too much or decreased. So
the report is showing something is good, not very bad. For the hospital setting, we encourage them to discuss this antibiogram at least yearly to change the guideline, especially the hospital-acquired guideline. So we give them the unified or the approved guideline from MOH as word. So they can make the modification depending on the changing of antibiogram and resistance pattern at them hospitals. So we encourage them to do this. So the point or the KPI for the availability of the hospital guidelines we meet. Did they update it or modify depending on the antibiogram at the hospital setting or no?
Any question?
Good afternoon. Thank you for both speakers sharing their experience with us. I think Prince Sultan Medical City can be a reference hospital for an ASP program with the data that you describe and the system or the processes that you are implementing. I want to ask, what about the physician after implementing ISIS? Are they still using the form that you described at the beginning of the lecture?
We've moved most of the data in the, which is the indication and all of these into the electronic system. So we don't have it as paper, but yes, we have the same information on the ISIS.
What about the acceptance of the physician to
fill
fill all the indication?
You mean for the ISIS?
Yes.
It's the same thing. They were doing it for a very long time, so there was no resistance from them at least.
What about the pharmacist? The workload you have, I saw that you have around 1,400 beds. So that require multiple clinical pharmacists.
Yes, we are around 20-something clinical pharmacists. We have, for stewardship, we have some of the pharmacists, PCAP or inpatient pharmacists who help us in doing the prospective audit and feedback. We are trying as much to cover all the areas, to cover it all the timing, not for even if they went on leave, just to cover those pharmacists who are on leave.
Thank you.
Thank you all. It's very interesting subject. My question is to Dr. Ala. At Prince Sultan, you said there is the main challenge was the EMR that generate the data for your team to help you in the implementation of ASP. How you overcome this data and how you select the quality of data from the system, especially as we know recently the military hospital within the Cerner. Now, I think this will help you more next year to extract the data for the antibiogram and for your ASP program. Can you please give us...
You mean previously with no electronic system, the lack of electronic system?
No, not the lack. And how the data you extracted from the system help you in ASP? What the quality of the data?
I cannot hear you, I'm sorry.
What the quality of the data that you are looking for from the EMR or the Cerner now to help you in the ASP program?
So as I mentioned, the alerts that keep popping up or firing, it helps us a lot instead of instead of doing the antimicrobial stewardship twice a week, I can at least see the patient for certain words every day. If there is an alert or something that tells me that the patient has a positive culture or negative culture while he's on antibiotic, I should not wait for the round to do it. I could call the physician and inform them instead of doing all the process of the pathway I mentioned. So it will help a lot.
تفضل دكتور آخر السؤال. تفضل.
Bismillah. Assalamu alaikum wa rahmatullah. I would like to start my comment with thanking Dr. Ala from Prince Sultan. I have the pleasure and honor to be one of the starter pharmacists who started the implementation of these guidelines in Prince Sultan Medical City, previously called Military City, from 2000. I worked there from 2000 until 2008. Frankly speaking, I never saw. Then after that, I moved to many cities and I surveyed many hospitals. I never saw such an implementation and adherence to restrictions and guidelines. I think Prince Sultan Military Medical City can be a model. I wish we could extrapolate this experience in our MOH hospitals. My question is to Dr. Ala Mutlaq, what is your plan to include peripheral hospitals? From my experience and surveys, there is no proper implementation and there is no consensus guidelines as well as stewardship programs and antimicrobial. Some hospitals do not know what is antibiogram. In peripheral hospitals speaking about 50-bed hospitals.
Sorry, doctor, but I didn't get your question about the antibiogram. Can you repeat your question?
My plan for the peripheral hospital, my question is about what's your plan to include the peripheral hospitals in the stewardship program? With the unification of the antimicrobial stewardship program and the antibiogram implementations there, and the role of the pharmacy and therapeutic committees in monitoring these guidelines.
Okay, if I understand your question, you want to implement the SB at your hospital, and you asking what is the role of pharmacists during the interpretation of antibiogram and resistance for the guideline, right?
Yes, in the peripheral hospitals and remote areas.
You mean the peripheral hospitals, the hospital with not enough quantity of sampling. This is you mean, صح? This is one of our challenges actually. We're changing the antibiogram from 6 months to 1 year to find a good quantity of sampling to give us a real resistant reflection. But for some hospitals, still the number of the sampling less than 30, which is the standard. We recommend to them to use the national or the MOH guideline rather than doing any modification unless they can use the guideline or the resistance from the nearest hospital, big hospital at this region. So I guess this is the way to solve this problem. Just I have a question for Dr. Ala. Dr. Ala, one of our challenges is when we trying to calculate DDD, the shortage of medication affects the DDD.
Yes.
So do you have any solution for this problem?
There is no solution. We just tried a note for interpreting the data that there was a shortage for certain medication. Even with days of therapy, when you have a huge denominator, so you will have a small number. When you have a very small admission at the same period, you will have a very huge number. So the data will fluctuate, but there is no.
شكرا لكم جميعا.
Thanks for your valuable discussion. And now, Dr. Abdurrahman Swayahdi will come to thank our speakers. Dr. Ala Mutlaq. دكتور آلاء موصلي. دكتور مصلح الرشيدي. Dear audience, we want to thank you for your engagement. And now it is the time to announce the second winner for our second gift for today. Let's see who's the winner. audience, please stay tuned. There will be one more tablet to be given today. It will be after the last session. Thank you. Dear audience, now we would move to our next session, which is about pharmacy technicians' future directions. Please let us welcome Dr. Mana Al-Najm, which is our moderator for today's session.
Assalamu alaikum. Good afternoon. First of all, I want to thank the organized committee for your invitation. This is Mana Faris Al-Najm. I am pediatric clinical pharmacist and residency program director at King Khalid Hospital at Najran City. Inshallah, today I will be moderator for our two outstanding clinical pharmacist consultants. We will start with Dr. Khalifa Al-Dhiab, who is a consultant clinical pharmacist at solid organ transplant at King Abdulaziz Medical City. Dr. Dhiab, he has Bachelor of Science degree in pharmacy at King Saud University. Also, he has a Saudi certificate in clinical pharmacy program. Inshallah, he will talk about the pharmacy technician with future directions. So, welcome, Dr. Khalifa.
السلام عليكم ورحمة الله. مساء الخير جميعا. إن شاء الله راح أتكلم اليوم عن الفارماسي تكنيشن بروجرام and development. My objective for this presentation, small introduction. راح أتكلم عن الفارماسي تكنيشن workforce في Ministry of Health. أتكلم عن career development, how we advance the pharmacy technician rules, and finally my conclusions. الموضوع هذا يعني لي كثير لأني أنا أيضا كنت تكنيشن سابق والحمد لله يعني حاليا consultant clinical pharmacist. فالبداية كانت من مستشفى الأمير سلمان بمسماه السابق. كنت تكنيشن هناك وبعدين فتح الله علي وكملت دراستي. التحقت جامعة الملك سعود، أخذت البكالوريوس وبعدها كملت ريزيدنسي. لو نروح لل IHP نلقاها تقسم التكنيشن رول إلى يعني 2 levels entry level و advanced role. الانتري ليفل اللي احنا كلنا متعارفين او يعني متعودين عليه اللي هو الكالكوليشنز الكومباوندينج ميديكيشن يعني انفنتوري بيلينج فور فارماسي. هذه كلها تعتبر انتري ليفل. لكن الان فيه يعني توجه جديد حتى باي الاي اس اتش بي انه يصير فيه مور ادفانس رول للتكنيشنز يكونون مور يعني مور انفولد ان مور ادفانس رول مثل الميديكيشن هيستوري اسيستنس الميديكيشن ثيرابي مانجمنت اسيستنس الكواليتي امبروفمنت الاميونيزيشن البيشنت اسيستنس بروجرامز مثل زي الاديوكيشن الاديوكيشن والتريننج للاذر تكنيشنز او الجونيورز تكنيشنز في الاندستري ايضا في الانفورماتكس. في كل هذه يعني تعتبر اوجه جديده ممكن يتطور فيها الفارماسي تكنيشن. لو نيجي لوزارة الصحة فيها تقريبا حسب الداتا اللي كانت عندي يعني سابقا أكثر من 8000 تكنيشن معظمهم من الذكور و95% منهم سعوديز. فالعدد يعتبر يعني ضخم جدا على وزارة الصحة. فمهم جدا أن يكون عندنا يعني تطوير للمهنة تطوير المهنة التكنيشن. إذا طورت المهنة بيكون عندك يعني التكنيشن هذا ويل تريند بيكون تعطي انت فاليو للامبلوي نفسه في موتيفيشن للامبلوي في ايضا انك يو اتراكت يصير عندك الناس الكويسه. كل الناس كل ما يكون عندك يعني جود كارير باث يكون عندك ناس كويسه. ايضا بدل ما تطلع منك الناس او تحاول تبتعد او تطلع من المكان تجلس لان عندهم كارير باث واضح وعندهم كارير ديفلوبمنت واضح. فعندنا يعني 2 باثويز يا أنه يصير عندك كارير باث أو يكون عندك كارير لدر. الكارير باث أن التكنيشن يكمل الدراسة زي ما صار يعني معنا ومع كثير من الناس يكمل الدراسة يأخذ بكالوريوس وبعدين ينافس زي باقي الفارماسيست على باقي المهن. فعندهم فرص كثيرة مثلا السعودي FDA في الصناعة في الجامعات في السيلز والماركتينج في الهوسبيتال أو الكوميونيتي فارماسي في نبكو. ففي مجالات كثيرة الآن قاعدين ينافسون عليها الصيادلة. فلو حصل لهم فرصة أنهم يطورون أنفسهم ويكملون دراستهم راح ينافسون الصيادلة على نفس المهن. أو يكون عندك كارير لدر. بعطيكم تجربتنا إحنا في الحرس كيف الكارير لدر ماشي. التكنيشن يبدأ عندنا بتك 3 وبعد فترة معينة يخدم خدمة معينة وبعدين يخضع لاختبار ويترقى إلى تك 2 ونفس الفكرة بعد فترة معينة وبعد ما يخضع الاختبار يترقى إلى تك 1. فهذه كارير لدر يعني كويسة للموظف ما يحس إنه طول عمره قاعد تكنيشن على نفس الفئة 20 سنة هو نفس المسمى فارماسي تكنيشن ما يتغير فيه شيء غير اللهم الراتب يزيد أو ينقص. That's it. التكنيشن في النهاية هو موظف عنده طموح عنده أمل عنده أسرة وده يبني أسرة عنده متطلبات مالية عنده يعني رغبة في أنه يغير من مستواه الوظيفي من مستواه المادي. فزي أي موظف عشان كذا يحتاج أنه يصير فعلا عنده الموتيفيشن وعنده الحوافز أنه يتطور. فبعرض عليكم الآن بعض الأمثلة اللي يعني ما شاء الله يعني تكنيشنز وكانوا أمثلة مشرفة. مثلا عندنا أحد زملائنا ما شاء الله فارماسي تكنيشن مشارك في أبحاث. فهذا أيضا مجال ممكن يسعون فيه يعني يحس أنه لقى نفسه في الأبحاث أو لقى أنه غير من شوي من الجو اللي هو عايش فيه اللي الجو اليومي هذا اللي عايش فيه التكنيشن. عندنا مثلا في الحرس كان عندنا 3 تكنيشنز حصل لهم وكملوا دراسة ما شاء الله وذي بيكم فارماسيست أيضا كملوا بعد الفارماسيست وأخذوا الماستر. واحد منهم ما شاء الله الآن مانجر وفي الثاني راح للبلانينج الفارماسيكال بلانينج والثالث ما شاء الله الآن سينيور فارماسيست في سبيشالايز كارديولوجي ساتلايت. أيضا عندنا من 18 تكنيشن موجودين فيه 2 حصلوا مؤخرا على شهادة البكالوريوس. يعني هذه الأمثلة يعني تعطيك إن فيه تكنيشن فعلا ودهم يتطورون ودهم يتغيرون ودهم يعني يصنعون الفارق لأنفسهم وللمهنة. أيضا عندنا من الأمثلة ما شاء الله زميلنا نادر الشريم معروف ما شاء الله على تويتر على منصة تويتر كان فارماسي تكنيشن أيضا التحق في مستشفى الأمير سلمان مسماه السابق والآن ما شاء الله معه ماجستير في الكلينيكال. الدكتور مانع الدكتور أخذ عندنا ريزيدنسي كان تكنيشن، وبعدين ما شاء الله كمل أخذ عندنا ريزيدنسي في الحرس في البيدياتيك، والآن هو ما شاء الله البروجرام دايركتور. فالتكنيشنز إذا أعطى الفرصة ويعني ولقى المجال راح يتطور يعني ما هي بواقفة فقط على الصيدلي. الكارير باث الحمد لله يعني كان يواجه صعوبة جمة، ما كان عندهم جتهم فترة موضوع التجسير هذا توقف. وأنا أتذكر يعني الدكتور محمد شناوي الفريق اللي كانوا شغالين معه تعبوا جدا فعلا على أساس ما يوصلوا للمرحلة هذه. فالآن مع وجود التجسير والآن فرصة أن التكنيشن يقدر يكمل ويلتحق بالجامعات ويأخذ بكالوريوس وممكن يكمل يأخذ أيضا يعني ماجستير، هذه قفزة ممتازة لهم. هذا باب كان مسكر، لكن كمنطق ما راح كل التكنيشنز يكملون الدراسة. أنت لازم أيضا تفتح مجالات للي ما عنده رغبة أو اللي ما عنده القدرة وما عنده الفرصة أنه يقدر يدخل أنه يكمل دراسته. فلازم نطور من المهن الموجودة حاليا، من المهن الموجودة حاليا نسوي لهم أدفانسنج للرول حقتهم. فبعرض عليكم بعض الدراسات اللي شافوا فيها كيف لما وي أدفانس الرول حق التكنيشنز وي جين سم بنفيت يعني. فهذه دراسة أسست الإمباكت أوف فارماسي تكنيشن انفولفمنت على الميديكيشن ثيرابي مانجمنت. لو تشوفون الجدول الميديكيشن ثيرابي مانجمنت قبل الامبلمنتيشن وبعد الامبلمنتيشن بوجود التكنيشن تقريبا تضاعفت الام تي امز خلال فترة تطبيق البرنامج حق التكنيشن، برغم أن اللي كان متوقع الانفولفمنت حقهم يكون أكثر من كذا، رغم ذلك يعني تضاعف الإنتاج حق الفارماسيست. فالدراسة لخصت إلى أن التكنيشن انفولفمنت mostly often important identifying opportunity، يعني هو يقدر يراجع يقول والله هذه في فرصة أن نصلح medication management therapy، فينتبه لها الفارماسيست ويركز عليها. أيضاً the increased satisfaction بالنسبة لهم، يغير من وضعه، يحس أنها تطور شوي، صار يعني involve أكثر مع البيشنت كير. دراسة ثانية هذه عبارة عن systematic review included 33 articles were included to full review data and extractions. طبعاً هم identify what is the best training يعني mechanism للتكنيشنز هذولي، يا يكون عندك certification based programs أو training based programs. certification طبعا اللي تنتهي باختبار، أو يكون عندك on job training، أو ما بعد ما يتعين الموظف تسوي له يعني tailored training program. وجدوا أن الليتريتشر فعلا سبورت تقول هذا، لكن لقوا أن البنفيت indirect benefit، يعني هي كانت مجرد على الجوب ساتسفاكشن أو من التكنيشن يحصل على جدول أفضل من الجدول الحالي. لكن لو كان فيها بنفيت مادي، لو كان فيها سلم رواتب، بتكون أفضل بكثير، غير أنها مجرد فقط تحط برنامج ويبقى هو زي ما هو على نفس السلم الوظيفي حقه وعلى نفس الراتب حقه. الدراسة هذه أعطتنا what is the 5 best practice to engage pharmacy technicians into the clinical pharmacy service. طبعا الاختيار هو رقم واحد، انك تختار واحد فعلا interested وفعلا motivated انه يبي يتطور، مو بس واحد لانه يعز علي او لانه قديم خلنا ندخله معهم في الهوجة، لا، نبي واحد فعلا يبي يتطور يبي يتعلم. التريننج طبعا لازم يصير عندك good training program، لازم يصير عندك certification program، انهم يكونون معاك involvement في البيشنت كير، يكونون عارفين داخلين معاك في البيشنت بروسيس. وايضا في الاديشنال بروسيس عندك ميتنج على الكواليتي، عندك ميتنجز عن البيشنت سيفتي، involve them with you. وبعد ما تخلص التجربه disseminate الانفورميشن، سوي study او سوي مقال عن اللي صار وبلغ الناس شو اللي صار، لعله يعني في احد يستفيد من المقال هذا او يطور برنامج ثاني يكون افضل. فوجدوا فيه يعني مجال شاسع لتطوير التكنيشن. مثلا الميديكيشن ريكونسليشن، انهم ياخذون الهيستوري ابون ادميشن او يسوون ديسشارج ميديكيشن ريكونسليشن، فهذا كان لهم رول فيه. في البريفنتيف هيلث مع الاميونايزيشنز، انفولفمنت التكنيشن في الاميونايزيشن. في الامبلاتوري كير مثلا زي المثال اللي احنا اخذناه اليوم، لو كان عندنا الكوردينيتور اللي عيناه في العياده يكون فارماسي تكنيشن، فهذا ايضا بيساعدنا انه يكون مثلا انفولف في الميديكيشن بوكس كلينيك تشيكينج، الكلينيك انسبكشنز، الكلينيكال سبورت. فهذه ممكن يساعدونك في العيادات سواء كانت أنتي كوغليشن أو ديابيتيك كلينيك، فبيكون لهم رول لو أعطوا الفرصة وأعطوا برنامج تدريبي فيها. اللي يساعدون أيضا البيشنت كير والكاديكيشن، مثلا الاستعانة فيهم للتدريب على استيراد البرودكت بريباريشنز أو الكومباوندينج. البيشنت ادهيرنس ممكن يعني انفولف في البرامج حقت البيشنت ادهيرنس، they can monitor البيشنت ادهيرنس ومانج البروجرامز. الانفورماتكس الان كل شيء مبني على يعني الكترونكس، فالانفورماتكس هذه مهمه. they can analyze the data, they can use to maintain the data, they can use also other يعني data entry, they can be involved in medication safety يعني reviewing the chart, food يعني cause analysis, الadverse drug reaction، فهذه ممكن يساعدونك فيها. في الدراج شورتج again they can identify a shortage حق and they initial the stages of management. فهذه كلها برامج ممكن تطبق، ممكن تساعد التكنيشن انه يتطور من الرول الحالي اللي هو فيه. فوجدوا أن identifying and providing training facilitate their integration into the aspect of clinical pharmacist process of care. This improve the efficiency and allow the clinical pharmacist to focus on evaluating information and developing patient-centered plan for care. بدل ما يكون الكلينيكال pharmacist منشغل 100% في البيشنت كير، تشيل عنه جزء بسيط اللي يقدر يساعده فيه التكنيشن، وهو يتفرغ أكثر لأشياء ثانية ممكن تساعد البيشنت كير. أيضا ممكن يكون عندك ريزيدنسي بروجرام، يعني البرنامج أو المستشفى هذا طبق ريزيدنسي بروجرام سبيشالايز في البيدياتريك. أخذوا فارماسي تكنيشن أعطوه برنامج 50 أسبوع تقريبا، وطلع لهم منتج هم يفخرون فيه، يعني يقولون أن المنتج هذا يساوي تريننج أو يساوي يعني مدة طويلة من مجرد براكتسينج. فسووا تريننج بروجرام وكان سكسس بالنسبة لهم. ايضا الانفولفمنت في انهم ياخذون معلومات في مثلا خلينا نقول في الجناح مع الكلينيكال فارماسيست، مثل المعلومات زي ياخذون اللاب، الدياجنوستيك تيست، يساعدون في البيشنت ميديكال ريكورد، بيشنت اديوكيشن ماتيريالز، ايدنتيفيكيشن اوف ديسكريبنسيز. فهذه كلها خلت الكلينيكال فارماسيست او الفارماسيست يعني يصير عنده مساحة أكثر، يصير عنده وقت أكثر إنه يصلح تشارت ريفيو، وأيضا زاد البرودكتيفيتي حقته. ف this is the white paper from ASHB تقول إن إذا إحنا عندنا رغبة أو عندنا فعلا عندنا القدرة وعندنا الرغبة إن نطور في الأوبورتونيتيز موجودة، فإحنا لازم تكون عندنا رغبة إحنا أن نطور التكنيشنز، وأتوقع هذا شيء شغالين عليه يعني الآن في وزارة الصحة، وإن شاء الله تشوف برامج جديدة يعني. فأختم إن السبورت والديفلوبمنت of pharmacy technician for advanced and specialized roles via training, certification programs, including طبعا residency program, will improve patient care provided by both pharmacist and pharmacy technician, and will close the gap in the career ladder. Thank you so much. If you have any question, I'll be more than happy to answer.
Thank you so much, Dr. Khalifa, for your interesting presentation. We have next speaker, Dr. Abdullah Al-Maidan. He is a consultant clinical pharmacist at King Khalid Eye Specialist Hospital. He has PharmD from Campbell University at North Carolina 1998. Also, he has fellowship degree in pharmacokinetics and critical care neurology. Also, he has a master degree in health system management at Tulane University at 1999. So, welcome, Dr. Abdullah.
Assalamu alaikum jami'an. Good afternoon, everybody. First of all, I would like to thank the organizing committee for giving me the opportunity to participate in this meeting, and special thank to Dr. Mana for the introduction. My topic for today will be about pharmacy technician unique experience, which is a little bit different from the presentation from Dr. Khalifa. I'll emphasize on pharmacy technician as a career rather than continue to become a pharmacist or a clinical pharmacist. Main outlines: introduction about pharmacy technician, difference between pharmacy technician and pharmacy assistants, pharmacy strategic plan based on Vision 2030, advanced responsibility of pharmacy technician, pharmacy technician roles in new fields, the evolution of pharmacy technicians based on ASHP vision, challenges and recommendation to improve the pharmacy technician career. Introduction: the General Administration of Pharmaceutical Care and MOH started the new pharmacy plan in early 2013. The plan consists of 6 strategic goals, 17 initiatives, and 83 projects. The Kingdom of Saudi Arabia launched the Saudi Arabia Vision for 2030 with strategic plan in the next upcoming 15 years. Based on the new Vision 2030, all the pharmacy strategic plans were updated to make it compatible with the new strategies. One of the strategic goals of the pharmacy strategic plan within Vision 2030 was the pharmacy workforce, and here we are talking about pharmacy technician. Definition of pharmacy technician: an individual who works under the supervision of licensed pharmacists, assists in pharmacy activities that do not require the professional judgment of pharmacists. The pharmacy technician helps licensed pharmacists dispense prescriptions, medication to customers or health professionals, and pharmacy technician's scope of service is to work with all healthcare providers and perform wide range of tasks related to medication and a practice setting, depend on their qualifications and training. Some demographic data sourced from the U.S. Bureau of Labor and Statistics: the number of pharmacy technicians working in the United States has grown from 165,497 to 420,400 in 2018. The average salary in 2020 for pharmacy technician was $35,100 per year, which is equal to $16.87 per hour. The projection of job market for pharmacy technician will grow by 7% between 2018 and 2028, adding 31,500 new positions. What are the requirements or the qualification of the pharmacy technician and pharmacy assistant as per the Saudi Commission for Health Specialists? Pharmacy technician need 2 years associated degree for pharmacy technician from accredited academic institutions by the Ministry of Education after high school degree, as well as passing the license exam. In regard to the pharmacy assistant, only 1 year required to become assistant pharmacist. Main responsibility of pharmacy technician, as Dr. Khalifa mentioned earlier presentation: measuring amount of medication for prescriptions, packaging and labeling prescriptions, compounding pharmaceuticals, organizing inventory and floor stock, collecting information needed to fill the prescription, and entering customer information into computer system. The main responsibility of pharmacy assistant is to provide support to both the pharmacist and to the pharmacy technician in carrying out the technical function of the dispensing process, and also he can work similar to the pharmacy technician if he was or she was competent to do so. Taking into consideration, he needs to work under the umbrella or the supervision of pharmacist or pharmacy technician. Pharmacy assistant do not require to have a continued educational requirement and no need to be a member of any regulated health profession. What are the main characteristics for pharmacy technicians? In case of knowledge, he should have a good mathematics, problem-solving, language, medical terminology, and organized inventory. And regarding to the skills, communication skills, computer skills, and time management skills. For attitude, He should have ethical standards, willing to follow instructions, engagement in any type of work, and willing to learn ability to work in multi-team. As I mentioned earlier, one of the strategic goals of the pharmacy strategic plan in Vision 2030 was the pharmacy workforce. As we can see here in this slide, we have 3 initiatives. It was included in the vision related directly to the pharmacy technician. The first one, start development training program to worker in pharmaceutical care department at healthcare. And the project for this initiative was starting a bridging program for pharmacy technician to the BS and PharmD programs. The second one, improvement ergonomic administration department and sections of pharmaceutical care services at Ministry of Health Hospital and Primary Care. The project for that was the effective and best utilization of pharmacy technician in all healthcare setting. And the last one was monitor the cost efficiency and rationalize spending department and section of pharmaceutical care department at Ministry of Health Hospital. And the project was start measuring the productivity of pharmacy technician. And this study can show us the employment opportunity within the kingdom between 2006 and 2017. As we can see here, we have 3 types of ratio, 1:4, 1:2, 1:3, which means 1 pharmacist will oversees 4 pharmacy technicians, or 2 or 3. And based on the new strategic plan, 2018 and 2030, to the right, you can see the number jump almost 50% increment, which means there is a high need for this kind of career. Again, in this slide, we can see some statistics regarding the number of pharmacy technicians, male and female, compared also Saudi and non-Saudi. As we can see here, between 2006, the number was almost 3,000 something, and in 2017, it reached almost 8,000 for the male pharmacy technician. And also, we can see the gray line for the female also start to increase during this period. Regarding the traditional assignment or the activities for the pharmacy technician, we can see it on the top 5 or 6 lines, talking about floor stock, packaging, compounding, billing, filling automation machine, etc. But after the advancement in the career of the pharmacy to work as a clinical pharmacist and start to providing medication therapy management service instead of dispensing or distribution medication, that give the chance for the pharmacy technician also to have advancement in their career. In addition to that, there are another reason for increment in the job opportunities for the pharmacy technicians. First, increased population of the elderly. According to one of the studies in WHO, that they said the population for the above 60 years of old between 2015 to 2050 will increase from 12% to 22%. Also, increase access to prescription drug coverage, and here we are talking about insurance companies. Increased incidence of chronic disease require multiple medication management. Again, according to the WHO, they indicate that there is a projection to increase the chronic disease on 2022 by 60%. Increased scientific advance and research ratio into new drugs. As everybody noticed, there are too many new drugs have been introduced to the market. For example, in 2018, almost 60 drugs have been introduced as a novel drug. In addition to the increased pharmacist responsibility to be involved in the management of patient care. Here in this slide, we can see a comparison between the non-traditional activity for the pharmacy technician before and after. As we can see here to the left in the pie, the orange color, traditional and the preparation and distribution was almost 79%. If we compare it to the green color, the non-traditional, it was almost 80%. After the new assignment and responsibility, the traditional work decreased to 68%, while the green color jumped to 18%, which means there are too many careers starting to be opening for pharmacy technician. As we can see here in community pharmacy, home healthcare agencies, mail order pharmacists, pharmaceutical wholesalers, health insurance, medical computer softwares, and long-term care facilities. This study, I believe, it was covered in the previous presentation, but my comment was on the conclusion that once the pharmacy technician and the other support personnel are both engaged in supporting the direct patient care process, they must be provided opportunities for advancement and growth in their institutions. A second study talked about the role of pharmacy technician in economic benefits related to cost saving. A total of 16 publications were eligible for this type of article. The pharmacy technician participate at advanced scope led to both cost saving and time saving. It includes 6 studies related to cost saving, 6 reported for time saving, and 4 reported for both time and cost saving. During the studies, they found there are 10 of them. It talk about cost saving from 4,526 Australian dollars to 88,009. Lead the hospital to expand their incentives and technician workforce. This study is considered one of the earliest studies talk about the ability for the pharmacy technician to enroll for an administrative immunization. At the conclusion from the study that from December 2016 to 2017, the technician administered 953 immunization with 0 adverse event report. During the COVID-20, there was also an article published regarding changing in the ratio of pharmacists to cover or oversees the pharmacy technician. As we can see here in 7 states in America, they changed the number. Instead of 1 to 3, 1 to 4, they make it 1 to 2. And as in the pie, we can see it reached almost 44%, which means there is a high confidence in pharmacy technician to do many or different type of jobs. In the next 3 or 4 slides, I will talk about examples about the pharmacy technician roles in different areas. I will just highlight the main point. For example, in automation, maintaining and troubleshooting automation, assisting in the configuration of the new devices, monitoring inventory based on the bar level, ensuring integration between the systems, performing a quality assurance audit, ensuring the medication that are barcoded and will scan accurately. Another example in community pharmacy, technician receive written prescription requested from patient or electronically from the physician to prepare the prescription, also to establish and maintain a patient profile as well as process insurance claims, vaccine administration, medication reconciliation, and here we're talking about taking the history of the patient and make sure there is no duplication using their medication. And also pharmacy technician can perform final verification of a prescription that have been previously reviewed by a pharmacist, and in too many articles they use terminology, technology, or tech versus tech, which means you have the ability to review the prescriptions. Investigational drug, collaborate and cooperate with other members of study team, monitoring the protocol compliance, assisting with the database management of the study, ensuring compliance with the regulation, policies, and study protocols, assisting with preparation of the job aids for orienting and training for the protocols. Last example, in quality and medication safety, they can oversee also the medication errors, medication adverse events, drug recall condition, maintain staff competency database, pharmacy staff education, assist in pharmacy operation and identifying opportunity to improve the efficiency and quality and the safety within the pharmacy department. Now I'll talk about the evolution of pharmacy technician based on the ASHB Pharmacy Forecasting 2020, and they indicate that the growth of pharmacist role across the healthcare setting has led to the need for a new model and a comparable evolution in the responsibility and roles of pharmacy technician, specifically during the COVID pandemic. The pharmacy technician have been increasingly called to take responsibility for both clinical and operational functions to help the pharmacists in their task toward direct patient care. The clinical functions such as conducting a medication reconciliation, delivering bedside medication, facilitating medication therapy management, preparing home infusions. And for the operational, dispensing prescription, monitoring inventory and flow stock, perform prescription monitoring program, perform remote data entry of prescriptions, and providing insurance formulary guidance. And the final recommendation of the SHB in order to establish a national standard of the pharmacy course, emphasize on the competency expectation required of pharmacy technician completing a credit training program and the assessment of those competencies by the program itself, address the structure and process related elements within the training program necessarily to implement the evidence-based outcome measures. Lastly, advance the quality of pharmacy technician education and training program. And these are some of the example of the board, for example, Pharmacy Technician Certification Board, American Association of Pharmacy Technician, that also involve in the advance the career of pharmacy technician. What are the main challenges of pharmacy technician career in Saudi Arabia? First, limited career structure and lack of opportunity to advance the practice ladder or expand the scope of practice rules of pharmacy technician. Lack of pharmacy technician accredited educational programs within the School of Pharmacy in addition to Pharmacy Technician Society. The rules and responsibility of hospital pharmacy technicians and community pharmacy vary significantly within the workforce. And the last thing, the absence of clinical pharmacist services or patient counseling services with some of the MOH institutions. Recommendation to over these kind of barriers, it will highlight on 3 aspects. The first one, the organization focus recommendation. Healthcare system should require a technician to be certified by a pharmacy technician certified board, and this type of board should be developed by MOH and the Saudi Society for Health System. In addition to pharmacy department should foster the development of professional career path or career ladders. And regarding to practice focus recommendation, the pharmacy technician should participate and advance the role in all practice setting to promote efficiency and take more responsibility for advanced technician and supporting activities. And the last one, regarding the profession, scope of a practice include core competency and clear job description should be developed, and in addition to a national training standards. Conclusion, developing advanced role and baseline of skills and competency for pharmacy technician frees the pharmacist to focus on clinical activities and improve patient care. Thank you very much.
Thank you so much, Dr. Abdullah. We will start our discussion. بس قبل ما أبدأ بأسأل في أحد فارماسي تكنيشن معنا هنا؟ واحد. يا ريت تطلعون قدام، ممكن تطلعون قدام عشان يكون فيه انتراكتيف يعني. Thank you so much for that. Thank you so much for your discussion, your presentation. And also it's very important to focus on pharmacy technician. So my question to you, Dr. Khalifa and Dr. Abdullah, regarding established programs for pharmacy technician, like residency. For example, if we have some residency for 1 year for pharmacy technician, for example, for IFE or compounding, do you think it will be helpful for them to improve their practice for them, and also for about to avoid burnout? As we know, if we still or pharmacy technician for long time, I think it's not good for them. So, what do you think if we can start programs for them?
I think this is a very nice question. I totally agree with what you said, since I believe also Dr. Khalifa mentioned in his slide, there are too many trials have been tried in different hospitals. These kind of trials should be collected at one time by a committee or scientific committee and start to study these kind of initiatives and see what's advantage, disadvantage, and also do a benchmarking with ASHB and another country who has advanced role in this kind of residency program. And with collecting all these kind of information, you can create a residency program in addition to the other aspect, as I mentioned, the ladder and the career path within the hospital.
Totally agree مع دكتور عبد الله أن فعلا these programs should be assessed. ممكن تكون لجان تشوف مدى how efficient having such a program in our country. We are moving toward more development of pharmacy عندنا في البلد. مثلا we need informatics deeply. We need specialized training technicians في certain areas. الأشياء اللي نحتاجها مثلا زي الكيموثيرابي، البيدياتريكس. هذه الأشياء أتوقع أنها need focus from us. إن we go through these articles or these studies, we study them thoroughly, and we submit proposals to the approving agency, and we see where we can go from there.
Thank you. Any question from the audience? Abdurrahman? أنا أبغى الفارماسي تكنيشن هم اللي يسألون علشان هم اللي يحسون بالمعاناة، فأبغاه يطلع اللي عنده علشان ممكن يفتح شيء بحيث انهم يساعدهم. الحين مرينا، انا كنت فارماسي تكنيشن، مرينا بصعوبات الحمد لله عدينا، لكن انا اسال الفارماسي تكنيشن هم اللي الحين احس انهم يعانون. ان شاء الله احنا نقدر نساعدهم شيء. تفضل استاذ.
طيب، اول شيء الله يعطيكم العافيه على الطرح الرائع جدا. سؤالي من باب السلامه الدوائيه، وانا مهتم في السلامه الدوائيه. دائما ما يقال مثلا في حال الخطأ أي عمل المفروض يقوم بصيدلي وقام بفارماسي تكنيشن. في حال وقوع خطأ، هل النظام يعفي الفن الصيدلة من العقوبة فرضا؟ مثلا في صرف خطأ، دواء خطأ، مات مريض، أو كالكوليشنز، أي الأشياء المفروض يقوم فيها صيدلي وقام فيها فارماسي تكنيشن، هل في نظام ينص بأنه ممكن الفارماسي تكنيشن يكون خارج العقوبة فرضا؟
طبعا يمكن أنا ذكرت في المحاضرة، احنا الآن الابروتش ان from traditional to non-traditional assignment أو التغيير اللي قاعد يصير، هذه يحتاج إلى نوع again for preparations. ما تجي في يوم وليلة أنه يتم تغيير responsibility of pharmacy technician to على طول يبدأ يعمل review للprescriptions، يعمل verification و etc. احنا نتكلم لازم يكون عندنا بروجرام كان well organize program يكون في طبعا نوع من السيرتيفيكيشن ونوع من الاكزام in order to make sure that once the pharmacy technician passes from all these kind of criteria or demands he is ready انه يبدا يعمل نوع من الفيريفيكيشن الوصفه. فهذه راح تكون ما تجي في يوم وليله، محتاج لها عمل، محتاج لها يعني نوع من البروجرامز اللي تنظم بشكل تحت الامبريلا للام او اتش طبعا والسعودي كوميشن، وعلى ضوءها تبدا التغيير في الاساينمنت.
دكتور نادر الشريم.
السلام عليكم. First, I would like to say thank you. My name is Nadir Shreem, the internal medicine clinical pharmacist and manager of clinical pharmacy at King Abdullah ibn Abdulaziz University Hospital. First, I would like to say thank you for your presentation, Dr. Abdullah, Dr. Khalifa, about the pharmacy technician career and the chances and the opportunities for our colleagues, the pharmacy technician. Also, I would like to say thank you, Dr. Khalifa, for speaking about me and including me among your presentation. Really, to be honest, since 18 years, I'm trying to follow your step and hopefully one day to reach your level. My question for both of you, did you start in your institution to expand in job description for the pharmacy technician to include more activities, as you mentioned in your presentation, or it's need to be an approval under the umbrella of law from the Ministry of Health or the Saudi Commission? Thank you.
I'm not aware that we are starting to expand because we are satisfied with the career ladder that we have. We have 3 career ladders and technician can reach tick 1 with a good salary, to be honest. The technicians there are satisfied. So satisfied financially and satisfied من ناحية الوظيفة. I don't think we are started to implement such a thing، لكن أتوقع النيد بيكون موجود أكثر في وزارة الصحة اللي فيها العدد الأكبر، تقريبا أكثر من 8000 تكنيشن، وهم اللي فعلا عليهم الضغوطات أكثر. أنا يمكن فاهم مقصد الدكتور عبد الرحمن، أن بعض الأحيان يكون التكنيشن هو اللي قاعد يغطي عمل الصيدلي.
We're facing that one. We're covering the pharmacist role.
أنا كنت تكنيشن في السابق وكنت فعلا أقوم بدور الصيدلي، كأني أنا الصيدلي. فمثل هذه الأشياء هي اللي فعلا تحط ضغوط على التكنيشن، أنها ليه متى وأنا كذا، طيب أنا أبغى أتطور، أبغى يصير عندي فرصة أفضل، طالما أني أنا قاعد أسوي الجاب اوريدي وعلي المسؤولية، فليش ما أتطور؟ فهذه الأشياء صراحة اللي يحتاجها أكثر هم وزارة الصحة. هذا في رأيي الشخصي.
So, Doctor, do you mean that in your institution that there is Tech 3, Tech 2, Tech 1? Is there different in job description or just not?
Yes, there is a different job description and there is a difference in salary and responsibilities. Tech 1 is the highest, so he's the most senior.
Thank you, Doctor.
الفارماسي تكنيشن بليز، ابغى اشوف الاسئله، استفساراتكم، اقتراحاتكم. هذه فرصه ودنا يمكن تفتحون عيوننا على حاجه ممكن نقدر احنا نسويها.
السلام عليكم، يعطيكم العافيه دكاتره. صراحه لمستونا بهالامر، لاول مره احد يهتم في فنيين الصيادله في اي مؤتمر أو محاضرة. إحنا كنا في كل مرة نحضر نتمنى في أحد يلتفت لها الأمر، لأول مرة الحمد لله وفقنا فيه. أنا أبغى أسأل دكتور خليفة، لما تفضلت وقلت إن في فرص لكن إحنا نبغى رغبة. أنا من الشرقية وأقول لك إحنا ما عندنا فرص في الشرقية، ولما ينزل أي إعلان لأي جامعة في المملكة سواء من الشمال إلى جنوبها مؤخرا إلى مكة نتعنى ونسافر عشان نسجل، يكون الإجابة لأهل المنطقة. طب إحنا في الأخير كلنا سعوديين، ما أعرف بس في هذا الموضوع نصنف على المنطقة. إذن إحنا ما حصلنا على فرصة. أنا بدون مبالغة 12 سنة أشتغل، من أول ما كملت السنتين إلى يومك هذا أجهز أوراقي سنويا سواء للابتعاث أو لأي فرصة تجسير في المملكة وما نحصل عليها. مع أنه يكون كل شيء عندنا ممتاز، ما عندنا ولا شيء جيد جدا وما تحصل الفرصة. يعني ما أعرف هذه كيف إن إحنا نحتاج رغبة عشان تجينا فرصة، أو تقول الفرصة موجودة بس محتاجين رغبة. يعني إحنا قاعدين نشوف الفرص سحاب، نشوفها بس ما نمسكها. يعني أنا أتمنى أنت تعطيني الطريقة اللي إحنا نقدر نواصل فيها ونوصل للشيء اللي أنتم وصلتوا له واللي إحنا فخورين فيه يعني.
الله يعطيك العافية. فيما يخص يعني التجسير، هو وقف فترة طويلة، وزي ما قلت لك يعني كان في ممانعة، والرجال هذا دكتور محمد يعني سوى المستحيل على أساس يقدر يحصل الفرصة هذه. أنا يعني كنت شاهد على جزء بسيط ترى من اللي صار، يعني واجه ممانعة من أكثر من جهة. ما كان فيه يعني خلينا نقول تعاون من الجامعات. فالآن بعد ما فتح إلا من قريب ترى، وما فتح إلا في الغربية. الآن صدقيني الجامعات هي راح تتواصل مع وزارة الصحة، راح تطلب منهم يعني الآن أن نبغى نسوي عملية تجسير ونبغى نبدأ برامج. لكن تخيل يعني الموضوع هذا كان مسكر فترة طويلة وتوه ينفتح الآن، يبي له وقت. يعني ما راح يعني تتوقعين أنه راح ينتشر على طول على مستوى المملكة. حاليا الظاهر على مستوى المنطقة الغربية، لكن يعني فور ديفنتلي يعني يمكن الدكتور محمد يجاوب أفضل مني. فور ديفنتلي يعني موف للأذر سيتيز، لكن الأشياء ما تجي كلها دفعة واحدة. ولاحظي زي ما قلت لك كان الموضوع مسكر تماما، وكان الدكتور يواجه صعوبات ما يعلم بها إلا الله.
طبعا إذا في صعوبة في الجامعات الحكومية مثل ما أنت تفضلت، طيب ليش ما يكون في التفات على الجامعات الخاصة؟ يعني إحنا زميلات عندنا حتى بعد ما تكمل وتاخذ البكالوريوس تركنها بالدرج. ليه؟ لأن أنت توظفتي as technician. يعني هي ما في مساعدة، حتى لما أنت يعني تتكلفين بالأمر هي بالأخير ما راح تصنفين يعني.
لا، هو السبب الأساسي ترى لإيقاف الموضوع كله كان موضوع يعني الموضوع التجاري، فكانت المخرجات شوي يعني أقل من المستوى المطلوب. هذا أدى إلى أن فعلا الباب هذا يتسكر وتسكر فترة طويلة. وزي ما قلت لك يعني تعبوا الأخوان في الوزارة على أساس يعيدون فتح الفرص للتكنيشن. ترى يعني ضغط عليه جدا انه يكون عنده حوالي 8000 موظف يبغى يطور نفسه وهو ما قاعد يسوي لهم شيء. فالموضوع يعني تسكر بسبب انه كان تجاري، والان رجع فتح من جديد. يبي له فتره، يعني لا تتوقعين الامور تتعدل بسرعه، يبي له فتره وان شاء الله الخير جاي.
طيب بخصوص اقتراحاتك يعني على الادفانتج يعني المجالات اللي ممكن يتطور فيها فني الصيدلي، هي مجرد اقتراحات من عندك ولا هي فعلا راح تفعل في المستشفيات؟
لا، هذه دراسات عملت اوريدي، موجوده في الغرب، موجوده وعرضتها انا وعرضها الدكتور، لكن تحتاج لها تطبيق عندنا هنا. لسه الان يعني الفرص موجوده، لكنها في الغرب اوريدي موجوده.
طبعا
بالنسبه لنا لا.
وبعد تفعيل برنامج وصفتي في المستشفيات ونزل مستوى العمل كثير، ايش توقعاتك لمستقبل فنيين الصيدله؟
هذا بخلي الدكتور محمد يجاوب عليه.
السلام عليكم، يعطيكم العافية جميعا. شكرا جزيلا. أنا يمكن ما حضرت يعني عارف النقاش حامي، بس سمعت السؤال حق الأخت الفاضلة. طبعا أيوة زي ما قال الدكتور خليفة، يعني كان الموضوع متوقف بشكل كامل في جميع الجامعات. كان ممنوع على كل الجامعات أن هي تبدأ برامج التجسير. الآن والحمد لله بدأت جامعة، وعندنا حاليا طلب من 4 جامعات أخرى في مناطق مختلفة من المملكة لفتح برامج تجسير. فهي الشرارة الأولى بدأت، ولكن يا جماعة احنا نبغى يعني نكون صريحين مع بعض. المهنة تعتمد على وجود فني ووجود صيدلي. مو الهدف أبدا إن أنا أحول كل الفنيين اللي عندي إلى صيادلة، يعني ما يعني مستحيل، ما راح يحصل. ولكن عندنا تارجت إنه المميزين يتحولوا إلى الصيادلة. نفس الكلام اللي هو على الماجستير. هل أنا مثلا لما بفتح ماجستير الهدف حقي إنه كل اللي موجودين يأخذوا ماجستير؟ لا، فئة معينة المميزين اللي بيستوفوا الشروط هم اللي ممكن يأخذوا الماجستير، مو الكل. فطبعا يعني راح يكون في سelection، ويكون السلكشن اللي هيطلع حاليا في الوقت الحالي هيكون جدا صعب، لأنه عندنا البول حاليا اللي موجودين من الفنيين، من الزملاء الفنيين حوالي 10,000 فني أو أكثر من 10,000. البوزيشنز اللي هتنفتح 20 مقعد حاليا، ولا في جامعة ترى ممكن، ولا في أي جامعة في المملكة هتقدر تاخذ أكثر من هذا العدد، لأنه الجامعات عندهم الطلاب الاعتياديين اللي هم بيدرسوهم، فهياخذوا هذول الطلاب أوفر عليهم، فهياخذوا العدد هذا وهيبدأوا فيه. ولكن الحمد لله الآن بدأنا. هل فقط أنا متأكد أن الدكتور عبد الله والدكتور خليفة وضحوا جدا أنه مو بس فقط التجسير هو الحل الوحيد للفنيين. عندنا ريزيدنسي بروجرامز ممكن انه يكون ابروفد، ممكن انه يكون موجود. عندنا برامج تطويريه وتدريبيه ممكن الفنيين يدخلوا فيها كمان ويكون عليها تحسين. ففي اشياء اخرى، دورات كثيره جدا، يمكن من اولها هذا يعني المؤتمر اللي احنا جالسين فيه يا جماعه. يعني كان كلام قبل كذا كل المؤتمرات اللي بتقام للصيادله، بتكون موجهه للصيادله، كل الكلام كله بيكون في المحاضرات موجه للصيادله. الان عندنا محاضرات وسيشن كامله موجهه الى الفنيين، موجهه هاو تو امبروف الفنيين. فهذا كله تطور حاصل بالنسبه للفنيين، كله يجي مره واحده زي ما قال الدكتور خليفه، لا راح ياخذ وقت ان شاء الله، بحيث ان هم يكونوا عضو فاعل في الكادر الصيدلاني في جميع المناطق. شكرا جزيلا. تسلم.
يعطيك العافية دكتور محمد. أي أسئلة؟ Any question from the audience please?
السلام عليكم ورحمة الله. شكرا دكتور خليفة ودكتور عبد الله. شكرا دكتور خليفة دكتور عبد الله. I have a question regarding two names or two titles, pharmacy technician and pharmacy assistant. So what was the need for the pharmacist assistant? What exactly? It's not a professional degree, it's not a profession by itself. So how is that impacting even graduates أو الناس اللي تبغى تكون this pharmacy assistant that's really clouding everything?
أنا frankly speaking I saw هذا التصنيف حقيقة باللائحة الفنية للسعودي كوميشن حقيقة لفت انتباهي even though there are يعني very rare موضوع بهذه الفئة أو الجروب اللي هم عندهم pharmacy assistant even though لازم ناخذ بعين الاعتبار أن الآن قد يكون في بعض المستشفيات فيها يعني نوع من الشورتج من ناحية الفارماسي تكنيشن، وقد يكونون هذول الأخوان متواجدين. طبعا من قراءتي بعض الأماكن أكثرها تتكلم على general health informations وليس pure pharmaceutical informations. يكون أخذ مثلا نوع من الوركشوب أو الكورسز اللي صار فيه he is qualified to become assistants، لكن in reality حقيقة هو ما دخل بالفيلد الرئيسي اللي هو مثل يعتبر as a pharmacy technician.
شيء الخير بالنسبة الهيومن ريسورسز وزارة العمل، أتوقع أنه بالنسبة للصيدلي الفني it's not a title حاليا as a profession. Is that correct or what do you think about that? What do you know about that as a profession, pharmacy technician?
Well, هو موجود يعني طالما موجود باللائحة وحاطين الكواليفيكيشن ريكوايرمنتس لازم يكون تحت مصنف أو وزارة الصحة تحت فني صيدلي. بس even though أنا يمكن خلال المحاضرة اللي تكلمت فيها أنا insist على موضوع إنه how we can advance the role of pharmacy technician within our community. مثل ما تعرفون يمكن الآن صار في الآن شح في النون سعودي pharmacy technician frankly speaking، فصار في طلبات كثيرة على المهنة. فأنا أتوقع مثل ما تفضلوا الأخوان يعني كارير باث هنا مهم، أو مثل ما تفضلت الأخت قبل شوي إنها جلست فترة على نفس الليفلز، لازم يكون في كارير باث للفارماسي تكنيشنز levels 1 level 2 3 مثل ما ذكر الدكتور خليفة، أو I'm sure there are another أو senior technician. في مسميات كثيرة طبعا لازم يكون فيها نوع من الكومبنسيشن، يعني ما نتكلم فقط على titles. Financial compensation, managerial compensation, something like that. فأتوقع ممكن يوصل بطريقة صحيحة.
إذا تسمحوا لي بس أنا يمكن ما جاوبت على موضوع الدكتور خليفة قال حول علي اللي هو موضوع وصفتي. وصفتي دخل إلى وزارة الصحة وزادت أعداد الصيادلة في وزارة الصحة 30% ولم تقل، ولم يتم الاستغناء عن أي صيدلي ولا فني صيدلي في وزارة الصحة. بالعكس تم تحويلهم وتم عمل النصيحة أن هم يروحوا يشتغلوا في المستشفيات في أقرب مستشفى. وصفتي دخلت في مراكز الرعاية الأولية وتدخل الآن في المستشفيات ولم يقل أي فرد واحد من عدد الصيادلة. بالعكس هيدخل كمان أوتوميشن وأجهزة أتمتة إلى المستشفيات. وأنا يعني الدكتور عبد الله موجود كمان، خبرتي في التخصصي في الأجهزة فيها التخصص فيها كل الأجهزة اللي ممكن تخطر لأي أحد على بال، سواء في الانبيشنت فارماسي أو في الأوت بيشنت فارماسي أو في البريباك. لم ينتج في مرة من المراحل إنه قلنا والله أو راح ننقص عدد الموظفين علشان جبنا جهاز. بالعكس أنت بتحتاج أكثر فنيين وبتحتاج أكثر صيادلة. فالموضوع يعني لا أحد يربط ما بين جهاز وما بين صيدلي وما بين فني أو سيستم أو نظام. يعني أتمنى أني جاوبت على السؤال، آسف لو كنت نسيته يعني. شكرا.
Any questions؟ أي أسئلة، أي استفسارات؟ So we will close our session. Thank you so much, Dr. Khalifa. Thank you so much, Dr. Abdullah, for interesting discussion.
Thanks, Doctor, for your interesting discussion. And now, I'd like to invite Dr. Mohammed Shinawi to thank our speakers. دكتور خليفة الذياب. دكتور عبد الله الحميدان. دكتور مانع المنجم. شكرا، يعطيكم العافية. Dear audience, now we will proceed to our last session for today, which is about research collaboration future. Please let's welcome Dr. Thamer Shamari as a moderator for this session.
Assalamu alaikum. Jazakumullah bil khair. So today, inshallah, we'll be having our last session on the area that I love, and with the great speakers with me today. So this will be about research and the future of research, and I have two very well-known speaker in the area. Today we'll have Dr. Yazid Arthaya and also we'll have Dr. Maher Ammari. So I'm sure all of you know them. I just got to mention them, to introduce them quickly. They have really long history of research and history of practice and history of CV. I'm proud that Dr. Maha, she was one of the people that I taught, or she taught me while during my training. So I'll start first with Dr. Yazid Arthaya, who will gonna talk about research collaboration or the future of research collaboration. Dr. Yazid, he is Associate Professor of Health Policy and Pharmacoeconomics at King's College of Pharmacy, King Saud University here in Riyadh. He got his bachelor degree in pharmaceutical science from King Saud University, and he's got his PharmD from Massachusetts College of Pharmacy and Health Sciences from Boston, the United States. And he went to South to get his PhD in health outcomes and policy from University of Tennessee Health Science Centers, and he finished in 2012. As I mentioned, so 2015. As I mentioned, Dr. Yazid will talk about the future collaboration in the research. Please welcome Dr. Yazid.
Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I'd like to thank the organizer of this interesting and great event for their kind invitation. It's my honor and pleasure to present today about a topic that is a little bit actually controversial and interesting at the same time. I will actually try to poke and stir the water that is stagnant in some areas so we can get to know each other and collaborate, inshallah, in the future. All right. Okay, do you hear me now? Okay, great. Okay, so the objective of my talk today are very simple and straightforward. First, I'm going to discuss the status of research outputs in Saudi Arabia, GCC, and our board. Secondly, I will list some challenges in conducting research in this part of the world. Thirdly, I'll discuss some challenges in research collaboration. I'm going to spend a little bit of time on that. And last but not least, explain why research collaboration is very important. All right. So let's take a look on the ratio of research and development spending or expenditure in relation to the GDP or the gross domestic product in different GCC countries or the Gulf Cooperation Council countries. If we actually, let me see here. Okay, if we look at, for example, Saudi Arabia, it spends about 0.8% of its GDP on research and development, which is 1.7% short of the average OECD countries. OECD countries are the countries of Organization for Economic Cooperation and Development. So we're 1.7% short of what we need to spend in order to innovate our economy and diversify our revenues. Qatar is 0.5, United Arab Emirates is close to us, 0.9. This doesn't mean that Saudi Arabia is spending less than the other GCC countries. No, Saudi Arabia is spending more. However, since the Saudi GDP is about $800 billion annually, so we still need to spend more, about 1.7% in order to be with the average of other OECD countries. How about the ratio of publication per 100 or 1,000 inhabitants? As you can tell, Saudi Arabia and United Arab Emirates in the same liver tier in comparison to Qatar, which is about 1.7 publication per 1,000 inhabitants. This is based on the World Bank statistics, and the rest of the GCC are actually falling behind this level. How about the organizations, the Saudi organizations, and their contribution to research in Saudi Arabia? We have more than 30 universities. We have different private and public healthcare institutions. However, as you can see here, the King Saud University alone contributes about 33 or 35% of the total research output annually in the kingdom. And this has been conducted between, just looking at the research published between 1980 to 2014. King Abdulaziz University, research output contributes to about 15% of the total research output between 1980 to 2014, followed by King Fahd University of Petroleum and Minerals, and then King Faisal Specialist Hospital, and then KAUST, or King Abdullah University for Science and Technology. So it tells you that about 4 or 5 organizations are contributing more than 2/3 of the research output on an annual basis, which means that there is a problem that needs to be fixed. All right, how about the percentage of papers with or without collaboration? Looking at the same period between 1980 to 2014, as you can tell, the number of research without collaboration represents only 19% in comparison to domestic collaboration, about 34%, and 47% international collaboration. And here we need to be very careful about international collaboration, because international collaboration has different meanings and definitions. I'm not sure if I just want to be diplomatically correct and politically correct. I'm not going to actually explain that to you here. I can explain that privately to you afterwards. But let's keep it at this actual level or of talk or frankness, and then we can discuss it later, inshallah. I'm trying to be diplomatic as much as possible. All right? So where is actually collaborations happening? Most of the collaboration happens with international collaboration, happens with what? With the United States. And this is due to the fact that many actually of the graduates graduated from the United States. And many of their research publications with their affiliations happens when they are studying in the United States. And when they come back, they can sometimes continue their collaboration with the United States and Canada. Egypt actually is second, given the fact that many actually faculty members from Egypt come here and collaborate with other researchers in their respective universities, followed by other actually India and Pakistan also, Germany, China, India, Australia. We have noticed an increase of publications coming from India and China in the last 5 years for reasons I'm going to discuss later, inshallah. And I'm sure that you have heard about the ghostwriters and the mock publications and the predatory journals. These are actually things that we need to tackle and overcome, inshallah, in the near future. All right. So contribution. Here's actually the national contribution and citation per paper and the 10 most productive institutions in the Arab world, and these are precisely for medical research. So quantity is important, but quality is more important. For example, the American University of Beirut in Lebanon contributes to about 63% of the national research contribution in Lebanon alone, 63%. And the average citation per paper is about 13.8%. King Abdulaziz University contributes about 90% of the total contribution in Saudi Arabia, and the average citation per paper is 13. How about King Faisal Specialist Hospital? Its contribution is about 9%, and the average citation per paper coming out of this institution is about 12.7 citation per paper. How about King Saud University? Although I'm from King Saud and I like to see more actually citation, contributes about 39% of the total research output in the kingdom. However, the average citation per paper is 8.3%, which is about 5 citations lower or short of King Abdulaziz University. Something that I hope to see improvement in the near future. How about the impact of research collaboration on paper citation? If we just take a look and see what kind of impact the collaboration will have on the number of citations per paper. This is was taken from Saudi Arabia in the year of 2017, as of November 2017, and it tells you here that the average citation per paper for any research project that did not have any collaboration is about 5.4 citations per paper, in comparison to 8.5% when there is a collaboration with other Arab country. And 18.5 citations per paper if there's a collaboration with other countries in the European Union. This actually increased to 21.2 citations per paper if there's a collaboration with a university in North America, United States or Canada. So collaboration improves quality, improves citation, improves the visibility of your paper. So what are the common challenges in conducting research? First of all, the value of graduate studies. I still remember when I actually joined the university some time ago, about 13 or 14 years ago, they told me, don't go for the PhD. You will bury yourself. It's a waste of time. Don't go there. Focus on PharmD, residency, and come back, because PhD is a waste of time, and you will come and no one will help you. Inability to demonstrate the value of research. We have a problem. Many actually, unfortunately, or some researchers got the PhD for the sake of being named doctor. Failure to support PhD holders upon their graduation. They come with their PhD degrees. Once they actually come back to their respective universities, no contribution, no interest, no funding, no support. So they switch gears and go to other actually career. Funding, lack of competitive research funding opportunities, which affects quality. So a word of mouth is very important, I know. Even in the United States and Canada and the United Kingdom. So I know I'll get another guy and then I will get the funding. That's okay. However, if there isn't a competitiveness or there isn't a competition to seek the funding, and there's a lack of transparency on how the grants were actually given, this actually creates, I would say, despair and frustration among researchers. So why should I actually spend time doing research? Resources, lack of time for research. You are a teacher, you're a PhD holder, you are a teacher, you are not a researcher. We actually sent you abroad to come back and teach our students. So don't waste our time and our resources asking for funding for your research. Scarcity of PhD programs. You can imagine King Saud University, which is the College of Pharmacy, which is the oldest college of pharmacy in the whole Gulf, and the Department of Clinical Pharmacy in particular, didn't have a PhD program until 2 months ago. We're going to actually accept students next year. However, we don't have a PhD program, which we were actually struggling with our colleagues in the same college to convince them that there is a specialty called pharmacoeconomics. There is a specialty called pharmacovigilance. No. Pharmacovigilance belongs to us, pharmaceutics. Pharmacoeconomics does not belong to you, belongs to the College of Health Administration. So we were struggling, but thankfully, we made it. All right, appropriate weak administrative support. Who cares? Lack of collaborative platform and communication tools. There isn't actually, if you are collaborating with someone else in the other university, you need to have an official platform to communicate with. Unfortunately, there is actually, especially with the emerging or the new universities, there's a weakness of collaborative platforms that can enable the researchers to collaborate with regional, local, or international researchers. Another interesting thing here when we talk about healthcare research. Dispersed and uncoordinated disease registry. When I came back 2015, I tried to reach different actually researchers in the School of Medicine, working in different hospitals, pharmacists, and I realized that there are actually multiple disease registries. But the problem is they are dispersed, unorganized, many actually missing observations, and there is a lack of collaboration between different registries. So what you find in one registry you didn't find, and sometimes there's a duplication, and the same patient is actually existing in the other actually registry. So we have a National Cancer Registry, which was established at King Faisal Specialist Hospital, and then was taken over by the Saudi Health Council. I don't know what happens to it right now. Tumor Registry, they changed the name, they removed national, so they can have their own disease registry. The cleft palate and craniofacial anomalies at King Faisal Specialist Hospital, congenital heart defects, and then heart failure assessment registry at King Saud University Medical City. I'm not sure if they're collaborating with each other. Gulf familial hypercholesterolemia registry, And this actually, I haven't taken a look at the quality of data in this registry, but it's promising that there is a collaboration between different Gulf states, National Epilepsy Registry at King Faisal Specialist Hospital, and then there's a collaboration with Riyadh Military Hospital, King Fahd Medical City, and National Guard. I have taken a look at this registry 3 years ago, and it still needs a lot of improvement. Neuromuscular diseases registry at King Faisal Specialist Hospital, and there's another one at the Ministry of Health. Transplantation registry at King Faisal Specialist Hospital, and they want to open a new one, another hospital. Diabetes registry at Riyadh Military Hospital, and another diabetes registry at King Saud University Medical City, and we have the Saudi National Diabetes Registry, which actually they don't have any collaboration between each other. Anyways, why researchers in this region avoid collaboration? This is a question that you need to ask yourself first. Fear that if they share the data, someone will publish the results ahead of them. You can imagine that some of the people, my acquaintances, all right, they have national data, they keep them in their desktop for about 6-7 years, and then when they gave up, they cannot publish their findings, they knock the door, my door, and they tell me, Yazid, do you have time to write? Well, I'm busy. Okay, but what kind of data? I have national data. I cleaned the data, I coded the data. However, I need to be the first author. So you will analyze the data, write the manuscript, and I will share correspondence with you. What do you think? Bad deal, I'm sorry. Okay? Lack of funding to initiate any collaboration. No money, no honey. Okay? Lack of time to share data or collaborate. By the way, lack of funding. I still remember one time when 2017, I reached out to one of the medical doctor and I told him I want to have access to your patients. And we're going to collaborate and, put our names in the same paper. He told me, do you have money? Do you have funding? I said, no, I'm sorry. Big shot, all right? Anyways. Lack of time to share data or collaborate. I don't have time. I'm practicing. I have the data. Okay. What's in it for me? Fear of financial loss or possible patent rights. He took my data. The allowance for excellence research is gone. I need it for me first. Fear of losing future funding. Well, do not collaborate with this person. This person does not have to have any rights to collect data from our hospital because he's a troublemaker like Yazid. Avoid him. Okay, all right. I'm going to bring, okay. Fear that others will use the result to question their findings. If I have the same data, I will question your findings. Perception of career risk. Well, I'm working in a good place. I don't want to lose my career, okay? Losing control on the research direction or potential outcomes. I will share the data, but I must be the first or senior author. You must cite my previous research papers and your findings should not contradict me. Otherwise, I'm not going to collaborate with you. I have heard all of this, all right? Jealousy between colleagues. Jealousy exist? I don't know. This is a very nice excerpt from Harvard Business Review. As you enter your recently promoted colleague's office, you notice a photograph of his beautiful family in their View vacation home. He casually adjusts his custom suit and mentions his upcoming board meeting and speech in Davos. On the other hand, you want to feel genuinely happy for him and celebrate his successes. On the other, you hope that he falls into a crevasse in the Alps. Really? Yeah, it happens. Okay, I hope he doesn't actually show up tomorrow. Well, okay, barriers to research collaboration, cultural tendency to not collaborate or share data. Are you the son of National Guard? Are you the son of King Faisal Specialist Hospital? This is our hospital. You came from King Saud University. Okay, just, hit the door. All right? طريق مستشفانا على تدله. All right? I've heard it. Collaborations require memorandum of understanding between different organizations. Well, we are very protective of our own data. We don't want to share. Unstructured or poor quality of data. A lot of issues. Local IRB offices limit access to and sharing data. Trust me, the IRB office sometimes they need to adhere to ethics or principles of ethics, in conducting research. Sometimes it's a gang of 6 or 8, and they determine which research to be accepted or not. And if you don't include our colleagues, we're sorry. Your research did not meet our actual standards. What standards are we? And by the way, it happened to many of my colleagues. Unfamiliarity of good research practices. Many actually clinicians are unfamiliar with, with what research is all about. No mechanism in place to share data. They don't have any actual platform to share data. Competition in research and concern over sharing credit. Who's going to take the credit? The views among some people in leadership position in some organization that the data are their own. This is my own data. Lack of resources to participate or collaborate in research activities. They don't have the software. They don't want to share the software to analyze the data. They don't have the staff to facilitate the research collaboration. How about the benefits? I'm going to wrap up in 2 minutes, Dr. Thamer. Data validation. If we collaborate, we can validate our findings. If we collaborate, we can exchange knowledge and skills. If we collaborate, our research will be more impactful, and the outcome will be more actually valid. It benefits to our society, and benefits also a better contribution to the overall scientific community. So what is the take-home message for that? First, the policies that promote solo authorship must be abolished. This is very important. For me, when I publish as a solo author, I get the full reward. If I publish with multiple authors, they will split it between or divide them between the other authors. So what is the interest for me to share or collaborate? All right. Penalizing researchers who collaborate with researchers from other local, regional, academic, or health institutions by denying them full funding must be ended. And this happens. This is a practice. All right. Third, a culture of sharing and collaboration should be encouraged. We are in the same country. The organizations belong to the public. The government has spent billions of dollars to provide care to our patients. There is a National Guard, King Saud University, and King Faisal Specialist Hospital. There is Kingdom of Saudi Arabia. Fourth, financial and non-financial rewards should be given to those who reach out to other local, regional researchers. We should reward them, not only financially. I mean, you need to raise my morale so I keep running and promote me so I can actually contribute more. Last but not least, healthcare data, disease registry, EMR, surveys, claims data from different public institutions should be accessible to researchers with reasonable conditions. Reasonable condition meaning adhering to ethical principles, not adhering to my own policy. With that, I thank you so much, and I hope you learned something new from this presentation. Thank you.
Thank you, Dr. Yazid. It's very nice summarizing to the obstacles and challenges that we are having in the research. And a lot of questions actually came in my mind, and I'm sure we have also a lot of questions from the audiences as well. So now our next speaker is also well known in the research, Dr. Maha Al-Ammari. She's a clinical pharmacist and a researcher at the King Abdulaziz Medical City, Riyadh National Guard, Ministry of National Guard. She had got her bachelor's degree in pharmaceutical science from King Saud University. And also she got her master's degree she has actually 2 master's degrees in clinical pharmacy from King Saud University, and also in epidemiology and biostatistics from King Saud bin Abdulaziz University for Health of Sciences. She's also the chairperson for pharmacy research unit at the King Abdulaziz Medical City. Dr. Maha, she's going to talk about calling for multi-center studies in Saudi Arabia. Please welcome Dr. Maha Al-Ammari.
بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله. It's my pleasure to be with you today in this very nice gathering with Dr. Yazid أتعب من بعده. ما شاء الله تبارك الله عليه, he's كفى ووفى ولا ما شاء الله تبارك الله. So I'll take 2 minutes then I will leave that, right? يعطيك العافية دكتور يزيد. Well, Dr. Yazid gave an insight and full picture on the collaborative research. Dr. Yazid, Allah يعطيه العافية, he gave a lecture and full insight on the collaborative research in Saudi Arabia and the challenges and barriers. And it seems that he's really frustrated. Yeah? It seems that he's really having a passion for a change. He's looking for some efforts, something to be done in this country in order to promote this type of research and research in general. Well, my talk today will talk about the multi-center studies, and I've been asked to shed the light on my experience while conducting these studies in Saudi Arabia. So the only objective from this talk is to explore the challenges while conducting these multi-center, and it's a challenge from my perspective, to be honest with you. So it's a real experience. A very smooth entry to my talk by giving a small introduction that multi-center is known since 1940s when they study the role of penicillin, some penicillin derivative in common cold, and the studies were published in Lancet at this time. And we know that any observation study is done to establish a baseline to address the research question in one center in order to conduct a clinical trial on a multi-center later on. So multi-center studies is considered a platform to generalize the results, to have more powerful results. And there is definitely many differences between one study done in National Guard or King Saud University or King Faisal University. There's definitely a difference by doing these single studies and by doing it collaboratively or together by conducting multi-center studies. The sample size will be larger, the generalizability will be better, yeah? The protocol definitely will be more detailed and complicated, and this is what it will take to conduct the studies. We have less bias, we have more stronger statistical analysis, and we have very good heterogeneous characteristic for the studies, but the cost will be higher, and that's why we need the fund. And it doesn't matter it's a prospective or retrospective multi-center studies. I feel very frustrated when I'm applying for any multi-center study and it's a retrospective, but it's a multi-center cohort. They says, well, it's retrospective, we will not fund. If it's a clinical trial, then we will fund. So again, this will require a lot of effort. The key element for any multi-center collaboration is to spend time and prepare your team. So you need to devote time, whether you are busy, you are a professor, you are a pharmacist, you are a leader, you are administrator. Spend time in planning, preparation, and organization. You need to create your motivated, cooperative, and competent research team. And you need to go through different phases while you are preparing your protocol and your study. It's pre-planning, planning, and execution phases. When it comes to pre-planning phases, please spend the time in developing your research question. Do brainstorming. Check the literature. Go thorough in the literature and see what's existing. What do your country need exactly? Personally, I don't support any research question says, well, this had been done in the United States, then we'll see what it will be in Saudi population. So we are replicating the studies instead of looking for a real research question. Conduct a pilot study in order to check internally and externally for the feasibility of your protocol. Pilot study, it's usually done, internal pilot study is usually done in order to check for the sample size calculation, is it appropriate or not, to check if I need to recalculate it, to assess any problem in the recruitment process, and eventually I will adjust the protocol based on that. External pilot study is a feasibility study, and this is basically to see if the study can be executed in this design or not, or we have a problem in the methodology. All of these pilot studies will help us to polish our protocol. The planning phase, it requires extensive resources and coordination among multiple sites, multiple centers, and collaborators. Fund allocation and budget distribution is very important in the planning phase. And I think the key leaders in the organizations are very important to be involved in this step. Then the protocol development, which is a critical step that required problem-oriented face-to-face meeting. And people need to be committed in this state. Experts in the field and statisticians are very important and crucial members in any multi-study collaboration type of research. Then the execution phase, of course, the grants had been approved, rules are clear, systems are working, then the study will be launched. So this is basically how the آلية العمل in multi-center collaboration or multi-center studies. Now, what does the organization or the organization of the multi-center studies? Now, it's a steering committee, includes the primary investigator or the principal investigator and the clinical experts, and they are overall design and study conduction. We have a drug safety and management, and those people are clinical expert project managers and research coordinators. We have the research center, who include the primary investigator, project manager, research coordinators, biostatistician. We have the writing committee at the end to wrap up everything and start drafting the manuscript. And we have, of course, the clinical sites. Now, every site have a rule. The primary site or the original site, the principal investigator in this site, let's say it's King Faisal Specialist Hospital, are the originating site. So this site will oversight all the study aspects. They are responsible for everything. For the National Guard, for military hospital, for security forces hospital. So every site the study is conducted, they are responsible about it. The project manager is the person who oversees the daily activities of the study. So he or she on a daily basis, they will touch on these things. Then we have the research coordinators with the daily activities, consent forms and stuff, data managers, and we have the biostatistician. Now, those people in the clinical sites, who are they? They are the site principal investigators. They have overall responsibility of the site, patients enrollment and recruitment, follow-up, and coordinate with the major site itself. Site co-investigator, patient enrollment and follow-up, and the research coordinator at that site for the daily activity, consent, processing, coordination, the data collection, cleaning, and coordinate with the original site as well. Now let me go through this painful process. Sorry to say that. Have you seen the dates? 2012. And it ended in 2020. So how many years? 8 years, right? So my story started when I submitted this research proposal at KMARG, at National Guard, as part from my master graduation project for the biostatistic. And it grant approval actually in 2012. Yeah? But it had been submitted before that. In 2014, before that, we start to collaborate with our colleagues in Jeddah. And it took us 2 years to grant the approval from Jeddah. Okay? And to formulate a team there. 4 years it took us to formulate another team at King Khalid University Hospital. So now we have Jeddah and KKUH with us as a multi-center study. Believe it or not, this process is really painful. Every single institution, even our sister in Jeddah, they have different policy. They have different system. They have different perspective. They have different workflow. They have different views for the research. Our colleagues in KKUH, they have different policy in their IRP. People are enthusiastic, but the policy does not support them. In 2020, we get the first publication from this research. And it's actually, the research title is Estimating Warfarin Dose for Saudi Population Utilizing Clinical and Genetic Data. And this is our first paper from it. Another 2 publications is coming in the pipe. So I learned from this 8 years that I need to plan things ahead of time. I should not wait till problem happened, then I think about involving other sides. So I thought I should keep this in my mind. I learned that I have to be vigilant in selecting my teams. مش معناه أني أعرف يزيد ويزيد يعرفني معناته he's a good researcher and we will be matching together in this research. No. Define the rules. I really learned how to define the rules. If I know Dr. Thamer, and Dr. Thamer, he's a good researcher, so I have to state clearly, you will do this and I will do that. This is our deadline, this is when we should meet. We need to define the rules for every person in the team. I learned how to communicate efficiently with people on a professional level, not on personal level. إني أرفع سماعة على فلانة وفلانة لو سمحت الله يسعدك الله يرضيك الله يخليك. No. In this business, be professional. كثير أسماء راح تطيح من حواليكم بس that's fine. Documentation. Every single step you go through any multi-center study, you have to document it. Email, memo, you need to have an official documentation. I learned how to follow up on things, big things and small things. I learned how to follow up on people, big names and small names. علمتني كيف أكون متواجدة في كل لحظة أثناء تجهيز الريسيرش. والأهم تعلمت الصبر. تعلمت الصبر بطريقة جميلة. So الريسيرش يحتاج نفس. This is my second story after the first one when I learned some lessons. So in 2017, I granted an approval on a study for validating, not validation, this is another study. Here, I did a brainstorming with my colleague Fakhr Al-Ayubi at KKUH. I told her, Fakhr, all the existing bleeding risk assessment tools for DUAC is not really helpful for us. And most of the clinicians are using has bled to assess for bleeding, for DUAC, while one of the elements for has bled is INR. So how we could do this with DUAC? So we came with the idea that we need to develop bleeding risk assessment for DUAC that suits our population. So this proposal had been approved in 2017. Less than 1 year, we granted an approval for the next center. In 2021, we got our publication. Again, I learned some lessons from here. Teamwork worked. Initially, I don't have a team. I start to formulate team while I'm going on. But in this proposal, in this project, the second one, I formulated my team and I depended on them. So teamwork worked, really worked. Brainstorming, brainstorming, brainstorming. Talk to brains, talk to people, listen to them, and accept their challenge. I learned how to delegate tasks. And when I start delegating tasks, my shoulders relaxed. Okay? I learned how I trust people from this step. Again, and again, I need to define rules. Follow up, and again, be patient. كل تجربة أمر فيها تعلمني الصبر أكثر وأكثر ولكن بطريقة مختلفة. So these are my experiences in conducting multi-center studies. So what are the challenges from my perspective? Some of the points here might second Dr. Yazid's opinion, and I truly agreed 100% with all what he mentioned from barriers point of view. So system, complexity of IR approval process at the institution. This will prevent or delay the approval process for your study. Different HIS system in the hospital. Systems are still using papers. Other systems are still using computers. Okay? Other hospitals, they don't have integrated system. Some of the data could be derived from the system and some from the papers. So this will prevent researcher from collaborating with you and says, well, it's an easy process, I can go with you in the research. National regulations. We have regulation for the clinical trials, but we don't have regulations for multi-center studies. Lack of local CROs, right? We don't have this luxury of having CRO, you give them the protocol and they will arrange everything for you. Lack of research coordinators, biostatistician. Let's admit that we have a problem with the biostatisticians. We are still depending on non-Saudi biostatisticians to run our statistics, right? And you are paying money for them. Project managers as well. Networking. I think we are poor in networking, and I will start with myself. I know Dr. Yazid since 1 year, 2 years, Sashur? Huh? He said 14 years. That we need to talk later. Okay. This is the first time I met him after he came from his scholarship. I know Thamer. This is another barrier. يلا تفضلوا. I know Thamer since 25 years maybe, yeah? Yeah? And I still know him, alhamdulillah. Again, if you know somebody, you will attach to this relationship. You don't want to look to the next one. We need to go outside our box. We need to know each other better. We need to know people outside the country better. We need to collaborate really with them. We have challenge in the research. Sample size is the challenge. لو جيتوا أبغى أطلب أسوي research sample sizes 2,000 subjects من وين أجيبهم؟ من وين أجيبهم بالكرايتيريا اللي عندي؟ Recruitment process is very tough. Lack of written agreement between the investigators. And I think Dr. Yazid touched on this. Now, if me, Yazid, Thamer, Abdullah, Ali, Huda, Maha, they want to do a research. مين اللي يحفظ لي حقي في هذا الريسيرش؟ مين يقول يندفع لي 10,000 ريال مش 5؟ مين يقول إني أنا primary author, secondary author ولا ما أنحط في البيبر؟ Where is this agreement? IRB does not replace this. IRB cannot do it. لأنه IRB is only for ethical approval of your research idea. But it does not replace any agreement between the researcher inside the team. We have a problem in data management and database. And definitely we have a problem in budget and money and funds. Definitely. And اسمحوا لي, I will end this talk by this question. When we should have our national pharmacy research platform? Is it a time? Do you think we are ready? Do we have a leader to take a lead ويعلق الجرس ويقول we'll do it? Do we have a good sponsorship for this? Who are the people interested in this? And اسمحوا لي إني أقول إنه this one aligned with Vision 2030 in the kingdom as well. Because in the vision, research has a big domain in that vision. I will end my presentation by special thank for my mother, hospital, National Guard, King Abdullah International Research Center, King Saud bin Abdul Aziz, and definitely Ministry of Health and IHOP team. Thank you very much.
Would like to call Dr. Yazid for our panel discussion.
They were very nice presentation. As I mentioned before, Dr. Maha and Dr. Yazid, they were known speakers and from the leaders in the area, in the Middle East area as researchers. And they were talking about a really a big challenge that we are having. And I thank them to be like too transparent to talk about this issue that we are having. I have a lot of points to discuss, but before, please, if you have a question, raise your hand until they get the microphone to you. I'll ask my question to them.
So I have a question about the definition of collaboration. You mentioned the collaboration, Dr. Yazid, and also this is the same question for Dr. Maha as well. So when we say collaboration, what do we mean by collaboration? At what level? We have as a like department level, people who work in the same, like let's say people in the clinical pharmacy department or pharmaceutical department, or is it good to talk about the college level pharmacy? Is it good to talk about like health colleges? Or is it to talk about like colleges in different cities? And what do you think? Do we need this? Is this good? Is it bad? So I just want to learn from your experience in that. Dr. Yazid and Dr. Maha.
Well, thank you so much, Dr. Rathamer, for this interesting
وتكرر
question.
الميكروفون دكتور عشان يسمعونك شوي.
Yeah, this is actually, well, collaboration is a broad term. So when we say collaboration, it can be based on individual initiative from the person himself or herself, and they go and reach out to different people and start the collaboration in light of all the problems and the challenges that we're facing. Or it can be between different colleges, or it can be between different universities. It can be domestic, it can be regional, it can be international. So this is a very broad term, and every single part of this collaboration or level of this collaboration entails or involves different challenges and different benefits as well. So if you can narrow it down to what kind of collaboration, but I just want to touch on something that you mentioned. Do we need a college or a department or a university to initiate the collaboration, or it can be started from the bottom up, from the individual himself, and then he or she will take the torch and then come up with a bigger collaboration between different institutions. It's my humble opinion that collaboration should start from the individual themselves. This is happening here, happening in the United States. People apply for grants, people actually reach out to different universities. So I don't think the college or the university or the department or the institution should lead that. I think the individual themselves should lead it, and then the institution should actually address their needs and their aspirations.
Dr. Maha.
Well, I think I totally agree with Dr. Yazid. Collaboration has different levels, and every single level has its own barriers, its own challenges, and it requires certain support. If you will collaborate between departments, let's say Department of Oncology and Department of Pharmacy, this is smooth, easy. It had to have its own resources. When it comes to collaboration between hospitals, it's totally different stories. When it comes to collaboration between hospital and university, this is another story. So every single level has its own challenges and it requires its own resources. Can we standardize it? Can we say, well, this is the checklist or the ABCs for collaboration between universities and hospitals? I think we cannot, because every research is a story by itself. Every research carries its challenges by itself. But at least we can draw the main lines for collaboration. We can decide on the, let me say it, الشكل الموحد للcollaboration. Then when things come into variation, small variation, we can deal with it immediately.
Thank you, Dr. Maha. So any question? So Dr. Maha, I'll get back to you. I know that you started research by yourself, and you were like from the few people at starting the research at your institution. And actually you did a great job to increase the environment of research in your institution. My question, it's really got my attention, like you need like almost 6 years to get IRB approvals from different institutions. Myself, if I talk more than a month, not getting any answer from IRB, I go, okay, cancel this research, go to the next. So you're taking 6 years to wait. What were the problems? And please, if both of you were too transparent, can you be transparent?
It took me around 6 years, simply because I need patients. My sample size is 1,000 plus, and I need patients to do this. And to be very transparent with you, and This goes back to one of Dr. Yazid's slides about the registers. My project was related to genetics. So if we have genetic registry, this project will take 3 months without going to any other institution, without doing collaboration. But because we need to draw blood samples, we need to do the genetic testing for the patient, that's why it took that much. Now, when such a protocol goes to an institution, this required extensive IRB approval and review because it's purely ethical things. When you took blood from the patient and analyze it genetically, this is the highest rank in IRB review. So, yes, it took 6 years, and I want to do it. I really want to do it. And after this project, now at KMARC, the database that I initiated is utilized for many other genetic diseases and genetic researches. So I built the infrastructure for genetic database at Saudi Arabia, initiated from KMARC.
Excellent. Thank you. Dr. Mohammed, تفضل.
Thank you, Doctor. Dr. Yazid, thank you for this great presentation. I have a question. In majority of cases, once we approach our pharmacists in the hospital, why you are not doing researches? The first answer, I don't have time to do the research. Second thing, he will tell you a very strange answer as well. The strange answer is, this is an academic people responsibility, not my responsibility as a hospital pharmacist. How do you answer this strange answer?
Thank you so much, Dr. Mohammed, for this great question, actually. I think part of the problem is their unawareness of the incentives that they will receive if they engage in research projects. For example, even pharmacists, I taught some pharmacy students, and they graduated and joined residency programs, and they finished the residency program, and they finished the R3 or the BGY2, and they became pharmacy consultants, and they were unaware that there are incentives for them they can apply for and receive. This is in part because of the, I would say, unintentional. Let's actually give the pharmacy departments the benefit of the doubt. Unintentional, I would say, ignorance or unwilling to educate the staff about the incentives of conducting research. For example, there are financial incentives for any employed or employee in a pharmacy department working at the Ministry of Health or National Guard or King Saud University Medical City or any other actually, or MODA, Ministry of Defense Health Affairs. If they publish, they will get an incremental, I don't know how much money they will get, but this is something that I will respond usually and say, you will wait a year or two, but the money will come. So this is actually something to convince them to participate with me. The second thing, and luckily, alhamdulillah, most of the people that I taught, a pharmacist in particular, they have self-motivation to conduct research because this is a way to save their rights. Especially clinical pharmacists, they go in rounds, they provide recommendations to physicians, but who's going to take the credit at the end? Mostly physicians. However, when they publish their collaboration, when they publish their contribution, when they have on the PubMed, they feel self-satisfaction. And this is something that I have witnessed in many of the pharmacists I have worked with. So this is my response would be to those who are reluctant to engage in research activities. But it's actually, I know, Dr. Mohammed, you are doing a great job at the Ministry of Health, and there are so many challenges there. But unfortunately, some hospitals, they're not do their, pharmacy departments in particular, they're not do their due diligence in educating their staff about the importance of research. But alhamdulillah, we have you at the Ministry of Health, and we're looking forward, inshallah, to change the culture.
Thank you, Doctor. I have another
Yes,
question.
go ahead. Because I'm going to follow up this question with Dr. Ahmed. Go ahead.
You mentioned the National Pharmacy Research Center.
Platform.
Platform?
Yes.
Great. That suggestion, once we took it to the higher management, they said that it's a scientific research. And there is no such a specialized research, especially for pharmacists. If you are talking about the disease, if you want to create a group You should have a pharmacist, you should have a physician, you should have a lab, you should have from many specialties. However, as a pharmacist, if you want to create your own research, this is not recommended. This is what we received as a feedback from them. Give me an answer. Why?
You mean give me a justification? Justification.
Justification,
for this
yes.
platform.
Yes.
Well,
Or
I'm
just only
proposing-
have pharmacy platform.
تمام. I'm proposing this platform for us as a researcher to get used to each other, to know each other, number one, on this level. If I know that I have XY in Ministry of Health, and I have XY in King Faisal Jeddah, and I have XY in Al Medina, and so on and so forth, does this promote the research in Saudi Arabia? If I know that research and doing research in this country is the future, especially that couple of months ago, National Guard, under the auspice of His Royal Highness Mohammed bin Salman, they signed contracts with the lead companies in the world to open their offices here. Come do your clinical trials here. And most of the companies here, they know this. So do we need to initiate our own researches with these pharmacy companies and clinical trials? So if I don't know any of those researchers, how we could do it? Who will manage these researches? There is no more clinical trials will come from outside and they will apply it on us. We need to initiate the protocols and we need to work on it here. So we need to prepare ourselves. Our new generation, students and interns, they need to know the skills. They need to know the ethics about the research. They need to have a platform for their brilliant idea for research and innovation. How many of your students, Dr. Yazid, came you with a very innovative idea for research? And any one of you. And you cannot help them because you don't know anyone. I have a couple of them. We don't know who can help us to execute these researches. If I have a platform with all key researchers in the kingdom, if you need help in research question, go to this link. If you need help in analysis, this is the team for analysis. If you need help in manuscript, this is the team for manuscript writing. So if we have this community, if you have this research environment, this will promote the research process in the kingdom. And again, I'm repeating this in every single meeting, we need to be aligned with the vision of 2030. If the pharmacist needed to be involved in patient care for diabetes, for example, because diabetes is burden in Saudi Arabia, and part of your participation is not only education. I'm sorry, education now is available to everyone. Part of your participation is doing research. I'm sorry, I'm biased to research because I'm a researcher. As part of this is doing research. It's enough that we talk the information from other population and copy it on our patients. We need to do our own. So, والحديث يطول. في justification أقوى وأعمق behind this. But I can share it with you later.
Yes, to like have more time. I'll
just have a quick comment to actually Dr. Muhammad's question. A little bit of disagreement with Dr. Maha with regard to the National Pharmacy Platform, because it would be very hard to justify it to the people at the different organizations. I'm in favor of having an interprofessional, collaborative platform where actually we show our value as pharmacists to other professions and we break the ice and the barriers. And trust me, Dr. Maha, I collaborated, most of my research actually right now is collaboration with both pharmacists and physicians. And the value of pharmacists has improved a lot when they see actually pharmacy resident and master students and faculty members participating with other physicians. We think, differently, but we come together and work together, and we broke multiple barriers by working together. And they have something we don't have, we have something they don't have. So when we come together, and we have interprofessional collaborative research platform, that will be more win-wins for us and for the other actually health professions. So I guess we need to tweak the title, a National Interprofessional Collaborative Research Platform.
I want to go back, just for the sake of time, I'm going to go back to Dr. Maha. Of the comment mentioned by Dr. Muhammad, which is with the pharmacists in the floor that they're not really interested in research. Don't you think it's not because the pharmacists, don't you think the education system at university that we have is really the main, like one of the major reasons that students from the school years are not involved in the research?
No, I totally agree. We don't have any research subject in the curriculum, right?
Yeah.
Disagree.
In King Saud في عندكم?
I disagree.
عندكم?
Yeah,
King
we
Saud?
have a pharmacoepidemiology
I'm
course.
talking about the curriculum and teaching them
Yes.
what is the research
Yes.
methodology.
Yes.
وإلى
What
آخره.
is the hypothesis? How to come up with a research question? What's your hypothesis? How can
Maybe
you
it's
actually?
only in King Saud University.
I don't know, but
Yeah,
at King
this
Saud
is what
University
I'm
we do
saying.
have. We
And
do
I
have
think
an
this is what
interesting-
Dr. Samer is pointing
Yeah,
to.
but
that
just
we
before I
don't
mention,
have it on our.
having a subject doesn't mean, Dr. Yazid. Yeah.
صح.
Oh, wait.
Having a subject and having training for a year and a half, I think it's be.
No,
Yeah.
I'm not talking about a specific college or university.
Yes,
I'm talking about in general.
Generally, yeah, we do like
Having a subject sometime, not necessarily that is really.
I think there's a problem with the interest. I have, a straight A student. I still remember her GPA is about 4.99 out of 5. And actually, she was one of the master applicants, and I believe 90% and more than 60% of the applicants failed. And when it came to research, she told me, Dr. Yazid, I am not interested in research. I don't like research. And till now, she's a pharmacist working in one of the hospitals, and she's not interested in research. So interest.
It's
Interest is
multi-factor,
great.
Dr. Just go back to Dr. Mahakam. Continue. Sorry, we interrupted you about So, you believe that the education has a major role in shaping the students later on pharmacists?
Motivation as well. And believe it or not, most of the junior pharmacists, they want to be attached with certain name to learn some skills, not only research. They want to attach to Maha to learn how she's managing small things. So some of the junior pharmacists, their target is not only the research, but they want to learn some skills. They want to attach their names with you for you to teach them something. So education, lack of motivation on departmental level, operational work kills everything. Come, do counseling, dispense 1,000 prescription, process 200 order per satellite in the inpatient, finish your duty, go home. Shall I get some day off for research? No, you are entitled for 4 or 5 days per month. That's it. Then pharmacists, they need to take their vacations in order to work on research, which is unfair for them. So it's on departmental level, if they were giving incentives. And again, I'm saying not every pharmacy will like to work research, as Dr. Yazid said, but those who are interested, ليش ما يعطوا التميز؟ ليش ما يعطوا الفرصة أنهم يتميزوا بهذا الشكل؟ ليش ما يكون عندهم support من الادمنستريشن؟ Plus لا ننسى أنهم they are entitled لبدل تميز. They can submit for بدل تميز when the paper is published.
This is the thing, Doctora, that I want to reach. بدل التميز, one of the disadvantages, بدل التميز, خلاص, a lot of pharmacists, they are going to publish in predatory journals. And they are guided by certain people that they are taking money from them in order to publish their researches. And they are very happy. They do not know the direction to do this. So this is one of the disadvantages of just again,
This is awareness.
Dr. Yazid, you mentioned one point. I think it's a really dangerous point that we know the PhD holder are the most people doing research in addition to other specialty PharmD and other. But you mentioned that there is no support for PhDs to conduct research. So I want to hear from you and also from Dr. Maha as well. So that's me. Let me ask a question, again, transparent. From your active researcher, how much you get fund as percentage to your research?
Well, let me be honest and clear with you. When I first came back from the United States, I was faced with multiple challenges, not only me, all of my colleagues. But I was lucky that I chose the path of dry lab. Because dry lab only involves the software and you need to seek and reach, and collect data from different hospitals or the registry if you're lucky to have access to one of them. But for my colleagues who specialize in a wet lab, like in pharmacology, medicinal chemistry, pharmaceutics, they struggled much more than I have. Many of them have switched gear and they pursued an MBA and they want to work as an administrator. They are fighting for department positions, looking for or exploring other options outside of the university because there is no funding. I spent about 3 years. I came back 2015. I spent about 3 years until I was lucky to meet someone who knows someone who knows someone. So we collaborated and we secured some funding so we can keep running and going and conduct our research. But I still remember I knocked the door of some philanthropist. Seriously, wallah al-azim. I knocked the door of some philanthropist. And one of them opened his cabin and gave me 23,000 riyal. Here you go, Yazid. Go ahead and conduct your research. So I reached that level. Alhamdulillah, I'm very thankful. I really thank him, that person who funded my research at the beginning. And so if you have a willingness, if you have the motivation, no one can stop you.
Sure.
Don't listen to anyone who wants to demoralize you. That you cannot, always. I still remember a Jewish guy at my university back in the United States. He said, Yazid, always think globally and act locally. Think globally. Don't think that if they buried you here in Saudi Arabia or the Ministry of Health or the National Guard, they don't like you, they succeed. No. Improve yourself. Improve your skills. The sky is the limit, as His Royal Highness Prince Mohammed bin Salman said, the sky is the limit, and keep running and going and you will reach and you will succeed, and they will look at you and they will say, well, we tried to kill him one day, but he's a good fighter, so keep fighting.
دكتور مها وانا
أنا وضعي أفضل بكثير من يزيد.
Okay.
When it comes to grants, when it comes to fund.
Because you are the National Guard.
My first grant was 2.5 million.
MashaAllah.
Yeah.
So you're different. You're different than poor people
it's
here.
It's different. I'm from the other end, but believe me, it's a responsibility.
Yes, it is, of course.
You are accounted for every single riyal. You are questioned for every single riyal spent. Where you spend it, why, to whom, give us a justification. So 2.5 million is not an easy, it looks wow, fancy, صح, in a grant project, but it's a responsibility. And we utilize it. We utilize the 2.5 million. The second project was 170,000, and again, it's a lengthy process. And not only funding the project when you submit the proposal, and National Guard at Kmark level, the authors, both the primary and the co-authors, they are getting incentives after publishing their papers without asking for that.
I think our problem, at least our area, myself, Dr. Yazid, which is health outcomes, that when we go for King Abdulaziz Medical City for Science and Technology, Medical for Science and Technology, and ask them to fund, and we've spent months to write a very long proposal, and they say, you're not a wet lab, so sorry, we're not funding you. So this is like one of the like challenges for the health outcomes. I disagree with Dr. Yazid when he said like before that the people with lab they don't really get a lot of funds. Actually, they do, especially from King Abdulaziz for Science and Technology. But I'm maybe different to Dr. Mahmoud.
If you allow me to, when I mentioned wet lab, for very, very few people, not all of them, Dr. Amir. And when we talk about King Abdulaziz, City for Science and Technology, I still remember someone told me write a proposal. I spent about 2 months writing the proposal. I submitted the proposal, and after a year, they sent me an email back saying the proposal was not filled in the specified form.
Okay.
I submitted another one to Kmark, King Abdullah City Medical Research City, and National Guard, and we assembled the team with clinical pharmacists and physicians. And the proposal stayed at the desk at the IRB office, and we for 6 months, and was reviewed by one of our colleagues, pharmacist. And you know what? We withdrew that proposal and we submitted it to King Hussein Medical City in Jordan, and we got the approval in 2 weeks, and we conducted the research. So do not stop. There's the United States, Jordan, United Arab Emirates. We are in a global village. National Guard and King Faisal. By the way, I would like to thank King Faisal because they were one of the first people who broke one of the barriers for me when King Saud University, refused to sign a memorandum of understanding with them. So we had a detour and we collaborated and we conducted one of the.
Always there is detour.
So I would thank him, personally. Dr. Abdul Ismari, the head of neurology at King Faisal Specialist Hospital for helping me at the beginning. So this is only a story, but don't stop. Always, try to explore other avenues.
Okay, last point, I'll go back to the proposal by Dr. Maha. I think it's really, really important. We are looking for like an umbrella to have a research, to talk to each other, to learn from each other. I know many researchers. I work with many researchers, as also my colleagues here. But we believe we need this. And my suggestion, I know Dr. Muhammad is really active to helping the pharmacy science in Saudi Arabia, as what he did and is still doing in the Ministry of Health. And I think this will, as one of the output of this amazing conference, is to take this recommendation and suggestion, try to have like a meeting with Dr. Muhammad and discuss how we do this, what possibility of this, and we can't have like funding this, because we all know that I'm not talking about the government because they already know their responsibility, but also the pharmaceutical company, they have responsibility to fund research. They already did with our colleague physician, but I don't see a lot of pharmacists have. So I think it's a really good idea to talk about it, to try to make it bigger, and hopefully we'll see it for, I don't know if we're gonna catch it ourselves, or at least we'll do this for our next generation. At the end, I really don't want to stop. I don't want to take more time from the audience. It's getting late here. It's really enjoyable, as I expect, session. I would like to thank Dr. Yazir for your really nice presentation and your input, and also Dr. Maha for what he shared with us today. And I would like to thank the audiences today for listening to us. Thank you so much.
يعطيكم العافية.
بالعافية.
Thanks, Doctor, for your valuable discussion. We really enjoyed it. And now I'd like to invite Dr. Mohammed Shinawi to thank our speakers. Dr. Yazid Al-Rathea. دكتور مها العماري. دكتور ثامر الشمري. Dear audience, there is one more left gift to be given today. But before that, we want to see together our promo video. And now, let's know together who's our third winner for today. Dear audience, thank you for being here today, and please stay tuned for tomorrow. There will be more and more gifts. See you tomorrow.